Hello. Yes, welcome again to the 8th edition of Health Tech, being presented to you by the Bengal Chamber with PwC as the knowledge partner. So in the opening session, we have with us Mr. Arnab Basu, President of the Bengal Chamber, and Advisory Leader PwC, Mr. Rajiv Savarwal, Partner PwC, Mr. Obhijit Banerjee, Senior Vice President, the Bengal Chamber, and Managing Director, India Limited, Mr. Deboshi Dattagupta, Co-Chairperson, Biotech and Pharma Committee, the Bengal Chamber, and Managing Director, East India Pharmaceutical Works Limited, Mr. Obhijit Majumdar, Chairperson, Health National Committee, the Bengal Chamber, and Chief Executive Officer, Apollo Multispecialty Hospitals. I would request the dignitaries to please take their seats on the dais. So, theme of this year is quality measures and standards for transitioning to value-based healthcare in India. So we'll talk more about it, and the chief guest or the keynote address would be delivered on AI in primary healthcare by Dr. Vinod Paul, member Niti Aayog, but to suit his convenience of calendar, he will be addressing at 12 as part of the next session. So with this, I would request President Mr. Arnab Basu to please deliver the formal welcome address.
Good morning. Good morning, ladies and gentlemen. It's an absolute privilege and pleasure to be here with all of you. This is the 8th edition of our Health Tech program, and BCCI has been doing this program, bringing the best of healthcare and technology together for the last 8 years, and it's been my privilege to have been party to this for all the 8 years. And if you think of this program, why, as the Bengal Chamber, we sort of embarked on this program, this was conceived and started much before the pandemic, right? And we all felt that if you are looking at India of tomorrow, if you're looking at an inclusive growth for India, then bringing healthcare solutions to the average Indian can only be achieved by bringing healthcare and technology together. And that was the theme on which we started this program, to say that how do we make healthcare affordable, how do we make healthcare available, and how do we bring the best of technology into healthcare. And that's been the guiding North Star for this program over the many years. As the program has passed through different levels of advancements in the field of healthcare and of course different technologies, our focus is now on a far more qualitative approach. This year's theme is focusing on the quality and the standards in our efforts to provide healthcare access to all across. Whether you look at social development, whether you look at economic development, and whether you look at development in this geographical part of the country, all of these are very much dependent on the quality of healthcare which you are providing. So while we have brought in themes around artificial intelligence, around drug discovery, around research and development, around different kinds of robotics in surgery in the earlier years, this year the focus is purely on how do we improve the quality of the healthcare which is being provided. And with advancements in technology, many of that is now far more achievable, and it is also far more efficient. Healthcare providers are now prioritizing far more on digital and AI transformations to meet some of the consumer demands. Some of the workforce challenges which they have, which is very significant part of how you drive quality, is also being driven by technology advancements. Whether it's in terms of reduction of costs, EBITDA improvements, how do we enhance the overall quality of care, And with the government of India emphasizing more to build a digital health ecosystem to foster healthcare in the country, I think digital and AI transformation becomes very central to that. And all of that is also in line with the SDG Goal 3 of the United Nations. And I think when we think of this topic, gone are the days when this can be thought of purely from the perspective of the provider perspective. Right now, the consumer perspective is far more important. The consumers have choices. We are also seeing, at least in this part of the country, that certain pockets of consumers are not coming into the healthcare ecosystem of this country right now because of geopolitical instability. And I think when you look at all of that, it becomes very, very critical that how do we look at some of these points. And the national quality assurance standards have been developed in India, focusing on service provision around patient rights, around different support services, around what kind of inputs we are giving, clinical care, infection control, and many other points. And many of these are currently being tracked and monitored at an individual level across the country. And it is important that this aspect of quality is addressed from the primary level. And AI and, I would say primary healthcare has major significance, which will be deliberated in today's discussion. The concept of universal healthcare highlights primary healthcare as a foundation pillar of public health. And as many of you know, that primary healthcare has been an issue in the country for quite some time. If you look at India in general, there are quite a few health-related parameters, including expectancy at birth, infant mortality, maternal mortality rates, prevalence of diseases like cancer, diabetes, cardiovascular. I think many of these, India is not very great in the global charts. And when you see some of these and compare with where we would want to be, you would find that even things like, basic things like nutrition quality, quality of air, quality of water, education levels, all of these have a great influence on, some of these parameters. So what we need is probably a far more holistic approach, and that would be the purview of the deliberations today. Also, I think a few days back, the Honorable Union Health Minister has announced that India will now meet the target of eliminating tuberculosis, now about 5 years ahead of the global target. Now, how can we do some of these things if the quality of nutrition is not good enough? And so that tells you that when we look at healthcare, it's not just about providing healthcare in a hospital, it's not just about manufacturing drugs which take care of certain diseases, but a far more holistic approach which the country needs. And I'm sure that all of us in our deliberations today would cover many of those points. With this note, I think that our engagements and initiatives today will help many of the ecosystem players today to go back with new ideas, learn a few things about what's happening in other parts of the world, and of course, propel us towards the country's goal of achieving the SDG 3. So with that, ladies and gentlemen, welcome once again to this session. It is, as I said, a privilege to be sitting here and learning along with all of you. Thank you.
We would now request Mr. Rajiv Sabharwal, partner PwC, to please deliver the partner's address as this program is being presented with PwC as the knowledge partner.
Hey, Arnab, thank you very much. Yeah, I feel comfortable here, okay. So, morning, ladies and gentlemen, right? I was told to talk about BBC, value-based care, from India context, okay. Unfortunately, I don't know much of India context because I've been here only around a year and a half, okay. I'm a US partner who is on a secondment out here, so 30 years of my life I spent in the United States. But it's not that different, it is just a phase differential. What we are talking about is what happened in the United States 20 years ago, 25 years ago, and then another 5-7 years post that in the Western Europe kind of countries, right? it is coming to India. It is an axiom, it's a self-evident truth, it is imperative, it is not gonna change. So let me just start talking about a little bit about the evolution of healthcare in the Western world and how it is very applicable to the India of today. Okay, that's ultimately the goal that I will try to come to. Somebody had my PowerPoint? Of course, there's a technical glitch. I'm a technical partner. Okay, so let's go to the next one. Okay, so when I went to US, it was literally the wild, wild west. Okay, we were scared of going to the doctors because the doctor visit will cost you 400 bucks. When you were making $2,000, right? At that time, 400 bucks was a significant part of the thing, right? So that's why you go to the pharmacy, you go to CVS, you get an over-the-counter drug, and you be happy about that. That changed drastically in early 90s. The reason why it changed drastically was because the big networks came in. The Uniteds of this world, the Aetnas of this world. United will tell the doc, for every visit, I'm gonna give you 40 bucks. My patient is gonna give you, my member is gonna give you 10 bucks. Take it or leave it. But if you leave it, 5 million members of mine are going with me, okay? That was a significant change. The power shift took place, okay, from the providers to the payers. But over next 5-7 years, what happened was now the networks, the payers became omnipowerful, okay? And that was not good. They became omnipotent, right? So that was not good. So the regulatory bodies had to jump in. HIPAA was introduced to have collaboration between payers and providers, to set up networks. And HIPAA was able to do that because the public part of it is still, Medicare, Medicaid still covers around 40% of the US market, okay, US healthcare market. They're almost a $1.3 trillion budget for them. So that they had the biggest power out there, so they were able to push it. Every single change that has been brought up by governments in the history of human civilization has followed one approach, and that is called the carrot and stick approach. And India is no different, okay, and I'll get to that. Carrot and stick is you entice them with some kind of initiative upfront, and then once they have gotten used to it, the carrot has been taken, okay, the cheese has been taken by the rat, okay, then you bring the stick out, okay. That is exactly what is happening with ABDM. Abha ID, you get 20 bucks every time you record a transaction, you get used to it, you have your systems comparable. 5 years down the road, the government is going to say it is mandatory, you don't have ABHA ID, you don't use ABHA ID, we are not going to be covering the paneled patients, etc. Similar approach, okay? India is also on the track, and that is what happened in the US in mid-2000. Then around 2007-8, a phenomenon took place, okay? That was called real-world evidence. The big pharmaceutical companies started figuring out that how to reduce their cost of their clinical trials. For that, they said that instead of identifying or trying to find a single molecule out of the 50,000 molecules that I have and investing gazillions of dollars, okay, into the clinical trials, why don't I go and ask the providers that what are the outcomes that they are generating for a certain type of molecule or certain type of therapy, and then leverage that to baseline my research, okay? That real-world evidence, they kind of offered a lot of money. And then the providers woke up. They said, oh my God, it is not only about providing a service, but it is actually identifying the outcomes. And that was the critical shift where the entire spectrum shifted from fee for service to value-based care, fee driven by outcomes. Okay, so that has been the case in US, in Eastern Europe. Eastern Europe was the next follower, by the way. NHS through in UK, Canadian organizations, everywhere. If you will see the map on the slide next, or yeah, this map, you'll see that North America started, okay, and then it went to the Eastern European bloc, okay, Russia, etc. Australia bought in, Brazil came on board, and then UK, UK, France, etc., etc. Everybody started focusing on value-based care. And it is coming to India now. India is becoming very focused about that too. If you go back to the previous slide, what were the primary reasons? I already alluded to them, but you'll notice that pharma focus on real-world evidence was the sea change. Okay, that was the paradigm shift right there. Consumer becoming informed, right? The internet bloomed at that time, and the consumer said, hey, dude, if I go to this particular hospital for a hip replacement, it's going to cost me 8,000 bucks, and I am seeing 90% hospital-acquired infections or 20% readmittance rate. Whereas if I go to hospital B, is actually $8,000, okay, and it is a much lower HAI and much lower admittance rate out there. The Medicare also started doing star rating, what they call a star rating. So if your hospital is generating X type of outcomes versus another hospital which is generating Y type of outcomes, okay, and X being greater than Y, then the first hospital is getting better remittance for the same procedure, okay, because 0 to 5 rating, okay, depending upon your star rating, you get $200 versus $120 for the same procedure, okay. That became, now all that was contributing towards the provider's income. So they had to, they were brought pissing and moaning to the table, but ultimately they had to do it because it was impacting their income. That was the second thing. And then the third thing that happened was chronic care. People have been focused more on curative care through the kingdom come, okay? But chronic care costs were going through the rocket, going through the sky, all right? For example, a diabetic patient in US in early 2000 was costing approximately $4,300 a year to manage, a single diabetic patient. In 2024, despite the inflation, okay, that cost has been reduced to $1,900. And that was a focus on outcomes, focus on curative care, instead of curative care, trying to do preventative care. And preventative care was driven by the whole concept or whole focus on VBC. Because before that, the network will say, you go to the doctor, I'm gonna pay the doctor $40. Whatever the outcomes are, I don't care. Medicare said, nope, I'm not gonna pay you $40, I'm gonna pay you $32 if there is a readmittance within 3 months, okay? But I'll pay you $44 if there is no readmittance, okay, the star rating concept. So now the focus started shifting towards the outcome base. There are three types of, if you go back please. There are three types of model that were adopted, that were explored, and they are still prevalent. One was the whole concept of RIOs, Regional Health Information Organizations. That happened because you cannot do preventative care without having collaboration with other facilities or other doctor practices. An individual practice will be a pediatric or a cardiologist or what have you, but it will not cover the entire range of the problems that the patient may face. So what happened was there was a huge collaboration, exchange of data. Regional health information organizations were set up. That was the first step, 2004, 2006. Bronx Rio, Santa Barbara Rio, all the Rios came about, okay? And government gave a lot of benefits. Medicare gave a lot of benefits to people who were a part of the Rio and exchanging data. The second thing that happened was a Massachusetts model, where they said there is a lot of resistance for the providers to exchange data between each other. So what we're gonna do is, the local hospitals can maintain their own network, but then certain critical data, they will have to push to the state level network, okay? So that was the Massachusetts model that was used. And then Kaiser Permanente, people like that sprouted up, which are IDNs, integrated delivery networks, which is, they are payers as well as providers. So they have captive hospitals, they have members, plans pay for it, okay? And they provide all the possible service that you need, care service that you need to the patient within that fee, okay? That is the model that India is starting to adopt. You will notice that Apollo is going for insurance. A lot of other hospital systems, large hospital systems, they are trying to either collaborate with the 26 private insurance companies that we have, or they are gonna try to set up their own insurance plan, okay? That is the model that people are trying to go after in India. If you go further, continue please, go ahead. These were some of the benefits that were derived, okay? And I'm not gonna bore you to death out here, but you can clearly see the shift happened from curative to preventative care. That was one thing. And you can see, the one surprising thing that I wanted to highlight was the physician earning. Everybody was extremely scared that when the value-based care comes in, the physician earning is gonna go down. All the physicians, there was a lot of uproar, there were a lot of petitions filed in the high courts and Supreme Court and everything, okay? Surprisingly, even if you see inflation adjusted, the physician earning over the last 15 years has gone, 10 to 12 years, has gone up by 2.5 times. Okay, you adjust it for inflation, it's still 1.5 times more. Okay, the reason for that is lot of the capitation fee that they get, because of their proper care, because of the team collaboration and the data exchange, they don't actually have to see the patient. The patient is already being taken care of. If you're doing a foot and hand inspection every month for a diabetic patient, you don't have to worry about taking care of them in an ER situation. Okay, so they were able to denote or accommodate more patients through capitation rather than actually what they could do previously. Okay, that was a surprising end result. So that's the only thing I wanted to highlight on this one. Now, if we go further, so capitation. There were different models for value-based care that were which were tried. Okay, capitation won out. Capitation is a model wherein a physician group, a provider, gets a predefined set of money, okay, for every patient that they own the care for. Okay, so for example, United has a VBC model where they will give a primary care physician, okay, something like $40 per month per member, okay, that they will provide it out there. That is the model that ultimately won out. But capitation is not an easy thing to do. You can actually lose a lot of money if you pick up the wrong people to be a part of your capitation group, and if you do not negotiate the rate properly. So risk pooling became very, very critical, and that's where the AI and Gen AI kind of functionality came in very handy, because AI was able to tell them what is the risk score for an individual patient. So they were able to, providers were able to negotiate the proper rate to take care of either very sick people, less sick people, or average sick people. Okay, so there were different rates. So attribution and risk pooling is a very critical part. Then care team formation. I'm a diabetic. I also have a renal issue. I need an endocrinologist. I need a dietitian. Those 7, 8 people who are going to form the part of the care team, that was very critical also. Because if you miss out on 1 or 2 of them, then in that case, patient is going to end up in the ER. So those were some of the things that were very critical when you decide upon the capitation model. And Indian firms or Indian hospital systems are starting to do that. That's why they are putting a lot of focus on AI. They're trying to figure out not only today what the patient is facing, but 5 years down the road what the patient is going to be facing, depending upon their socioeconomic conditions, et cetera, et cetera. So all these things are coming here. We are working with partners, we are working with clients who are asking us to do this. They're asking us to put something called digital twin. So wherein you create a digital image of the patient, you extrapolate it depending upon their habits, their eating habits, their socioeconomic condition, their current medications, their comorbid conditions, and you figure out 5 years down the road what percentage of this person is likelihood of having a cardiac arrest. Okay, that kind of thing, they're already being incorporated. If we go further, I just wanted to conclude this, that all this has happened in the Western world. It has come to India. We are in the nascent stage, but the three pieces that were the primary driving forces in the Western world to adopt VBC are here in India also. You have increasing collaboration going on with the leading health organizations across the world. Adani Group just announced the Mayo partnership. Okay, Leelavati has a tie-up with Mayo. A lot of people are having these tie-ups, and those organizations are asking for outcome focus rather than service focus from these organizations. So they are being forced to go towards outcome as if they were not already thinking on those lines. That was one part. Second thing is insurance incidence is increasing big time. Okay, in 2007, I still remember, I was doing a study out here, and I found out that the insurance incidence in India was around 4%. 96% of the business was cash business. Today, it is around 23%, and tier 1 cities, it is almost 80% because of the MNCs providing their employees health insurance, et cetera, et cetera. Okay, and the more insurance comes in, the more stringent they are going to be. They are going to be saying, hospital A, I'm not going to pay you $100, okay, for that procedure, because your outcomes are not good enough, because you're costing me a lot more because the patient is getting readmitted or coming to the ER. I will pay you only $80. So that kind of power is going to be driven by insurance company, and that is happening. And the third thing is regulatory compliance. We have NABH, we have all kind of standards coming in. I'm working with Kolkata Foundation right now on a couple of projects for diabetes standards, etc. ABDM is imposing standards. So all those standards are coming in, and standards are going to be focused on outcome. You put those three things together, India is ripe for VBC, okay? It's happening. Any questions or anything? No, then I have bored you enough. Thank you very much. Appreciate it. Yes. So the premium initially, till the time you have figured out the data patterns, okay, initially the premium is going to go up because everybody has the tendency of, how shall I say, covering their behind, all right? They all have the tendency. So insurance companies are going to say, dude, if I'm going to give this person cover all kind of situation, and I'm going to take care of all their entire care, I'm going to put a margin out there for my premiums, etc. But over a period of time, and that's what happened in US also. The premium initially increased, okay, then they kind of stagnated, and if you look at the inflation-adjusted premium now, it is actually going down, inflation-adjusted, mind you, okay? They still do increase in absolute dollars, okay, but the inflation-adjusted, they're going down. And the reason for that is, over 4 or 5 years, you're going to figure out the data patterns. You're going to figure out that if I do this hand and foot inspection for every diabetic patient on a monthly basis and force it through the VBC kind of a program, it is going to ultimately reduce my cost of care for a diabetic patient from $4,000 plus to $1,800. And that, tie that up with the ALR, MLR, medical liability ratio, administrative liability ratio, the rules of Obamacare, okay, and that by default is going to bring down the premiums. Yes. Yeah. I'm sorry?
For the for such a value-based healthcare system, because the agricultural products and the drug products both are monitored by them.
RWE, yeah, and FDA was the biggest source. After the Defense Department, FDA has the largest budget in the US government, all right? Very powerful. Okay, so they had all the data, but problem is twofold. One problem was that the government machineries don't differ from one country to another. They work the same way. They're bureaucratic. So they were sitting on that data. They will use that data even for NCI, Cancer Institute. They have huge amounts of data. Okay, I worked on the program called CTEP in 90s, okay, late 90s, where we were doing clinical trial evaluations for every single clinical trial. We had a lot of data. We never shared it. Never shared it because we were not sure if I share it with Pfizer, what is BMS going to tell me? They're going to say, are you giving a preferential treatment to Pfizer? Okay, so that risk, that mindset, but once it became public information after HIPAA, when interoperability became a mandatory requirement, now the data is getting interchanged very freely. Yes, ma'am. I'm sorry? I can't.
Thank you, Mr. Sabharwal.
I'm working in medical informatics, and in the process, I realize there's a big hindrance or resistance from the doctors to use computer recording their findings and things like that. They're scared, actually.
Yeah.
If they, for practice, if they deviate, what will happen to them?
Yeah.
So, do you think there is any kind of government mandation on table until and unless it don't happen? I'm sure.
You are correct on one part of your assumption. Maybe the second part is not exactly accurate, right? I'll tell you why. So the regulations can come, and people will always figure out a way to bypass the regulation. Okay, that is human beings, right? We do figure that out, right? Abha ID is a very good program. Abha ID is going to force it, and as I said, it is always a carrot and stick thing, right? Right now, carrot phase, stick phase is coming, okay? But then there will be people who will say, okay, fine, I will not use the impanel patients, okay? I don't care about them, all right? So they will still bypass that. It happened, I'll take an example when I was talking about Rios. Santa Barbara in California put in almost $90 million to set up that Rio. Failed, miserably failed, because no doctor will provide the input out there. In St. Louis, there was a small little county Rio that was created. They came out with a very, very innovative idea, and it was an amazingly successful Rio. Okay, in fact, President Obama mentioned it by name. The reason why they did was they told the doctors that every time you put the data in my EMR package or the cloud provided EMR package, I'll give you 50 cents. Now that was contributing directly to the income of the doctors, and the data started coming in boom, 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 boom. That 50 cent, Abha ID 20 rupees, what is the comparison in terms of overall scale? I don't know. But ultimately, some mechanism of that sort will happen, and it will overcome that whole rigidity about sharing the data and everything.
Thank you.
Thank you. So we will move on to the proceedings of the program. Next proceedings of the program. As you know, every year we come out with a thought paper by PwC. So this year it has been drafted on quality measures and standards for transitioning to value-based healthcare in India. So I would request my colleagues to please hand over the copies of the thought paper to the dignitaries on the dais. I would request Mr. Shantan Chatterjee, Co-Chairperson, Health National Committee, the Bengal Chamber, and Executive Director, PwC, to please also join us on the dais. So we would request the dignitaries on the dais to please formally release the thought paper. It has been uploaded in our website, so we will send the link of the thought paper to all the registered participants. So, with this, we move on to the next speaker, Mr. Abhijit Banerjee, Senior Vice President, the Bengal Chamber and Managing Director, Linde India Limited. We would request him to speak on perspectives on standards, oxygen, a critical product.
Morning, ladies and gentlemen. Thanks a lot to BCCI for giving me this opportunity to talk about a very important subject. Perspective on standards, oxygen, a critical product. Okay, yeah. The element oxygen is elemental to life, but invisible. It's universally available, but sometimes scarcely there for you. Just let's explore about how standards transform this humble molecule of oxygen into a lifeline for healthcare. Let me share some experiences. During the pandemic, especially the wave 2, which occurred between April and June of 2021, India's demand for medical oxygen went up manifold. What used to be around 700 tons of medical oxygen per day, the demand went up to almost 10,000 tons per day. The hospitals became battlegrounds, and oxygen cylinders and tankers became the main symbols of hope. Behind every oxygen molecule that reached a patient, there were several unsung heroes. The production teams, the delivery teams, the teams which were managing the distribution systems within the hospitals, just to name a few. As the leading supplier of medical oxygen in the country, I have received several messages of acknowledgement after the whole thing died down at various forums from various institutions, various individuals, thanking our teams for what they did. But I think what we missed out on was appreciating the standards followed by companies like us, which helped ensure that oxygen was there as a promise of purity, safety, and life. Let me talk about a bit of the standards which are there for medical oxygen. Medical oxygen, as everyone knows, it's a precision product guided by several regulations. We have the BIS IS 3096, which mandates the purity of 99% plus, and also the contaminants which are allowed maximum amount. The Indian pharmacopoeia has two types of oxygen. One is the oxygen IP, which is again a purity of 99% plus. Subsequently, to enable the use of oxygen coming out from non-cryogenic production facilities, mainly the absorption systems, oxygen 93% was also introduced, which brought down the purity to 93 plus minus 3. But the contaminant levels in that oxygen 93% were also prescribed. As far as the storage and transportation of oxygen is concerned, there are regulations from PESO because oxygen is a hazardous molecule. It supports combustion and explosions and a lot of other things. So there are regulations in terms of how this oxygen, either in a liquid form or in a compressed gaseous form, needs to be stored and handled. But behind these standards, we have several other standards, which I could say are the silent guardian angels of our industry. First of all, the Drugs and Cosmetics Act has a Schedule M around good manufacturing practices, so that it's ensured that medical oxygen is produced under the most stringent conditions. The benefits of this include contamination control, so that external contamination, which can be very harmful, both in terms of patient safety, as patient health, as well as safety. Because I mean, things like hydrocarbons can create havoc if contact with the oxygen. Ensures hygienic conditions, lots of regulations in terms of quality assurance, and last but not the least, the regulatory compliances. The journey of an oxygen molecule from the manufacturing plant to the patient is also governed by several guidelines. We have the ISO 7396, which ensures that there's a seamless oxygen flow to the ICU patients, maintaining pressure and safety all the time. We have the NFPA 99, which governs how, what safety measures have to be there to ensure that this molecule reaches a patient safely. We have instances in India, for example, in Nasik, that was sometime in 2021, there was a huge fire in a hospital just because NFPA was not followed. It's still non-mandatory, by the way. These standards ensure that there is efficiency and safety. What are our priorities going forward? You know, as I said earlier, oxygen is available everywhere, so sometimes scarcely there for a patient. So the outreach of medical oxygen to the farthest corners of the country are absolutely a priority. There are a lot of places which are far away from, let's say, the main producing sources, the cryogenic air separation units. There are technical solutions around that, which are the small on-site oxygen generators, the PSAs or the VSAs, or the adsorption technology. I'd mentioned that when I was talking about the IP. IP covers it, but we believe a substantial amount of work needs to be done on the Indian pharmacopoeia itself to ensure that there's a regular compliance on the quality checks which are necessary for such products. Digitalization. This is something our company firmly believes in. And using the latest technologies available, IoT, et cetera, to constantly monitor the oxygen purity as it's being delivered inside a hospital, as well as monitoring the inventories that the hospitals are carrying at any point of time, so that we don't see what in our parlance is called a stock out. And I think we also need to talk about, in India, talk about harmonization with global standards, which will help cross-border collaboration and can also help in exports. To conclude, this is a site a lot of us have been through. Beloved one, gasping for breath, and then finding solace in an oxygen mask. Just need to appreciate that behind that mask lies a universe of standards which have been created by scientists and technologists, enforced by regulators, and upheld by industries, all so that a single life can be sustained. Thank you very much.
So moving on to the next speaker, Future of Pharmaceutical Industry in India, Mr. Devoshi Dattagupta, Co-Chairperson Biotech and Pharma Committee, the Bengal Chamber, and Managing Director, East India Pharmaceutical Works Limited.
Good morning, everybody. Our beloved President, Sri Arnab Basu, and dignitaries on and off the dais. Welcome to Health Tech 8. Very, very important topics to be discussed today. Well, in the morning when I was coming to attend this important session, and of course made a mistake and I went to BCCI first. And while I was coming here on a taxi, as I had left my car, and I was thinking about the main theme of the program today, as we are talking about basically future, technology and quality, all three of them. Now, as I was coming in the morning, I had a little bit of paper in my hand and I was studying it yesterday evening. And my wife, she's a psychologist, she was asking me, what are you reading? I said, I have a session tomorrow, a very brief 15 minutes on the future of pharma industry. And she said, do you realize, have you been reading the newspapers for the last 2 days? I said, yes, I have been. I said, do you realize what kind of a soup the industry is in? Like, have you read about the articles regarding the lower quality of drugs that has been tested by the drug control? I said, yes, I'm aware, because we are getting the news as well. Now, as our president had also mentioned, quality of healthcare, that includes quality of medicines as well. So I actually represent the pharmaceutical manufacturing industry, as well as we are marketeers. As an organization, we have been doing it for 90 years now. But just to give you some idea about the future of the Indian pharma industry, I'll share some data and then I'll try to shed some light on what exactly the industry is heading to in the future, as far as medicines are concerned. So as you know, the industry has been growing around 9 to 10% every year, excluding COVID. COVID had a different rate altogether. But in 23-24, the industry was valued at around $50 billion US. And by 2030, it's supposed to go to $130 billion US. And by 2047, around $450 billion US. Now again, with medicines, there's another feedback I always get, that why are the prices so high? Why are the prices so high? Now, we have to understand a few things here. In order to maintain quality, there are some methods, rules, and regulations, as Mr. Abhijit Banerjee also mentioned about Schedule M of Drugs and Cosmetics Act. Our manufacturing also falls within that particular schedule. Now, as India is known as the pharmacy of the world, as you know, we are the largest exporters of generic medicines worldwide. Now, what happens to the 150 or 140 crore plus people in India? Now, what about them? The regulations, rules, processes are very strict that has been laid down. India has a new drug policy that has just been announced a few months back, and there the rules, regulations, and processes have been made even stricter. In order to make a single file tablet, there are extremely strict processes. This, coupled with a very robust retail process, is required to make sure that whatever you are consuming from the store is of the best quality. And I normally get this from a lot of people, that how are we going to understand whether the product is of the best quality or not. Again, the government machinery is there. It has become even strict now, which is absolutely required. But you have to understand the dynamics of the Indian pharma retail it's a very vast market. And I was hearing to Sri Savarwal, he was talking about US. Indian retail is very, very different from what happens in Europe and in US. Now, to control that, the government has developed a lot of new processes which has been implemented in the new drug policy, especially with Schedule M. Our plant in Kolkata, where we manufacture our medicines, we have been updating very regularly, and the rules and regulations and the technology that is coming in the future will make it even more robust. in these sessions, we will be talking about AI and technology. That is coming to pharma manufacturing as well. Now, India is going towards a policy of pharma manufacturing where there is very limited human intervention. You know, I remember when I joined the company in 2003, I had training in the manufacturing plant. I remembered that to manufacture one strip of tablet, there were around 16 people in the chain in the manufacturing area. Today, with more advanced machineries, there are only one in place of 16. And that person is supposed to look at PLC screens to see whether the machines are running properly or not. And there is another person visits from the QA or the QC to draw samples. So it's gone from 16 to 1. And there are indications that in the future that it might become zero altogether. That is what the government is saying. No human intervention in manufacturing of medicines, so that there is no chance of contamination. So that is what India is heading towards as far as the future of pharmaceutical manufacturing is concerned. Very strict rules, extremely strong administration which is required, tougher laws and very tough punishment. I hope that that is done in a very strict way in the years to come. And along that, we need a very strict, robust rules and regulations for retail as well. For example, our market is such that whether I think most of you might have done it. If you have done it, I request not to do it. Most of you have gone to your local retail shop and bought an antibiotic, right? It's very easily available. But legally, you are not supposed to have an antibiotic without a doctor's prescription. But in India, it is possible. It is still possible. But there is a change coming. If you are ordering from an online pharmacy, most of the time, if you order antibiotics, you are supposed to upload a prescription. And in most of the cases, you get a phone call, right? From somebody who will tell you that I'm a doctor, I'm calling from, say, the X online pharmacy, and what is your problem? So there is a change coming in both ways, both in manufacturing and in retail. So for us to have a very robust pharma environment where the end customers will have full faith on the product, we need a lot of work in both areas as well, in manufacturing as well as in retail as well. So as you had some idea about the amount of the size of the Indian pharma industry for the years to come, this will only be fruitful when it is supported by extreme use of technology, AI, and very strict laws and extremely strict administration. I keep on telling this, that extreme strict administration is needed. And for us, the pharma manufacturers, we also have to make sure that whatever we produce is of the highest quality. There should not be any compromise in the products that we offer. That is our industry. So for the last 2-3 days, I have been hearing, a lot of people in my housing complex, they've been very afraid of what is happening. But I do not think that there is, yes, it is worrying, but let me assure you that the processes, the law, the platform is already there. And the medicines that are made and in India, following the law, is of the highest quality. So rest assured, but at the end of the day, as I always say, I wish all of you good health. I hope that you do not need to take medicines in a big way in the future. Stay healthy. In case you need it, we are there to provide you the best quality medicines and services as well. So thank you.
Thank you, Mr. Dr. Gupta. We'll now request Mr. Abhijit Majumdar, Chairperson, Health National Committee, the Bengal Chamber, and CEO, Apollo Multispecialty Hospitals, to please address us on leveraging technology to improve healthcare quality.
So, very good morning, distinguished members on the dais and the audience here. I'm being told to talk about leveraging technology for the improving quality of healthcare access. And I come from Apollo Hospitals. We treat patients. We treat about 1 billion patients. Treating is something that we aspire to. So when I was given the topic, I thought I will talk something which probably people in the dais and on the audience can relate to, and that's what my 10 to 12 minutes discussions will try to emanate from. The idea is to talk about on ground what Apollo is doing, and also to talk about what is coming in the future. Please understand the audience here is, there are few things which are in the build-up stage. We don't get to see what is happening, but it is important to envisage how care continuum is changing. And there are several discussions since the morning that has happened. The advent of technology, Mr. Sabharwal has discussed. The insurance front we discussed. The huge gamut of pharmaceuticals that we talked about. And all that thing encompasses to the fact that everything that we are doing is try to do three things. One is improving the access to care, which is very, very important for any patient living any part of the country. And I limit these discussions for within the country by itself. Second thing is the improving the affordability of the care that we provide. The extreme complex care that we provide has to be affordable, and increasing the efficacy of the patient care that as a technology provider, as a pharmaceutical company or an insurance, everybody put together. So for the essence of discussion to be all encompassing, we'll try to put a bit of a theory that I know a little bit, and also how Apollo is doing on ground so that it's easier to understand. Having said so, I'm sure there are many people here who possibly knows things better than me and probably have various ideas. And as we go forward as the Bengal Chambers, the advent would be to integrate that and then put it into perspective. So as I said, the efficacy, the efficiency and the affordability is the primemost thing. The healthcare landscape is changing very fast. And again, a hospital and a patient starts with the factor of disease. And the huge effect of AI as well as the machine learning has advent on the disease pattern, and the identification of disease is enormous. For that, all that we want is to create a robust data system. So today's, the effect of Apollo Hospitals and various providers are to create an effective detection system which would be enablement through the technology and as well as the diagnostic processes. Predictive analysis is something very, very important. And our founder chairman, Dr. Reddy, was been advocating and has been advocating very strongly. So we have a collaborative process called Apollo Pro Health. If anybody can go through, you have time when you browse through while you're through the traffic, it will talk about how the predictive health analysis over a period of time, as I undergo a health check, rather than putting a data in a cupboard, how it can be integrated. And next couple of minutes, we'll talk about how we envisage through various partnerships. The clinical decision support system, which is a clinician-driven activity which is processed through AI, is something that we are building up. Personalized medicine, we all know it is changing. The targeted and the personalized medicine is the call of the day. You talk about targeted therapies in oncology, or a patient who is having a COPD, treating each patient differently, one to the other, that one size fits all is not going to be the norm of the day, is something that we are going to talk about. Telehealth evolution, we in India started in the way back in 1999 when President Bill Clinton came to India, and our founder chairman, Dr. Reddy, had the first telemedicine consultation being envisaged from his village in Chittoor. So today, our Apollo Telehealth does virtual consultations across. The mobile health app, a multi-channel health app called Apollo 24/7. You can browse it through your Android or the iOS. You can. It's a marvel that the technology has given us. Though we have made it, but it's the advent of technology and various partners, we have made it happen. And the Internet of Things by tracking devices. Many of you are wearables right now, which can actually capture the data and transmit to a provider, which will actually make the algorithms in a possible way that will talk about the detection and the treatment by itself. Now, about the future of hospitals, as we envisage it right now, we thought in 4 parts. The hospital starts with patients. So first, the patient disease detection system. The second is doctors. The providers of care continuum are the doctors, for them creating a platform which will address that. For the nurses, a very important component of care delivery is something that we are going to build up in the days to come. And obviously for hospital operations. So as you see, there will be Internet of Things providing connected devices, be it a heart monitor or a ventilator, from where you can transmit the data from a central server. over a period of time, you can do a gamut of things while you are a provider or you are treating a particular patient over a period of time from home where the data is being built up. That's something we are very actively looking at. For a hospital of any nature, there are providers present here. The asset tracking is something, many of you are already doing it in some way or the other. The opportunity of doing it is huge, and again, affordability. We talk about being in a hospital, utilization of assets and other things. What technology provides us is a framework how you can best use that technology to make it happen for your asset tracking and justify your ROIs. I think many of the administrators have heard of so many times about return on investment. I think in today's world, with a complex gamut of things happening around, for identifying the assets and tracking it and effectively using it, Internet of Things will provide a huge solution. The smart hospital rooms, we recently had a collaboration. Our joint managing director, Mrs. Sangeeta Reddy, she actually collaborating very closely on healthcare evangelist with Microsoft as well as Google. This will give, as I spoke about, 4 pillars. One, the doctors, second, the nurses, third is the hospital's operations, and fourth, importantly, patients. Imagine maintaining a queuing system by doing effective management of provisioning in your ER. How are you going to separate the patients, a patient with a critical COPD ailment coming and a simple cough and other things coming up together? Those are the things for physicians, for nurses, for the patients over a period of time, data being built where EMR will play a major role. We'll talk about it in a short while from now, as well as for your hospital's operation. That is the hospital of the future. On the absolute right-hand side of your screen, that is what we have seen and we have envisaged that is how it's going to be. There are several ways of your monitoring and keeping the data through the AI-driven approach for the surgical monitoring, for different areas of patients' engagements, for chronic disease. The EICU and teleemergency will come out in short while, as well as the alerts for certain patients where parameters are jumping while being in a hospital. The effort again is to ensure the quality of care increases with cost being kept in mind, and it's kept at a minimum possible level. Robotic surgeries, we know many of us talk about it. You go to the city, sometimes you feel possibly there are more robots than doctors in the city. But actually, it's a master and slave relationship between a doctor and a robo. The XI version, which have been introduced by Intuitive, one of the finest robot makers across, we have seen on our hospital itself in Calcutta, the how scenario is changing. And with a Robo 5 coming, which Intuitive will introduce in quite a few years from now, US FDA has approved it and some kind of stratification work is going on here. You'll see a sea change with huge reduction of the hospital stay, and forget about the fact that the huge blood loss and other associated symptoms with the surgeries happen, that's going to come down. Now, many people talk about the cost. So obviously it's a build-up thing which is happening up as technology is being embraced by many providers. So I give the best example as an administrator as we have. Apollo did its first liver transplant way back in 2001. It was costing in Indian currency is about 24 lakh rupees at that point in time. We did on a young kid who eventually went on to become a doctor. And after almost 25 years, we are doing the same liver transplant surgery at a cost fractionally lesser than that even in city of Calcutta. And that's the power of technology and power of scaling up. And that's what we are looking at. Robotics is a future, is hugely derived from the fact that you effectively integrate machine learning and AI together to build an effective system which is going to take forward. Now, everything is possible when you have a robust data system. The insurance today, many of us working in the hospital knows that the way we send a pre-auth or the way data is captured from a patient or a pre-existing record or history is spoken has nuanced things. And it is something which is a cause of concern both for insurance, for a patient, and for a hospital as well. It creates a trust deficit which is difficult to meet up at times. And I don't need to go into the detail of how it happens, but it's an acute problem. The only way all the things that we spoke about is possible to be delivered when you have a robust the electronic health record system built up. I'm sure Government of India and various state governments, including Government of West Bengal, has taken numerous measures to build the data system in your thing so that you can build an effective algorithm and use the technology to propagate what is coming up in the front stage. So yes, in the morning there was a discussion about the doctors are embracing technology. Our experience shows that as time progresses, nobody is a better adoption maker of any technology on any front than the doctors. The way they change themselves, the way they embrace technology, And we have seen some of the senior most doctor taking up a robo. And imagine at the age of 45, it is much easier to adopt a new technology, much easier when you are born with it. But if you have to adopt it at the age of 50, the only fraternity which is capable of doing that are doctors. So we are very hopeful that EHR, both in OP and IP, which our hospitals, like many other hospitals across the country, is producing, will be actually the backbone of the system being provided. So what it makes is, it empowers patients to think differently, interact with a doctor with the data in hand, and you can seamlessly provide anywhere and get into anywhere without thinking about your data and records being carried on. We'll not get into much technicalities. Few of the things that is coming up in the future is genomics-based therapies. Many of the hospitals are adopted that all too. Pharmacogenomics is something which is coming up, and I think the members here present probably would be able to throw a lot of things. One of the areas where we are using technology and the AI in a huge way is the precision oncology. Precision oncology is something that Apollo hospitals, like many other in Mayo or even the others like Sloan Kettering, is adopted. We see it coming, and technology is embracing the better results for our targeted therapies which is coming up. The factor again is to understand the disease and build a huge database which will, over a period of time for a particular patient and a community as a whole, which will build the ecosystem. That is what we are looking at. And the other thing that we can also talk about, the huge issues of psychological health that is affecting all of us. I think COVID has probably facilitated a need for taking it up. AI is coming up in a big way. Apollo, like many other providers, provides adequate importance to the fact that mental health is equally important as the physiological health. That is something where AI will have a huge approach coming up in the next couple of years, and you see that Apollo is also taking up great measures from the front in many ways. 3D printing, many of you are aware, already we have seen in orthopedics while you are doing the replacement therapies, but it is coming up in a huge way. A lot of research is happening in some of the Scandinavian country, US and UK, where AI and the machine learning would be actually integrated to do something which will take care of probably an organ donation factor in going forward in future. That is what something which is coming up. Lastly, I'll end up by saying all that thing is not a theory. Today in our hospitals, even in Kolkata, we actually connect 7 states where a patient admitted in a ER or even in a critical care bed in remote corner of, say, Darbhanga, or instead of that, a place like Godda, many of us have not heard of. In real-time basis, data is captured and sent to our central OS system, and the numbers which sounds like 27, 71, 19, 24, 25 are vital health parameters which are recorded on a second basis on a real time. The importance is have to sanity of the data and the data efficiency being maintained. We have a platform which we have built up to do that, put together. What it again does is to give that similar level of care, and I use the word very carefully, similar level of care of somebody sitting at the hospital in a metro in a tier 1 city against somebody who is sitting at tier 4 city for a need for a care. But all that is possible, what we have spoke about, when you have that gentle heart there taking care of people with all the empathy for the patient care, which drives the healthcare organization. So here, ladies and gentlemen, we'll envisage a day where any, God forbid, on a highway, an accident happens, the AI-enabled traffic management system actually allows the 5G ambulance, which is present in many of our hospitals, and Calcutta, Apollo was the first to introduce, will give a trigger that patient had this vital change, and through wearable devices, you can actually have tracking data of that individual built into the national database, and you will see the whether what kind of a blood loss you will be able to have and what therapy you need immediately in the ambulance. In the ambulance, you can actually connect with ER of Apollo hospitals in anywhere in the country and per se any hospitals going forward, and you start the treatment very reason from there itself. This is not future, as it sounded as funny and very adventurous to talk about a vegetable vendor sitting on a corner taking the money through his smartphone. Many of us couldn't even think. As much we couldn't think of a hospital revenue coming 60% from insurance segment. 20 years back, many of us know we would be thinking of 1,000 times before talking to an insurance company, and probably we'll give our appointment after 20 days, and today reverse happening. The way technology will take shape is much faster than even we can think of. The only thing we'll have to be is open mind to adopt it and scale it up. And we are very hopeful we'll be doing that. And we are very hopeful Bengal will lead the way in taking it forward. Thank you so much. Yeah.
We would conclude this session, and before that, we would request President Bengal Chamber to please present tokens of our appreciation to Mr. Abhijit Banerjee, Senior Vice President and MD, Linde India Limited. Mr. Abhijit Mojumdar, Chairperson, Health National Committee, the Bengal Chamber, and CEO, Apollo Multispecialty Hospitals. And I would request Mr. Abhijit Banerjee, our Senior Vice President, to please present tokens of our appreciation to Mr. Rajiv Savarwal, partner PwC India, and Mr. Devoshi Dattagupta, Co-Chairperson, Biotech and Pharma Committee, the Bengal Chamber, and Managing Director, East India Pharmaceutical Works Limited. So we are concluding this session and moving on to the next session, which is, So the next session is a theme session on quality measures and standards for transitioning to value-based healthcare in India, which is the topic of the thought paper. And so we will have a presentation on the thought paper by our co-chairperson of Health National Committee, Mr. Shantan Chatterjee, Executive Director, PwC, which will be followed by the virtual keynote address by Dr. V.K. Paul, member Niti Aayog, and the panel discussion on the same topic, moderated by Dr. Preet Matani, Executive Director, PwC India, having panelists Ms. Sugandhar Ramkumar, soft skill trainer and counselor, Caring Minds International and Principal I Can Fly International School, Dr. Pinaki Bandopadhyay, Medical Superintendent H.P. Ghosh Hospital, Professor Dr. Shantanu Kumar Tripathi, Principal and Professor of Pharmacology, Jagannath Gupta Institute of Medical Sciences and Hospital, Dr. Sudipta Bhattacharya, Medical Superintendent, Peerless Hospital, Kolkata, Dr. Wing Commander Sareen Raj, Deputy Medical Superintendent, Ruby General Hospital, and Mr. Venkateswarlu, IT Head, Woodlands Multispecialty Hospital. So I would request Mr. Shantan Chatterjee, Dr. Preet Matani, and the panelists to join us on the dais. Sharbani, would you take forward from here?
I request all the delegates to please be seated. We will proceed towards the next session. Our next session is the theme session on quality measures and standards for transitioning to value-based healthcare in India. We will start with a presentation on the thought paper. I request Mr. Shantan Chatterjee, Co-Chairperson of the National Healthcare Committee of the Bengal Chamber of Commerce and Industry, and Executive Director from PwC India, to please proceed.
Good morning, everyone. Thank you for joining. And I think my task is a lot more simpler when you have stalwarts who have actually spoken a lot about the topic as such. But as per norms and all, we'll just be taking you through the glimpse of this paper. Obviously, this paper is on the Bengal Chamber site. You can go there. It will be on our PwC site as well. So the intent is not just to take you in some of the concepts, we'll take you some of the things as well in simplistic as it was explained by the panel. But the key thing is also to share what is happening on the ground, give a glimpse, I would say, of the India story, as we say, or the Bharat story. What did our survey cover? What are some of the salient points? And most importantly, what's the action, I would say, going forward? So I say, what is value-based care or value-based healthcare delivery, as we are talking about? It's a combination of all the things that you see on the screen, right from the bundled payments, the capitation model that was being referenced in the morning, the pay-per-performance, the entire focus rather than just being on service, on outcomes, on actually the impact that it creates on the patients on a whole. So on the right-hand side, what we are doing out here is the focus not just being saying this a service was provided, or an episode of care was undertaken, or a medication that was done, but what happened post that? What actually happened from that medication? What happened from that visit? What happened from that, I would say, care being, given to the patient is the focus, right from the patient-centered thing. So what and how did it impact? What did it help in saving? Now again, these are few things which sometimes contradict, but over here what we are talking about when the word value comes in, and that's a very, I would say, abused word in some context, but in healthcare context, the value is when I'm able to achieve the outcome we are talking about. And in doing so, how are we sharing the risk? Because if you talk about, we are talking about human lives here. So all these things is what encapsulates value-based care talking about. And what are the measures? See, because we have been talking since morning about this entire focus around being technology-driven, something what we call is like healthcare, which is being, as I say, it's a human-delivered but technology-empowered. So end of the day, what are we talking about in this case is some of the measures, and why it's important, because it's human lives we are talking about, right? From the clinical measures, which is what I was saying in terms of the outcome, what it actually achieve, the entire focus on some of the cost measures. So how can I basically be, if not the word frugal, but in terms of efficient, in terms of being operationally more, I would say, superior with regards to delivering that care? And to do that, what are the process measures? Now, all these things is what basically ties this entire value chain. So it is not just about the measures. We are talking about how the outcomes. And to do that, what are the processes? And to do that, what is the experience? Now, this thing is a new addition, I would say, in the last 5, 6, 7 years, where the entire focus used to be primarily on the care being given. The thing that has got it primarily added is the experience. Because it's not just about a human that you're providing, but the way you are providing is also equally important. And to do that in terms of efficiency. Now, if you tie all these measures together, is what it comes out to. I'm just trying to simplify some of the blocks, because as which we may try to basically put this, but it is something which is a hugely important and pertinent topic in today's world, especially in Indian context, where we are seeing a lot of evolution happens. So what's been the journey? So we were talking in the morning that some of these things the ball has started rolling, and all of us in out here sitting in the room are part of that journey. So right from some of the, I would say, initiatives which the central government has taken, the state government, because healthcare is a state subject, goes towards it. So in terms of the digital health infrastructure that gets rolled out, in terms of the Ayushman Bharat initiatives, now similarly there are initiatives at the state level also. The digital health mission, now the entire thing around ABDM that was referenced and mentioned, the entire focus of how do I have a unified health interface. It's a huge, I would say, vision that we are all working towards. And all this cannot happen without a public-private partnership. Because healthcare, we may have a notion of sitting out here, it is being primarily the metros, primarily the cities, but that's not the reality that we should be blinded by. There is around almost 80% of the population who has or is based in a rural setup, and where there might be a public health setup which will be nearer and servicing that. So how do you get that in board? So what you see is in terms of we have tried to put I would say more like a journey map to see that how have things started rolling. Right from the National Health Stack in 2017, and not that things were not happening before that, but we have just trying to take a near, I would say, view to some of the things in terms of the comprehensive, the primary healthcare, the CPHC as we say in terms of getting rolled out, The National Digital Health Blueprint 2018, that was a significant, I would say, initiative where the blueprint was done by at the central government and how it is then being rolled out across the states. 2021, in terms of the quality cells and the checklist being, I would say, there. 2022 in terms of the location-based HPV pricing. So if you see the journey, these are all important blocks that have been, I would say, coming in. Then in terms of 22, the value-based incentives being introduced, and 22 in terms of, again, in terms of the continuum care, the DRG-based payment. So what you're seeing is, as much we may think that it is an episode link, but the entire way, and obviously we should give credit to all our, I would say, stalwarts in terms of at the bureaucrats, at the ministry, and obviously led by the Honorable Prime Minister and his team, to be setting some of the things in motion. So when you talk about a blueprint, when you talk about some of the incentive measures, you talk about some of the value measures, these are all being in place. Now it is very important for each of us sitting in this room to be A, cognizant on what's happening, B, try to say that how am I basically in sync with those initiatives, and C, most importantly, try to communicate that and take it forward and not just let it be on paper. Because if you think about it, for some of you might say, oh, is it still happening in India? That's the reality. That surprise element is something we should be taking out. And then communication to the patient that, okay, this is what is happening, this is how care is being delivered, this is what the value is actually linked to it, and all the things that we spoke about, that the measures actually become the true proponent for it. I'm just trying to, it's a breeze, so if you feel it's at a pass, the pace is a bit fast because it's just a glimpse of the paper. You can do a detailed read of the paper on the site. So this is some of the primary survey that we did. In fact, there were 60 plus respondents from various healthcare fraternities. It was a survey that we conducted with select individuals as well. And some of the, I would say, responses were not too, I would say, surprising, right? The first one, where only 50% of the respondents perceived value-based care as a patient-centric. Now, if you think about it, that number should have been definitely in the high 70s and 80s, which tells that there is still a lot of work to be done in terms of disseminating this information, this communication, this actual on-ground thing that this is what's there, this is what is to be done. Now, whether it's a primary, secondary, or tertiary care, a doctor, a physician, or an administrator knowing exactly what it means, how they are actually doing it, and what is that they need to be doing to further that. That's one of the key things. Then in terms of some of the, I would 60% respondents believe that the model could address problems like poor healthcare outcomes, which is a reality. But if you again ask me, the number should be significantly higher. Because if you remember the points that I mentioned, it takes into clinical, it takes out outcomes, it takes about cost, it takes about operational efficiency. So in a way, it puts all the dots in a very well-rounded manner. And then in terms of some of the things that it said that what it needs to be doing. So for the fourth point, which is to say that respondents also agreed that to do all of this, and that's a critical section of a paper, there is a huge enablement of technology that is needed. And that goes needless to say today, nowadays, that anything is there which is not tech-driven or tech-powered, as we say. So it will always be human-delivered, but it is all tech-powered. So a lot of the things, in fact, I'll show you a glimpse of where and how tech power, I would say, delivers it, or what are the initiatives, or what are the interventions, what are the applications which are enabling this value-based care. So that was a realization that most of people realize that there is so much to be done by a tech. So it is not just only a manual thing that we are talking about. Then the last bit, in terms of 65% of the respondents believed in terms of the robust policy and regulations. Very important part of it, because one is having the concept, B is having the means, which is your technology infrastructure, but the way to make that is basically your governance and process to make it operational. Think about it. In fact, it's something the day-to-day life. Like, how do you make it operational is to do in terms of the discipline, the processes that we are part of it. So which makes it not just a good to do or an optional do, it's a must to do. That's what we are talking about. And that's what some of the survey mentioned, and I think it was resonated. But it also tells that we can look at the glass being half full or half empty. I would look at it being half empty. There's a lot of work to be done, as I'm repeating, with regards to understanding what it means for me in a healthcare setup or a payer setup, because it's, and when I say healthcare, it is both clinics and as well. B, what is that I need to be doing to basically achieve that? And C, how is that I then communicate to the patients of what is that being done in this regard. So all these three things are equally important as we go in. Some challenges, I think the font is too small, but I think the key thing, as I mentioned, how do we propagate? How do we ensure that the measures that we are talking about are not just on paper? Because a lot of times where we have seen that we have the measures, we have the quality measures, we have the standards, we have the best-in-class KPIs that are there, but they're merely on paper, or even the data that is being reported is just because for the sake of it. That ultimately may be good for a audit, but it does not basically go with the ethos of what we are calling a value-based care that we are talking about. Then in terms of, I would say, the challenges with regards to the data, the baseline that we're talking about. But first and foremost, I would say the challenge is the realization that people understand what it means, what are those 5-6 blocks that we are talking about, and how it is happening now. In fact, I had a slide, because of paucity of time, we are not showing it, but if you go in the paper, we have also shown some of the reference models of where, what is happening where and all. It is good to be, I would say, inspired by others, but it's very important to have that Bharat context of what is happening on ground and how do I make it operational. That's one of been my key learnings when we were doing that, and I'm sure that you will basically, I would say, echo that. Again, a busy slide. Trust me, don't worry. This all our content is there on the paper. How we have seen that across the different value, across the value chain, how does technology enable it? How does an EMR? How does an HIS? How does a patient portal? How does a wearable? How does a clinical system? They're all very important aspects in terms of the tech enablement or the tech powering that I was mentioning. So that's just a view to say that each and every of those applications and systems have a role to play for this vision to be doing. And just about ending, I would say, in terms of how we as PwC, we will be very happy to, if any one of you want to have a further discussion, enabling of how do we do that in terms of analyzing where you are, what is that operating design model that you need for your setup, for your organization, making it happen, getting the tech enablement done, the performance matrix put in place, and most importantly, making it operational along with you. I'm putting the last one as the most important. You can have the fancy of design, but till you don't make it operational in your setup, which works in your context, it will just be paper. So that's it, I would say. That's the fleeting glance. Sorry if I was just too fast in it, but hopefully you find the read useful. We found I would say, the topic very useful when we were working on that. And thanks to each of you for being a patient listener. And thank you. Thanks once again. Bye.
I request Ms. Angana Gora Chaudhuri, Assistant Director General of the Bengal Chamber, to please present a memento to Mr. Shayantan Chatterjee on behalf of the Bengal Chamber.
So, as Shorbani is checking with Dr. V.K. Paul's office, who will be delivering the virtual keynote address on AI in primary healthcare, we would request the moderator and the panelists to please join us on the dais, and we would request Shantan to please also stay at back at the, on the dais. So the session would be moderated, the panel would be moderated by Dr. Preet Matani, Executive Director, PwC India, and the panelists will include Ms. Sugandha Ramkumar, soft skill trainer and counselor, Caring Minds International and principal I Can Fly International School, Dr. Pinaki Bandyopadhyay, medical superintendent H.B. Ghosh Hospital, Professor Dr. Shantanu Kumar Tripathi, principal and professor of pharmacology, Jagannath Gupta Institute of Medical Sciences and Hospital, Dr. Sudipta Bhattacharya, medical superintendent, Peerless Hospital, Kolkata, Dr. Wing Commander Sareen Raj, Deputy Medical Superintendent, Ruby General Hospital, and Mr. Venkateswarlu, IT Head, Woodlands Multi-Speciality Hospital. So, Shorban, you let us know if you need 2 minutes, okay? We would request the moderator and the panelists to please take their seats. Doc- Thank you. Dr. Paul, can you hear us?
Yes, I'm able to hear you. Good morning.
Yes, good morning, sir. This is Angana from the Bengal Chamber. I had the privilege to discuss this program with you. Your talk would be moderated by Mr. Shantan Chatterjee, co-chairperson of National Health Committee of Bengal Chamber and Executive Director, PwC. Shantan.
Good morning, sir. It's a privilege having you here. Hopefully you can hear us loud and clear.
Yes, we can hear you loud and clear. Is the panel also on the dais?
Yes, they are on the dais, sir. So they are there.
Can I reverse the order of my inputs after I have heard the panel? As a Niti Aayog, my primary approach and I would say the mandate is to listen. So
Okay.
can I come in the end, because I'll be here for the next 45 minutes, the time that you have for the panel.
No, that would be really helpful, sir. Thank you. Thanks so much.
That's
In fact,
better,
so
because
we can have the panel discussion, and it will
Yeah,
really
I'm
be an
listening
honor.
to the panel discussion, and I'll be able to then intervene for about 10, 12 minutes at the end, having learned also from our very esteemed panelists.
Sure,
So
that would
please,
really
give me
be
this
helpful.
correction.
Thank
Give
you.
me this correction, and very warm welcome to the esteemed panelists. Looking forward to your ideas on improving improving and enhancing value-based healthcare in India and so on. Please.
Okay. Yeah, sir, just one question before I hand it over to the moderator. Do you have any hard stop with regards to your time so that we are conscious of that?
What is your hard stop?
No? Okay, fine. Thank you. Thanks
What
so
is
much.
your time? What is your timeline?
No, I think we have
Panel?
around our next
Tell me.
45 minutes. 110 till next 45 minutes.
110,
we are there.
110, no problem.
Okay, thank you so much.
I'll
Really
manage.
appreciate it.
I'll manage because it's an opportunity for me to do that. Please.
Thank
Thank you for
Really
grateful.
appreciate. Thank you.
Thanks, Dr. Paul, and it's an honor to have you with us. So we had some deliberations today morning, and we heard from other speakers about value-based care. Just a quick recap. Value-based care aims to deliver high-quality care with a pathway for enhancing patient satisfaction and population health while managing costs effectively. The focus is on quality over quantity, and there is a patient-centric approach to value-based care. It also means that we pay for the outcomes rather than for the service being rendered, not just the number of procedures being performed. So today on this important topic, I think we have an esteemed panel which has a mix of academicians, we also have clinicians, and we also have folks with skill experience on the panel today. So I'll start the panel by asking first, Dr. Sudipta. Dr. Sudipta, you are a medical superintendent, a clinician. In India, we build the best infrastructure, the best hospitals, but we still fail to measure outcomes, especially clinical outcomes. There is a lack of outcome measuring criteria as well as inhibition between hospitals from sharing outcomes publicly. Do you think measuring clinical outcomes, making measuring clinical outcomes mandatory, would help in improving patient care?
If you look into Indian scenario, there are more than 70,000 hospitals. And out of this, roughly around 1,300 hospitals are measuring clinical outcomes. And even if they're measuring, they are not sharing it with public. You know why? There is a fear that this might reveal weaknesses in their care system, and which can create competitive disadvantage for them, and also impact on the patient volume. And it is also true that there is no standardization in the capturing of clinical outcomes across different hospitals in India. This has led to the thing that you cannot compare one hospital's clinical outcome with other hospitals. Now, if we make, what happens if we make measuring clinical outcome mandatory? The first thing is definitely it is going to increase the accountability. The healthcare providers will become more accountable, and they will definitely have more focus on building robust quality processes, and the safety of the patient will improve, and in nutshell, the care will become patient-centered. At the same time, there will be more transparency. From the patient point of view, the patient will have valuable information in their hand. So they are prepared to take decisions regarding their healthcare needs. From the institution's point of view, see, they will be able to understand their weaknesses. They will be able to identify where they need to improve. And so they can build on their weaknesses to build a robust system. Also, they'll be able to analyze the clinical outcomes, which can become the basis of forming evidence-based practice in India. But Mr. Matni, we also need to look into the other side of the coin as well. Because what in India, this can lead to gaming the system. The healthcare providers might be incentivized to manipulate the data. Even the patient-reported outcome measures is not flawless. Then for the small institutions, it can create a challenge because some of the resources may be diverted from the direct clinical area. And then there is a lack of standardization in the outcome measuring, as I said, because many of the factors that influence the clinical outcome are not directly in the domain of the clinician or the healthcare providers. The issues like the clinical comorbid conditions, the genetics of the patient, his immune status, these and the adherence to the practices also impact the clinical outcome. So my opinion will be at this point of time, India, we should make it voluntary. If we make it voluntary, if we encourage healthcare institutions to voluntarily report their clinical outcomes and incentivize them, we reward them for better practices, that should be the strategy for India at this point of time. Thank you.
Thanks, Dr. Bhattacharya. I'll then go to Dr. Pinaki Bandopadhyay. Dr. Bandopadhyay, as a clinician again yourself, what do you see a role of a physician and how important do you think it would be in delivering value-based care?
Thank you, Dr. Matani. Doctor, the role of a physician is very important over here. What Dr. Sudipta was saying or intended to say, that we need to be recorded all the outcomes and need to be shared across the table and across in case of whole city. And fortunately or unfortunately, that practice we are not doing. So in case of that, but we being physicians, when we will meet with some conferences and discussions, panels and everything, we're only sharing the few case studies and something that's what actually we got it. In overall data picture, what we have, we hardly share across the things of the industry. If you want to practice, if you are talking about the value-based program, value-based thing in terms of outcomes, you need to, really we are intending seriously for that to improve the outcomes, then we have to think of data sharings across all hospitals, and that is integrated approach toward the society. Now, the second things are coming, what the clinicians and physicians thinks on it, takes is affordability. See, I would like to bring a reference. So some government schemes in West Bengal has transformed the cardiology cases extremely 80 to 85% on the schemes. So if we go the data and the patient's profile before, and so what the cardiology case, how the cardiology cases are getting reported before, and now how the cardiology cases getting reported and getting treated, you will start to see that there's the villages from down the line who has no options out there, they are coming to CT and getting it treated for small problems. In previously, it was, see, they used to go to government facilities, they used to be treated conservatively, but now they are entering into active interventions. Quality of life is getting better. So in case of cardiology, chronic acute myocardial infarction or some other cases, we hardly found neglected AMI right now we're reporting to with heart failure in nowadays in our hospital. So early interventions, transformation, all intervention going out there. So this is something a curative part. Something is now we have to, at the previous session it was discussed, is the preventive part. So preventive part is also have a heavy role. Thing is that we actually screen out for the cancer patients, we screen out the chronic patients. But some acute insults that can be prevented from the your changing lifestyle. These awareness and prevention detections on the potential cases. Suppose that we know that in future we will be having a huge problem regarding this dementia and neurological disorder. So dementia and neurological disorder is going to be the next epidemic. But you will hardly find, don't think, I even doubt if there is any screening procedures for detection of this dementia, early stages, and what we can do for that, rehabilitations. I am looking into some clippings were coming in the screen, some organizations here who takes care of the dementia and Parkinson's patients. But so we don't have hardly any screening over there. I have seen my relatives, friends, and circles, and a few patients also. The present day's usual representation of the dementia at the age of 50, 51, 52, also even in 46, 47 for few cases. So it is going up. So if future thoughts, past thoughts of getting these patients with these diseases from the later stage of the life, that it's bringing in early. In case of, you have seen this, Dr. Shetty has commented on cardiology patients. Initially, in the past, you used to happen the sons and daughters used to bring the patients to, bringing their parents to doctor for cardiological problems. Now the picture has been reversed. The elders are coming with the son of 40, 42 years for the cardiologist for the active intervention. So one cause is lifestyle that we can't change. We are running after rat race and everything. So prevention is important. Another thing is we have to link this not only prevention, we have to give the clinicians the confidence on that level, and this can be affordable. So I mentioned that government schemes and other things. So affordability is something that people should think in case of private sector or public sector, whatever it may be. Some standardizations, other things are required. It's a huge task to integrate this affordability with outcomes. But if people are not affordable, not able to, they will not report with the disease. And if they do not report with the disease, you will not get the proper outcome as desired. So this role is the physicians, not only the physicians, is the service providers also. In case of service takers, service provider awareness and other things, government also need to be integrated these affordable things. Otherwise it will not happen.
Thanks, Dr. Pinaki. If I may ask you, Dr. Tripathi, India has a very large population, and there is a dual burden of diseases. We are having non-communicable, but we are communicable, but we are also seeing a lot of non-communicable diseases coming in of late. How do you think value-based care can be leveraged to benefit the overall population health? What are your thoughts on that, Dr. Tripathi?
Yeah, this concept of value-based care is relatively new, and most of us currently involved with healthcare delivery, we have been otherwise primed in a setting where it is unduly more focused towards curative care and which otherwise address the interest of the provider more rather than the patient. Why I say this? Like I give you a small analogy. If I have a low back pain, what kind of management I'll get depends on where do I land in, which clinic or which doctor I visit first. If I go to a rheumatologist, or if I go to an orthopedician, or a neurologist, or a pain clinic which is dominated by anesthesiologists, the type of the management will differ. although we know that so far as chronic pain is concerned, it's a multidisciplinary management. But whether a given patient, singular patient, he gets the benefit of that multidisciplinary decision making in terms of his management. It ultimately boils down to what is the clinic or what is the hospital or what is the kind of doctor or specialist he lands in. Accordingly, he gets some management. When you talk of the patient satisfaction, and that is at the back seat. And from there, now we are now talking of value-based care, where a lot of emphasis has been given to the patients, patient-centric, and all the emphasis is given, but then the other players or the other stakeholders, whether it is provider, whether it is the payers, insurance, or the government, or even the other stakeholders, all will benefit by this value-based healthcare. Value-based healthcare. And this has been realized throughout the globe, and there has been a lot of experience already gained in different parts of the world. And in India, of course, Government of India has come up with the Prime Minister that Yojana, okay, that Jan Arogya Yojana, PMJ. So a very good policy has been laid down. That was in 2022. And that has been also integrated with the other programs, and gradually, because as we know that a vast majority of people in India, they are not covered with insurance, but this can be considered, PMJ can be considered as a tax-driven, okay, citizens tax-driven insurance system. And then the broad goal is actually to get under the spectrum of this PMJ, not necessarily the public system, public healthcare system, but also the private healthcare system. And it is true that the way it is now moving at this moment, it has not been made mandatory for everybody, but then through accreditation system, up till now the big hospitals, corporate hospitals, private hospitals, they are eager to get themselves certified, NABH certified, but then that's not enough. So we have seen that the kind of lack of patient satisfaction, even if I am insured, then out-of-pocket expense is still there. So all these have been considered and integrated, and in order to actually assess the functioning of the hospitals, whether and to what extent they are reaching out to the expectations, desired expectations of the patients and the society at large, the indicators have been identified, which also include not only patient satisfaction, the nature of the grievance redressal, the number of the readmission within 30 days after the discharge from a hospital. Besides, of course, the health-related quality of life, etc., all these indicators have been taken in. So hopefully it's a huge task, very challenging task, but hopefully we have made a very modest start only, and maybe in another decade or so, we'll be in a much better position so that a good proportion of the people will be benefited, and not only people or society, but also all other stakeholders, whether it is private sector or public sector, a much better quality of care we can provide. Thank you.
Thanks, Dr. Tripathi. Besides that, the government also has the Ayushman Bharat digital mission.
Right, of course.
A lot of data is being collected through the digital mission from
Absolutely.
labs, from hospitals. I think trends like AMR, antimicrobial resistance, and other things can be identified through the data.
That's a basic requirement, that you have to depend on the data and information and process them, and then only you can actually come to a situation where you can analyze and you can tell what we are doing, the way we are doing, whether it is satisfactory, and what is the areas where we have to strengthen ourselves further. So that is a must, and simultaneously in parallel there are also technological advancements. The AI is coming in a big way, machine learning, all these are to be integrated into to make the things more efficient rather. Thank you.
Thanks, Dr. Tripathi. Now, since we are on technology, I'll go on to you, Mr. Venkat. You being an IT in charge, how do you think that technology can be leveraged to play a key role in optimizing value-based care? And how important do you think is data interoperability in IT systems crucial for a value-based healthcare model if you have to transition there?
Good afternoon to everyone. It is a privilege to be here today to talk about something that is not transforming healthcare, but also important of the patient outcomes, actually. Leveraging the technology and the patient outcomes, right? For the value-based healthcare, the topic is great significant as the transitions we are moving from the fee of service model to the system emphasize of the quality of the care and patient outcomes. Okay, and let us first quickly define the value of based healthcare. Unlikely, the traditional fee for the model where the healthcare providers are paid for each service of and procedure. Value-based care model focus on outcomes. This means the healthcare providers are rewarded based on how they improve the patient health rather than the volume of services provided. The model pushes the better coordination, preventive care, and more efficiency of use of resources, essentially prioritizing the patient and outcome over the service volume. When you are asking about the role of technology, okay, how the technology play a key role actually for the optimization of the value-based healthcare. There are several factors, important factors, features are there. Because one factor will be like a data collection analysis on the professional, collect vast amount of the patient data ranging from the medical devices record to the real time of from the wearable device. Okay, by leveraging of the healthcare records, like healthcare records, we can continuously monitoring the patient progress to make the informed decisions of the care plan. Moreover, the predictive analytics, like predictive analysis powered by AI and machine learning, can analyze the historical data of the predict health trends, helping the identify and risk patient and enabling the proactive intervention. Now, you know that telemedicine and remote monitoring is growing significantly. Especially we wake up in the pandemic, allowing the healthcare provider to each and patient remotely with a remote kind of a thing and can manage the chronic diseases as well by remotely instead of going in the physical. Okay, there is a personal medical technologies like allow deeper understanding the individual patient profiles by using the genomics. Okay, and the advanced analytics of the doctors can offer more personalized treatment to the patient. There is a care coordination and effective care coordination also. In critical value care-based model, technology facilitate by enabling the healthcare providers into the digital platform for the easier and safer patient data and reducing the duplication of the tests and procedures and ensuring all members of the care on the same team. See, when it comes to let's talk about the data interoperability, okay, which is crucial for the value-based healthcare model. Interoperability refers the ability of the different IT systems, devices, applications, exchange, and interpret the use of the data seamlessly. Why this is so important on the value-based healthcare? Have the accurate, up-to-date information about the patient, make well-informed decision without interoperable system, and data become a fragmented. Doctors must have a full health of history of the patient and leading the potential errors and duplication of the test or even the misdiagnostics. Interoperability ensures that the data flows smooth across various platforms, whether it would be between hospitals or primary care providers or specialists or even across the regional healthcare system. The streamline of the data improve the patient care and reduce the inefficiency and foundation of the success value of the based. I will give one best example, ABA, right? In the ABA integration, right? there is a patient information can exchange from hospital to hospital or anywhere in the world. Because if we have a patient history information, the doctors can take immediate decision, because there is no patient history which is available. Because one of the patient will go to the one hospital and second hospital, third hospital, but the patient history, if you do a ABA integration also, that can be also, we can have a patient information. As we're looking for the future, integrating cutting edge technology is the healthcare is not an optional, it's an essential for us. With the rise of artificial intelligence, blockchain, and the secure data exchange, even the advancement of the robotics, we can expect an advanced connected the patient-centric healthcare system. The shift of the value, of the ensuring the patient receive the best care possible, and healthcare providers are improving the outcomes rather than the volumes. In the conclusion, what I will tell you is that technology play a pivot role, optimizing the value-based healthcare, offering the tools, data analysis to improve the care coordination and personalized medicine. Data interoperability is not a technical challenge; it's a fundamental requirement for ensuring that the right information is available to the right people at the right time. Thanks for your time. I believe that the continued innovation and the focus of the patient outcomes, technology will be help create a healthier and more efficient and sustainable healthcare system for everyone. Thank you.
Thanks, Mr. Venkat. Very aptly put. Thank you, sir. Dr. Sari, we spoke about various stakeholders, but I think the patient is one of the key stakeholders. And how do you think patient engagement and involving them in decision making, would play a major part in, achieving optimal value in healthcare, in value-based care?
Thank you. At the outset, thank you. And yes, till now we all have been talking about what the disease and who is treating that disease, a doctor. So the country has been following that there is a disease and we have to treat. But where we are treating on a patient, so we have to engage the patient whom we are treating. And we need to know the requirement, what exactly the patient wants the outcome and not only the doctor. A disease outcome for a doctor could be different, but for the same patient, what he wants out of that disease, what is his requirement, and what exactly he wants. Whether he knows he will be treated only for this episode, and again after 1 month, he again has to be treated for the same disease, or he will be once treated and will not fall sick again, or whether he has to keep continuing some kind of treatment. So these are the patient engagement. We need to engage first. We need to inform the patients what exactly is the diagnosis, what exactly would be required in future, and what the treatment protocol should be. Once it is well explained to the patients, then definitely they know the disease. And once they know the disease, the second step is to know the outcome. What exactly would be, whether it fits their aspiration, what their choices, and how they see it, perceive it, how good they will be, what will be the quality of life. Once they are treated, what will be the quality of life, and whether the same quality of life, what the doctor has told, fits as per his choices also. So once this engagement is there, patient understands the disease and he is more into a decision maker. With the doctor, he also becomes a decision maker. Okay, I'm suffering from this lap chole. Okay, only one episode, I'll be operated once and I'll be fit for my life. But when the same another patient comes with a chronic disease, then he has to be motivated. This treatment, what he has come for, if he gets admitted, it will not be, he'll be free from disease. He'll be only treated and then he has to continue for quite some time or lifelong also.
And also his buy-in required in,
Yes.
managing that
Yes.
hypertension.
So hypertension, diabetes, kind of these diseases where the treatment stays till the patient is staying. So this is what the patient engagement is, and once he understands his disease, he knows, yes, what he has to follow, when he has to come for the follow-up, how many, at what interval he need to go, some tests, and then how to remain fit. There will be counseling sessions also required. And once he has understood that, there is more chances he will continue with the treatment and he will not fall back thinking, oh, I was treated, but I was not cured. So right now, it is not only treatment, we are talking about curing the disease, making him or her understand the disease, and bring more patient satisfaction. Now, from just curing the disease, we are going towards patient satisfaction. We are more into feedback. Even Ayushman Bharat is all about feedback. It is one of the most important criteria which is going to come, and it is also there in the insurance. It is also on the hospital part, feedback. So feedback will only come when the patient is satisfied with the treatment, satisfied what the clinician has told him, satisfied what he has paid for at the end of the day. So to turn now, then shared decision, yes, definitely. When the first part is covered, when the patient has been engaged, the second part comes shared decision making. So the patient and the doctor, they take a decision what exactly they need to do for the treatment of the disease. So I think it is pivotal in the coming value-based healthcare, because from just treating a disease, we are moving towards quality of the outcome, quality of the life, and the patient feedback. And that's going to be very important in coming days, not only in the corporate world, but even the government sector. And our Honorable Prime Minister, the way he has motivated the country for the Ayushman Bharat, where we are just bottom 40% has been covered with one of the best and one of the biggest universal insurance plan. So that's a big achievement, and patient satisfaction. To achieve that, definitely we have to be on the shared decision making. Thank you.
Certainly points to ponder over, Dr. Sareen. And Ms. Sugandha, if I may come to you, you are a soft skill trainer as well as a counselor.
Yes.
And in healthcare, especially, human resources is one critical part. And we are almost always short on skilled resources in healthcare to deliver care to the patients. How do you think skilling can play an important role in delivering value-based care?
First, let me be, thank you so much for being here. I'm here with so many doctors around me, and I'm sorry that I was late. I went into the wrong Park Hotel, to be very frank, so that's why it took me some time to come. Skilling is something you require not only in medical field, but in any field of work. And getting a skilled person is a challenge. Let me be very frank with you in that. And not only skilled, in the person who is skilled need to have a very open mindset, as well as maybe, what do I say, a mindset to learn new things. That is again an uphill task. But yes, skilling is something which is required. Like for example, our company, our organization, Caring Minds International, it started out as a mental health OPD clinic. But we realized that we are falling short of well-trained psychologists, counselors, and psychotherapists. So we opened an academia wing where we train students on various counseling as well as psychotherapies. So what we are actually doing is we are creating our own pool of skilled professionals who can be, who can come on board as and when it is required. So skilling is important, sir. And secondly, hospitals can think of a skilling unit where they can rope in professionals according to their requirement. If that can be adopted by all the hospitals, and of course, primary health care is something that we all are talking about when it comes to value-based medical care. And for primary health care, a skilled professional can, prevent the issues escalating. Thank you.
Thanks. I mean, now that we have had the perspective of the panelists, one common question for all the panelists would be like, do you think as a country, with medical inflation rising, we have medical inflation going up almost twice that of what the general inflation is going up, we should start adopting value-based care rather than just focusing on traditional fee-for-service model? I mean, I'll go in the same order that we started. Dr. Bhattacharya, may I start with you?
So India, for a very long time, has largely been following fee-for-service model. Now, what it has created is that there is overutilization of the services. It has created inefficiencies in the system, and definitely it has led to increase in the cost of healthcare. Indian economy is largely a value-based economy. And unless you deliver value in healthcare, the model will not survive. If you slowly move towards the value-based economy, value-based healthcare, it will serve two main purposes. First, the core of the value-based healthcare delivery system is that it will focus on the clinical outcomes. And that will lead to building a robust quality processes that will improve in the patient safety. In a nutshell, the care becomes patient-centric. At the same time, since the value becomes very important consideration, it will cut down on the unnecessary investigation, it will cut down unnecessary procedures, unnecessary medicines, unnecessary hospitalizations. So this will make the Indian healthcare system more affordable for the large sections of the community. I think that is why I feel that we should move to value-based healthcare.
Thanks, Dr. Bhattacharya. Dr. Bandyopadhyay?
Yes, I agree that this topic was going on. So I previously also told that if we seriously intending to prove the value-based service, first of all, in my opinion, it should be the healthcare system, at least region-based or zone-based, should be integrated in sharing data. And the standard of practice to be determined on basis of that, the outcome can be predicted, and also the cost and affordability can be defined. So last of all thing is that if we really want to focus on the outcomes, so we have to think of two things. Something is standardizing the treatment and also the cost and affordability section. And in case of cost and affordability section, government has a huge role to play, and also the private players. So in 2009, Professor Romarto Sen commented on something that is a costly misunderstanding that private healthcare sector cannot bridge the healthcare gap. So it is true, but it needs the time, because actually if you see, when in every organization's private sectors, I can only comment on, I don't know what things are happening in government public sector. In the sense, we are measuring few pathways, outcomes, how the things are. And the data that are actually deriving from this outcome, this is internally getting discussed in that group. But it is not getting shared with the other ways, other industries and everything. So if I want to conclude on it, then I would like to say, yes, we should go for the value-based outcome. And other paraphernalia to get this value-based outcome, successful venture and successful future, we need to think of it.
Thanks, Dr. Pinaki. Dr. Tripathi, if I may come to you.
I think at the moment, we practically perhaps no other option than to go for the value-based care now. Since long, we have been too obsessed with the hospital-based curative care. And I fully agree, as Dr. Bhattacharya mentioned, about excessive overutilization and many unnecessary interventions, the problems that could have been otherwise prevented. So if we keep all these in mind, the resources are very unevenly distributed towards curative care without the legitimate focus or legitimate need of the citizens for preventive and promotive care. If we focus more on preventive and promotive, And there is sometimes a perception that preventive promotive care obligation is only will lie with the government. It's not necessarily. So there could be corporate hospitals we can also think of instead of coming out of that hospital-based care provision. You can also think of having a total holistic kind of network, okay, trying to actually help the patient of today, but tomorrow he is no longer a patient, he is going to be healthy. So the term patient is an episodic term. So I am healthy today, tomorrow I will become patient, day after tomorrow I will be healthy again. So the obligation of the institutions, whether it is private or government, should also be commitment to the person who has visited my hospital today. But tomorrow also I have to keep in touch with that person and try to see he doesn't need a readmission, he doesn't need an admission either, okay, how we can minimize that. And there is also revenue in that area. If you engage yourself into the preventive, promotive, rehabilitative care, there is a lot of scope for revenue earning from there also. There are certain areas which remain very neglected, like the continuum of care. When you talk of value-based care, you also talk of, instead of fragmented care, you have to think of the holistic, one hand, of course, quality of care, but at the same time, so far in the hospital, it is care bundle, and also beyond that also the care cycle, okay? That means all sorts of care, preventive, promotive, curative, rehabilitative, that is the concept of care cycle. A patient, simple case of, there are a lot of case studies, simple case of a diabetic patient, for whatever reason he has landed up to my hospital. He was otherwise well controlled with anti-diabetes drugs. And for some emergency, he has visited the hospital, we have treated him well, he has recovered, and in the discharge certificate, during the hospital stay, he was switched to insulin. And when he is leaving the hospital, we again gave him a good number of oral antidiabetics, forgetting that the patient was getting some oral antidiabetics before he landed up. Without counseling the patient goes back, starts taking the new medicines prescribed, and also the old medicines. Within 7 days, within 3 days, he comes back again to the hospital. So what is lacking is this continuum of care, or the transition of care-related errors, problems that is not considered. So this is also the issue. We have already come into an era where there is a huge demographic shift towards the elderly. So the elderly care, how that can be also addressed much better through the value-based care. So time has come, we have to think all this, and it's a good thing that government has already started the journey, and I hope that more and more private hospitals, on one hand, the government hospitals, they are overburdened with patients. On the other hand, in the private hospitals, we accept or not, there is a lot of gap in the trust, okay? So we need to rebuild that trust and try to reach out to all citizens of the country, nation, with a level of good mutual relationship for benefit of all stakeholders. Thank you.
Thanks, Dr. Tripathi. Mr. Venkat, your thoughts?
See, in terms of in conclusion, with the medical inflation continue to rise, we must rethink our healthcare system. The shift of the fee for the service to the value based is not a just service possibility, because it's an urgent necessity also. Okay, by the high quality and cost effective care patient outcomes, we can reduce the financial burdens on our healthcare system to improve overall the healthcare of our populations. Let's move towards the future, for the value truly drives care. Thank you.
Thanks, Mr. Venkat. Dr. Sareen.
Thank you. Right now, as the Ayushman Bharat I'll talk about is following the fee for service. Fee for service is, again, we are dealing with the disease, and to treat the disease we need more hospitals. And these hospitals need to integrate with the insurance companies or so. It can be government promoted like Ayushman Bharat, or the private insurance companies also. But at the end of the day, we are trying to treat only the disease which is coming up in the society. So fee for service also is based on the incentivizing the payment system in terms of accreditations, like what kind of accreditations are there, and then the outcome based. What outcome is there post surgery, and to that or post any admission. So for that also there is a measurement criteria. It is all defined kind of. So health related outcome, this is one. Patient satisfaction, then readmission. Within 30 days of that, readmission is there. So these all are the criterias which are there in the fee for service, which is what we are following to make it more valuable. But the other is ki valuable system is what when we are targeting a population. How to make that population disease free, because the kind of load the country has. And if we see abroad also, USA, they are one of the biggest spender on the healthcare. But still the burden of disease is so much, they are also trying to come back from the fee for service to value based, where they are trying to make the society or make the population disease free. And they are also not trying only to treat the disease, because their spending on the healthcare is almost 70% of our GDP. Our GDP is $4.5 trillion and USA spends around $3.5 trillion on just healthcare. And from there, they are this is for the treatment of disease. But whether USA is free from the burden of disease? No, it is not. They have the highest number of chronic diseases patients with obesity, diabetes, and hypertension, this all. So what now they are following? They are trying to make the society disease free. And to do that, it is a population centric. They are not targeting disease, now they are targeting population. And that population, what it consists? It consists the kid who is just born to the person who is the oldest one in the society. So everyone is targeted, vaccination, then treatment, then those who are screened for various diseases. So screening is one of the most important thing what is in the value based. You have to screen the society, you have to screen the population. And wherever at the earliest try to control it. And by doing this, you are avoiding the hospitalization or admissions. So this is the target what brings in the value based system. In India also, how we are doing it? By integrating the wellness center. The Honorable Prime Minister, he has said that we are going to have 1.5 lakh wellness centers. These wellness centers are going to integrate with the Ayushman Bharat. And who is going to integrate it? It is going to be Ayushman Bharat Digital Mission. So the PHCs which are there next to your door, they know about you. They would be the care planner or the disease planner or the screening who will screen you, they will guide you, they will treat you. And then only they will escalate this to the higher secondary or the tertiary care if it requires. Not everyone is rushing to the hospital for the treatment. That is not the end. That is only to increase the burden. So right now, fee for services is increasing the burden of the disease on the society, whereas the value-based system will make the society free from the disease. And then only a healthier society is achievable. At the end of the day, the quality of life and healthy society, that matters. And that is what we are going to achieve with this value-based system. Yes, definitely, it requires massive infrastructure changes. It requires that each individual in the country is associated with one next to home kind of doctor or a physician, or a diagnostic centers which will screen the whole population for any disease. So in my term, I think, yes, the transition is required for the healthier society, but it will take time and a lot of integration or infrastructural things are still to happen.
So Dr. Sarin, you would be happy to know that, there is a certification-based incentive based on NABH, for example, for the government, for PMJY. But there's also a white paper that has been put up where the government is also looking at having incentives on outcome-based,
Yes.
readmission rates, other
That's
things.
five, that's what I said, five parameters.
Yes,
That is
five
the
parameters.
readmissions, then patient satisfaction, then quality outcome.
So out
So
of 15%, 7.5%,
7,
50%.
1.5% is this, and the 2.5% is accreditation based, bronze, silver, and gold kind of.
Yes, yes. May I come to you, ma'am? What would be your thoughts?
See, value-based medical care is a boon for somebody like me. In any medical intervention, the first thing, the first fear, the thought that comes to us is the cost. Either I fall back on my savings or I fall back on medical insurance. If value-based comes and when the medical, the charges are reduced, it's really, really going to help a common person like me. First. Secondly, on the flip side, I wonder, is it possible in a country like India where the population is increasing as I speak? So that is a big challenge for this particular prototype to be implemented. And I'm sure I was so heartened to hear Sir talking that it is going to be, and you know, the patient satisfaction is the priority. And I think I am in really good hands in medical medicine, you know, health-wise. But one more thing I would, as a psychologist, I have interacted with so many people. The general mindset I have realized is a doctor's credibility or doctor's skill is proportionate to the hefty fees he charges. Please correct me if I'm wrong. I think those on the stage will agree to this. Because, you know, I always hear, oh, Baba, that doctor, he charges some 2,000 bucks as consultation. He is the best in the city. So, to break this mindset among common people going to see a doctor, that is again the next challenge we all will have if we are going to implement this.
Yeah,
Right?
we had a demand-supply gap for many, many years.
Right.
That is getting addressed. I mean, your medical colleges seats have doubled.
Yes.
Both undergraduate and postgraduate,
Right,
more than
right.
doubled. So that
Okay.
that is getting addressed hopefully.
Cross fingers, like, you know, we have more good doctors to take care of us. And again, if the primary health services, if that can be streamlined, I think value-based medical care will automatically take off. Like, yeah, that's
Thanks.
my take.
Thanks, ma'am. So, yes, I think, yeah, we can stop. Thanks panel for simplifying value-based care for the audience, and thanks audience for being a patient. Sure.
Hello, sir. Can you hear us?
Yes, I'm able to.
So thank you, sir. I think for patiently listening. Hopefully, you found the panel, some of the thoughts being, and a lot of thoughts being, I would say, discussed useful. So it would be good to get your perspective as the think tank, as someone who is basically having a huge say in terms of how things are getting shaped up. So obviously the theme of the session has been value-based care, but it would be good to hear from you if that's one you would like to speak about, or is something about primary care as well.
Okay.
Open to you, sir.
Well, thank you very much. Am I audible?
Yes, sir. Loud and clear.
Thank you very much. So first and foremost, I've been very much enlightened by the esteemed panelists. You all are leaders in the profession, and we look up to you for ideas, for helping the government, helping the society to build a strong system. So thank you very much indeed, and it's an honor to be amongst you. This audience, I'm able to see the audience. A very warm welcome on behalf of you and the government of India. Let me divide my comments in two groupings. Firstly, on the topic of value-based healthcare, and secondly, a couple of important messages to you all in terms of the bigger policy ideas. So first and foremost, I think to me, and thank you that you panelists for refining my own ideas. Now I see the following characteristics of value-based health. First, a value-based healthcare must be driven by protocols. Evidence-based, agreed, broadly agreed protocols, and that takes care of the point that there cannot be too, like extreme variations in the way we approach healthcare or addressing specific clinical conditions. It's not easy to do it, but there are situations where we know the conditions where structuring for approach is much more precise. And I can take an example of, say, childhood diarrhea or pneumonia. There are situations where it may not be so precise. But in terms of working with even today's diseases like diabetes and hypertension, or anemia, which is even more widespread, I think we have a path to decide how to go forward. It becomes complex. Indeed, it does become complex when, the surgical muscles are being. I understand. But there is a space for standardizing care, and I think that is one thing. Hence, I think is as today's big business group, a lot of standardization is possible. It's happening as well. But then there are some areas where there is kind of a lot of subjectivity, and a very esteemed panelist said that here varies where you land. And I think for India to make value-based care as a way of life, we will need agreed pathways to clinical care. So we move from over-individualized, care to more standardized care, which takes into account evidence and changing evidence and so on. And on this treatment workflow, many illnesses, something like 500 of them. The second that to healthcare practice is truly going to the detail. And when we deliver, we do it standard. So I'll not dwell on it, but clearly that's the second pillar. The third pillar is like the Arjun, on the bird's eye, so to say, is on outcome. It's coming very strongly from the fact. The time has come that the outcomes are looked at and looked upstream to see what we can refine in terms of protocols, in terms of delivery, in terms of quality, in terms of, clearer decision making and so on, so that ultimate purpose of good health in terms of our outcome. So you all have said it, and I agree with the very important statement made by an esteemed colleague here that we can make a beginning on a voluntary basis. So I like this word to spread, that let's start looking at outcomes in our system. Let's begin voluntarily. And at some stage, we will see how the other approaches have to be. So that's the truly what about. But I want to bring in 4 more aspects to this. One, our care is fragmented, and they're all interconnected. To put up and forth, the quality, a lot of outcomes. Our care has increasingly become, rather fragmented. We have moved in some way to specialization, but then the connection between specialties are weak. It particularly applies in the tertiary care system, perhaps to some extent in secondary, perhaps more in private. But this pervades. The best care is an integrated care when we are all together, the cardiologists, let's say, and the diabetologists, and and so on. But I think those pathways, those connects are, I think it's needed.
So losing your voice a bit.
Sorry. Please do warn me when the voice is weak, because
yes,
I don't.
Sorry.
Is that better now?
Yeah, a bit better, sir. Thank you.
Much better? Yeah. Sorry for this. Is that almost optimum?
Yeah, better. Yes. Thank you.
Sorry, I apologize. So the fourth point that I was making was to bring in integrated care. I'm not as yet talking about bringing even Ayush therapies aligned with holistic health, but surely, dialogue between the teams is very much needed. More acute the condition, more complex the condition, that is missing, and a value-based healthcare would demand that. The fifth one is humane care, communication. It cannot be overemphasized. There cannot be a value-based healthcare system that is not respectful of my emotions, my overall, ability to connect with the system, that empathy. If this has to be an integral part. The sixth point that has been made very eminently, and I endorse and I return to that very briefly, is that it should get connected to all elements of care, including preventive and primary care, right? So let me give an example. If a more than a 30-year-old individual comes for care, I think it's almost mandated today, if not 100% mandated, that the blood pressure of this person should be checked, because 1 out of 3 Indians, and perhaps 1 out of 2 Indians in urban settings, close to that, may have in your clientele. So bringing in that element of prevention, secondary and primary, is an integral part of value-based. And I'm very happy that this issue has been rejected very nicely by the panelists, and thank you for doing so. And this brings in the common advice that one would like to give on the lifestyle, for example, good sleep, for example, even we extend it to yoga, perhaps, and so on, and food and diet, and avoiding things that are clearly bad, like tobacco, and of course, too much of the screen time is bad. Sleep is good. So I think bringing this element is truly value-based system. And last but not the least is affordability. We cannot have a value-based system which goes beyond rational cost, rational profits. A value-based system on scale of a society, of a state, of a nation, of a district cannot be the one which promotes property. It has to be a balance. I see but this is partly and clearly and a build up on what I heard from you. Let's work together to create a culture of value-based healthcare in India. I'll be available for this discussion with all the stakeholders, and thank you very much for bringing me today into this discussion. My second part is about the health system. In a way, all the 3 points that I make in this phase have been triggered by you all. Firstly, second point was humans. The third point was made with regard to primary health care in terms of the system development. So let me quickly dwell on where I see the responsibility from you as the chamber, as the collective of the industry. So let me quickly go over the first one. The first one is the infrastructure. India has, to begin with, about 1.4 bed per 1,000. 1.4 per 1,000 population. That's what we have today. This is about about 18 lakh beds approximately, or 19 lakhs. It doesn't matter. We have included also Ayush beds in this. So we are at 1.4. The national health policy advocated reaching more than 2 beds per 1,000 by this year. And that would mean that perhaps we need to add 8 lakh more beds even to reach 2 per 1,000. So here is an opportunity for all of you and the businesses and the private sector and the government sector and all the stakeholders. So that's a given. And adding another 8 lakh beds is a given. But now I push the frontier to Viksit Bharat. When we go in the direction of Viksit Bharat 2047, the clarion call by the Prime Minister picked up the imagination of the entire country, I would like to submit here then our expectations are much more optimum healthcare system. For example, human resources example I can give right away. We are, let's say about 1 per 1,000. Let's say with Ayush, we are about 1.4 per 1,000. We would expect to be 3 per thousand by 2047. Okay? Likewise, we would like to push the ratio of infrastructure toward that which exists in the developed nation. And let me give you those numbers now. For the global average is 2.9, double of us. Okay? 3, that's about 3 times. And higher income moves to about 5 bed per thousand. Now let's say even if you pitch to 3 per thousand, going up to let's say 2035, and we will talk about going beyond that later on, we need 20 lakh more beds. So for 1.4, add 20 lakh. So by 35, let's say 35 lakh beds. So my request to you is we start thinking about how to bring in additional 20 lakh beds. These are not developed nation norms, these are global average norms. The LMIC norm is about 2.3, this is 2.9, so we'll be just higher than LMIC. And how do we get to 3 beds per thousand? We will need an additional 20 lakh. So therefore, I make a request to you. Let's think about how this task can be done. Of course, a lot of it, this should happen in the public health sector. And there are big things happening. For example, critical care beds under the PMA BEAM scheme, we are looking at 35,000 beds being created in the next 2 years. We are already building pediatric care beds in the central government scheme post-COVID, about 15,000 pediatric care beds. That's a lot of 50,000 beds. And there are other programs that are doing. So it should happen in the public health space, but it should also happen in the private space, including the small hospitals, the nursing homes, in fact, even more importantly, perhaps, the mid-sized hospitals across our nation. Please remember that each bed generates about 3 to 4 direct jobs. And you can imagine if we add, let's say 10 lakh beds, you have 30 lakh jobs to 40 lakh jobs and so on. If you add, 20 lakh beds, you are adding close to 1 crore of jobs. And then 2 to 3 times number is the indirect job. So this is an important ingredient for Viksit Bharat in terms of the job, the productivity, but above all, also to be able to deliver the aspirations of people for healthcare. So please, let's discuss how it is to be done. There are schemes of the government, state and the union, which enable this, but I want to put this here, that we need to be creating infrastructure. Now I move to the human resources here. As you would know, that there has been, and mention was made, we have more than doubled the medical colleges to more than double from 387. It's now 2x, 103% actually increase. We have 130% increase for UG and PG seats, 52,000 to 118,000 seats. PG seats have moved from 32,000 seats to more than 75,000 seats. And more will happen. The Honorable Prime Minister has given a call for additional 75,000 seats put together in the next 5 years, and we would add for 10,000 seats this year. So now that's happening. Where is the challenge? The challenge is that overall number of doctors will improve from about 1 per thousand. And the developed nations typically have 3 per thousand. So there's huge scope for us to move for quantity and building quality into our training, where I need your effort, but I don't go today in that direction. But what I want to point out to is that the specialist insufficiency is an asymmetric situation. Overall, UGs, the pipeline is now building up. For PG, pipeline is building up, but the challenge is still significant. Let me give you an example, and this is last year's benchmark based on the pipeline for various disciplines. So let's say obstetrician. The annual supply of obstetrician till last year was about 5,000. We checked the new numbers. Currently, we have about 70,000, again last year. For a high income country, obstetrician ratio is 16 and our ratio is 5. If we have only the current pipeline of 2024, we will take 33 years to have enough obstetricians. Okay? For psychiatrists, if we have to be like high income country, even LMIC country, we have a huge challenge because our pipeline is relatively modest and needs to be built. For cardiologists to reach LMIC standards from about 0.7 per lakh to 2 per lakh, we will need 20 years to meet LMIC standards. And perhaps if you go to high income, which is a ratio of 6 per lakh of population, it will probably take more than 50 years. This is just to let you know that there's a huge scope for specialist training. Government will increase seats for sure, yes. And this impetus will come from the 75,000 seats. But then we will make efforts to do this in the public sector organizations. I urge you that you contribute in your own way within this envelope and more going forward by creating opportunities for DNB courses in private hospitals. Every bed of our nation deserves to be used not only for care, but for training of human resources, doctors, nurses, allied professionals. Very important. Today we are not discussing that. Allied professionals. So every bed. And you have the pathway available from the DNB system. Mid-sized nursing homes can contribute. We are going for, if you have, let's say, 30 beds for medicine and the food consultant, you can take 2 seats tomorrow. You are a medical teacher tomorrow. So again, more details, we're happy to share, but you know that this pathway exists. It's very liberal, it's very flexi. It's based on the premise that postgraduate training is by apprenticeship. It's not about classrooms, it's about being present in the casual emergency, being present in the ward, being present in the operation theater, and learning from your mentor, your senior, and each one of the specialists is a teacher to another potential medical specialist. That's how it is, and this operates very well. I would like you all to think about how much more capacity you can bring in from the private sector. It is very important. In doing so, and that's my last thing, when you bring in a teaching program on the part of the consultant with 8 years experience and one only 5 years experience post MD or MS, what you do is that you are also improving the care in your facility because you have a resident, you have a committed resident, and therefore it's a win-win situation. And I urge you to please contribute to the pool of specialists.
So your voice is not audible right now. I think lost you for the last 15 seconds.
Okay, I'm back.
Yeah.
Is that better again?
Yeah, back. Thanks. It is better.
There may be a fault somewhere here or there, but doesn't matter. I'm only making a pitch for National Board of Examination system to be invoked in all your hospitals that fulfill the criteria. To do so, please join this and you can contribute. Our estimate is that you can contribute to more than 30,000 seats collectively from the private sector over a period of 5 to 10 years. My third point relates to the Ayushman Bharat, which you mentioned was made. Ayushman Bharat PMJ, you mentioned very important point. I'm now talking about Ayushman Bharat, Ayushman Arogya Mandir, the health and wellness scheme. As was correctly pointed out, a silent revolution is being unfolded since 2018. 1,74,000 plus Ayushman Arogya Mandirs have been operationalized. There is a new provider in 140,000 of them. 1.4 lakh community health officers have been planted in sub-center level Ayushman Arogya Mandir. The PSC one is headed by the doctor. So a new health provider, mid-level provider, the silent revolution, 1,40,000 of them have been put in place. Having said that, you may be aware that now we are expanding from mother-child, maternal-child health and newborn care and communicable diseases to non-communicable diseases, to senior care, to eye, ENT, mental health, and so on and so forth, oral health and so on, the 12 packages. I would like you to have more discussion around it. All the health and wellness centers, Ayushman Arogya Mandirs, have a provision for more than 100 medicines. The sub-center one has 14 free diagnostics, free medicines I mentioned. The PSC has 63 diagnostics and 172 free drugs. We would like this facility to be the heart of the village, heart of the urban settlement. We would like all the beneficiaries, typically about 6,000 for a sub-center, to use these facilities for backache, to screening for tuberculosis, for anemia, screening for diabetes, getting treatment for diabetes medicines, and so on and so forth. And very rightly mentioned that a connect using the ABDM system, ABHA ID, the Ayushman Bharat health account, will connect for future to a digital highway for healthcare as well as to PMJ. So my plea is, see how best you can help us make the best out of it, spread the good word, build confidence into it. Community Connect is available through an institution called JAS, which is the involvement of the bhagidari of the local stakeholders. I think we are building, I must emphasize, we are building a future-ready, resilient, future-ready, Viksit Bharat primary healthcare today. We have not finished this work. The platform has been created, the packages are being layered, and action needs to be built up to make the best use of this and to please bring in the engagement of other stakeholders to make the, make the best use, shall we say, and the best benefit that can accrue to our society. Please remember, it's about prevention, it's about wellness, which is embedded in these centers. It's about secondary prevention by detecting early the cancers, and so on. And there, eventually, and soon enough, I do hope that the digital tools, including AI tools, will be very, very useful. And therefore, those of you who are innovators in this space today, please think about how we can have AI-enabled digital health solutions and products that can bring in quality, improve reach, and improve outcomes ultimately. That would serve a great purpose. I give a call for creating diagnostics, which are point-of-care diagnostics, very accurate, that use AI tools, and so on and so forth for this layer of very important layer of health system. 85% of the health burden is and can be addressed through the primary healthcare center. You made that point, and I endorse that, and I wish you to please help build India's primary healthcare system, both in rural and urban areas, which a developed nation that we would be deserves, and this should be achieved by, let's say, by well before 2047, because health and good health is an enabler of country's productivity, welfare, and economic might. And therefore, we being related to a sector which makes all this happen, healthy India will make developed nation India as a Viksit Bharat. And therefore, our responsibility is profound as we move in this direction. I'm very honored to be amongst you and to be able to share these ideas. And also, above all, the learning I accrued in the course of the nice panel I had the privilege. Thank you very much.
Thank you, sir. Thank you so much for your, I would say, not just enlightening, I would say very comprehensive, I would say, way you articulated, right from capacity building, right from, in fact, skilling, right from in terms of how we basically get some of the tenets of what the panel were discussing with regards to value in every aspect of healthcare and making it action. So because healthcare is something, as and Viksit Bharat has healthcare as one of the key focus areas, how we bring that to life. Thanks for all your guiding words, sir. And we would really be, I would say, looking forward to mull over some of those as we go ahead in the sessions today. And thank you once again on behalf of the panel as well as the chamber. We really are honored to have you, I would say, sharing your perspective. Thanks so much.
Thank you very much. काम ये कुछ गड़बड़ है तुम
Preet, you can just, I think, wrap
हेलो
the
मेरा
moderation
सिस्टम ही फेल हो गया
discussion.
कल को और इम्पोर्टेंट
Yeah, maybe over to you, Preet,
Yeah,
just to sum
thanks.
it up.
I think we were just wrapping up the panel and we were just closing up the panel. I'm not sure if we have any time for any questions, but I think maybe we can have the questions offline to the speakers, panelists, if needed, over lunch or whenever you can catch them. Thanks, everyone. Thanks, panelists, for the session. Thank you so much.
We have a pleasant task to perform. I request Mr. Shayantan Chatterjee, co-chairperson of the National Health Committee of the Bengal Chamber, to please mementos to the panelists and the moderator on behalf of the chamber. Thank you. We will take 5 minutes for the changeover. Our next session. It's a very interesting session on geriatric care. Age well, live well. A holistic approach to senior health and wellness. I request the moderator of the session, Mr. Anindo Das, Vice President, Marketing, Infinity Group and Jagriti Dham Senior Living, to please join us. I now invite the panelists to please be on the dais. Swami Uma Padonando, Campus in Church, Bose House Campus, Rishra, Cultural and Education Center of Ramakrishna Mission, Vidya Mandir, Belur. Dr. Dhiresh Kumar Chaudhary, geriatrician, founder and president, Bajpo. Mr. Devshankar Mukhopadhyay, CEO, Peerless Giving. Professor Dr. Arunangshu Talukdar, Professor and Head, Geriatric Medicine Treatment, Medical College, Kolkata. Dr. Tulika Bhattacharya, Socio-Behavioral Gerontologist. Ms. Maradhika Singh, Global Head for Workforce Planning, British Council. I request Mr. Das to please take the session forward.
Stay on the way. Shamiji is on the way, but we'll start the program. So thank you so much, Bengal Chamber, for organizing health tech event for, I think, for the last 7-8 years. And it's so nice that, Bengal Chamber is the only chamber of commerce who is at least thinking about the elder community. They are the only chamber of commerce. It's a round of applause to Bengal Chamber, to Shorbani and the entire team. At least they are thinking about this important, ignored vertical, this section of senior living. I have with me, some interesting panelists, and I'm very glad that few of them is there now in Kolkata, like Tulika and I forgot his. and Dev Shankarda, sorry, Dev Shankarda. So they just, Dev Shankarda stays in, in Gurgaon, and I think whenever I just told him about this program, and he just accepted and he came down. So without wasting much time, I'll just straight away start with, I have with me on my right, Dr. Orunangshu Talukdar. Dr. Onurangshu Talukdar is the professor and head geriatric medicine department, Medical College, Kolkata. He's also the chair of the Geriatric Society of India, Kolkata chapter currently. And thank you so much, Onurangshuda, for for accepting this particular proposal. And you have come here. You all are busy. But very, very interesting thing which I wanted to ask him, that India's rapidly, we all know that India's rapidly aging population is growing, so what are the key priorities in geriatric healthcare that needs immediate attention according to you? And the medical institutions and the policymakers, how they can work together for a more senior-friendly healthcare system. They can build a more senior-friendly healthcare system. So if you can share your insights on this. Thank you.
Thank you, Anindor. There are the two parts of your questions. The first part is the lacking and where we are now. And then how can we move further. So basically, honestly, I should say that the health care of the elderly is still neglected in our country. We consider the same treatment for an adult population like this. This is nothing but only the age is increasing. But this is not the real scenario if we wanted to do the best management for the elderly people. So this awareness is very much lacking, not only in the general population, the general people, also in our medical fraternity, among the doctors, nursing staff, among all the healthcare, and also the policymakers. Because when I just shared my story, then when we started the dedicated geriatric department in our medical college, this is the first department and the only department in Eastern India. So even most of our friends, colleagues, even the policymakers in the Shastro Bhavan, they surprised that why it is necessary. You have the medicine department, why this is necessary. So the management of the elderly is not the same like the management of these things. So if we wanted to fill up that gaps, that what is the necessary, that aging is not only the factor, there is some lot of physiological changes happen and lot of comorbidity coming up in their life with the passage of life. And there is a growing, there's everybody in our previous session also, the growing concern that there is increasing geriatric population in our country. Right now around 15%, 14 to 15% of our population. And believe it or not, it will be around 20 to 22% in next 15 years. So there will be huge elderly population will be, and we have to cater this. There is a huge gap in these things. First is I told that I believe that the awareness generation across all categories of our country through all types of people. Next is the resource build-up, because we don't have very limited. Till now, Government of India recognized MD geriatric medicine every year. Only 72 MBBS students can be accommodated in the MD geriatric medicine course. So we started this not more than, I am the one of chairman of this state, and I know not more than 300, 400 MD geriatrician till now within this area. But there is a huge gap. Moreover, the geriatric nurse is a specialized nursing practice. That is also very much neglected. There is very few centers, only in Nimhans, Bangalore, and some other few hospitals. They offer the geriatric nurses certificate course and the fellowship course. But that's also very much necessary, because the handling a dementia patient is not possible by the nurse which we see in our day-to-day, in our hospital day. They can't do this very well for the dementia patients. And these things is the resource build-up because unless and until you have the critical mass of the expert in the, as doctor, nursing staff and others, and also the other support staff, we cannot think about the how to proceed these things. And then there is there is some logistic gap also, that the elderly specific health facility is also a separate, not which we do not see in our common hospital area, because this is not the ideal. Honestly, this is the government service hospital, there should be the wide door, there should be hand grips and these kind of things in the hospital setup, and also in their old age home and all these things. So these gaps are very much prominent, and that will gradually as coming into the surface. So that is the first part. I think I can answer your question. And the second part, how can definitely the medical college, medical institution, health department and the policymakers, definitely this is one of the best forum. That's why when Anindra requested me to come here, yes, is the part to make the awareness generation among us. If you are the policymakers, you can give some inputs to our policy specialists or them. So by that way, if the more and more investment in the healthcare facility from the government sector and the private sector, that would be a much more beneficial for our elderly people. We should not consider them their death cases, but rather we should encourage to leave them with the dignity as long as they are living.
Thank you, Dr. Talukdar. And another question I have, that evidence-based medicine, we are seeing that it's playing some interesting role in the as a healthcare solution for the elderly. So evidence-based medicine, do you want to throw any light on that part?
Yes. As a science is always especially in the medical part, always we vouch for the evidence-based medicines. And medicines is not only the tablets, it's also the medical devices and all the instruments which we use. So in that way, each and every day we are coming the lot of medicines and the drugs, devices. And we have lot of myths and misconceptions. I can give you the one example, that when most of our family members advises our seniors not to go to the outside, don't do anything activity, live in your bed on these things. But evidence is showing that if an elderly person do the exercise routinely and regularly, he will live much more healthy and strengthened. And type of exercise and what type of activity, is it a aerobic or the resistant exercise, this kind of things. This is evidence shows us that this kind of therapy, non-pharmacological therapy and pharmacological therapy, definitely it will boost up the better care of our elderly people.
Thank you so much. So awareness, resource build up, logistics, these are the focus areas, we should be focusing on. And as doctor said about the evidence-based medicine part of it, I'll go straight to Dr. Tulika Bhattacharya. And thank you so much, Tulika. She also stays, in Delhi, and she was luckily in Kolkata during this point of time. And when I told her, she said that, okay, I will be joining the panel. And she's a socio-behavioral gerontologist. So the question I have for Tulika is, with your research on palliation and end-of-life care, what policy or societal shifts are needed to ensure dignity, comfort, and choice for seniors in their final years? That's the area, if you can throw some light. I'm sure you have done a lot of work in that particular segment. So your views on that.
So in this area, it is very essential that palliation and end-of-life care become mainstream. The policies are in place, but are we using those? So what can we do in the individual front? What does it mean for us? According to 2018 end-of-life care policy, people can refuse medically aided prolongation of life, but the quality of life doesn't improve. Even the quality of death and dying becomes questionable. So what can we do? According to this 2018 guidelines, people can prepare advanced medical directives. So what can we do? What do we do in advanced medical directives? There we mention what kind of medical treatment we would like to undergo when we might not be in a position to decide due to advancement of age or due to decline in the physical condition, whether we would like to go for artificial ventilation, whether we would like to refuse cardiopulmonary resuscitation, which is known as DNR, do not resuscitate. We can provide DNR orders. We can also mention whether we would like to refuse artificial hydration, artificial nutrition. So all these provisions are there. And if advanced directives are in place, then it becomes much more easier for the medical fraternity to take decision. But what if these decisions are not there? Then the family members and the doctors can become surrogate decision makers. Of course, it will be very challenging. Often the family members are not ready for this kind of decision. But it is challenging even for any kind of intervention, even for any kind of aggressive intervention like a surgery and all. But ultimately, the family members have to be explained, and ultimately they do agree, or at least they should be informed so that they can make their choice, whether they would like to go for palliation or not. So now the question arises, who will take these decisions? So it is, and who will spread awareness about these things? So it is the physicians as well as also the non-medical practitioners, for example, the NGOs, the caregivers, everyone as a society can do that, and like it is our responsibility so that we take initiative for preparing our own medical will. Another part of this thing is in order to make palliation and end-of-life care more mainstream, it is required that large amount of geriatric caregivers or dementia caregivers, as Sir was mentioning, these kind of structures are in place. Even for that, National Institute of Social Defense, through Ministry of Social Justice and Empowerment, they are providing 3 months geriatric care trainers. So these things are also in place. And in order to ensure dignity of older people, it is also essential that we as a society ensure the dignity of these caregivers also. Thank you.
Thank you, Tulika. But I think very, very interesting point, and I don't know how many people are working in this particular domain. I think we should work in Kolkata, something to, doctors like Dr. Talukdar, Dr. Chaudhary is there. Another point I wanted to know, because you have been working on a lot of global projects, how do you see, or how India can adopt some of the best practices which are happening in other parts of the world in terms of, creating a more age-friendly society? So I know it's a vast subject, but any viewpoints you have? I know you are working very closely with some international projects. So if you can highlight that.
So age-friendly society, the first thing, it needs to begin at home. We need to ensure that our homes are age-friendly. So what do I mean by that? So we can assess the home where we are staying, or whenever we are building a home, that it is constructed according to universal design's principle. Of course, many of us are staying in homes which are maybe 90 years old. So for that case, we need to see what are the structures which can be constructed, and for how long, how much modification is possible and what is not possible. So this kind of assessment, the earlier we start, the better. For example, the entrance of the house should have such space that it should be wheelchair accessible. Then, well, wheelchair, like even transition from one room to another room, those spaces should be wheelchair accessible. Then preferably the house should be in one level, or elevator facility should be available. There should be provision for increasing lighting inside the house. So these are the things that we need to begin with. Next thing is to have age-friendly environment, because no one is going to remain inside the house. People need to go outside the house. So whether the parks, the streets, the transportation system is age-friendly or not, we need to look into that. And what kind of modifications we can bring as a society, whether the park which is in our community, whether we can make it wheelchair accessible, skid-free. These are the things which we need to look into. Then, because once these things are in place, the homes as well as the environment outside the home, then people can socialize, which is another important component of age-friendly society. Often, due to lack of age-friendly infrastructure, people find it very difficult to even access basic healthcare facility. Also, other things which are essential for promoting healthy aging needs to be supported as a society. For example, maybe a farmer's market where sustainable food, where environmentally friendly foods are available. Then coming to the other part, where we need to ensure structures where older people can get provision to volunteer, to work, and also to mentor, because older people want to get involved with the society, so there should be provision for that. And lastly, there should be structures which should facilitate any kind of initiative which promotes aging in place. Aging in place as in aging within the community. So for that, even places like Jagrati Dhams are coming up, which can promote, which can facilitate people to stay somewhere nearby to their community, a place where like they know within their known community. So, or even the initiatives which I was mentioning, like geriatric caregivers training, dementia caregivers training. So all these kind of initiatives needs to be promoted and supported in every way in order to promote aging in place and age-friendly society.
Thank you so much, Tulika. A round of applause to Tulika for sharing so in-depth her inputs. I'll go to Shami Umapadanando, and he is the campus in charge of the Bose House Campus Rishra, a cultural and education center of Ramakrishna Mission Vidya Mandir, Belur. And thank you so much, Shamiji, apni এসেছেন আজকে আমাদের সাথে. And the reason for me, to bring him on the stage is because, they are doing some work in this particular area. So for the question I have for you, Shamiji, is, education, we all know that education plays an important role and in shaping a compassionate and skilled workforce for the elder care. So how do you see initiatives like, certified geriatric care and the nursing assistant course at Bose House campus, which you recently started, the need for it, and what problem it will solve in the society? If you can share your inputs on that particular angle from an education point of view. Thank you.
Thank you so much. খুব ভালো লাগছে. I want to talk in Bengali because Bengali is the sweetest language in the world according to UNESCO. First of all, I convey my regards, my best wishes from Ramakrishna Mission to all the dignitaries, all the guests for inviting me. প্রথমে একটা কথা আমি বলতে চাই, সেটা হচ্ছে আমি আমাদের বোস হাউস ক্যাম্পাসের দায়িত্ব নেওয়ার শুরুর দিকটায় আমি বিদ্যা মন্দিরের রিসার্চ সেন্টারে জয়েন্ট কোঅর্ডিনেটর হিসাবে এখনও কাজ করছি, কিন্তু তখন খুব ক্লোজলি কাজ করেছি। সেই পর্বে কাজ করতে গিয়ে আমার দু একটা খুব অভিজ্ঞতা হয়েছে, সেটি আমি একটু আপনাদের সঙ্গে শেয়ার করতে চাই, তাহলে আপনাদের কাছে খুব পরিষ্কার হয়ে যাবে যে আজকের দিনে এই জেরিয়াটিক কেয়ার কোর্সটার কি ভীষণ রকম গুরুত্ব রয়েছে। এবং আমার সঙ্গে এই ক্ষেত্রটায় আমাদের এই কোর্সটা শুরুর আগে ইউনিভার্সিটির, আমি একদম নাম করেই বলছি, ডাইরেক্টর রয়েছেন HRDC সেকশনের লক্ষ্মীবাবু। উনি ভীষণভাবে, প্রফেসর লক্ষ্মী শতপথীজি, উনি ভীষণভাবে আমাকে এনকারেজ করেছিলেন, মহারাজ আমি ইউনিভার্সিটির তরফ থেকে বলছি এই কোর্স আজকের দিনে ভীষণভাবে জরুরি। প্রধান জায়গা হচ্ছে আজকের দিনের শিক্ষা ব্যবস্থার একটা অন্যতম প্রধান সমস্যা যেটা দেখতে পাওয়া যাচ্ছে, দীর্ঘকালীন আমাদের এমন একটা অভ্যাসের মধ্যে দিয়ে আমরা গেছি যে কিছু ছাত্র অনার্স করছে, কিছু পার্টিকুলার সাবজেক্টে মাস্টার্স করছে, হায়ার এডুকেশন করছে, এবং সে সেই ফিল্ডার মধ্যেই ঘোরাফেরা করতে চাইছে। আর বাকি কিছু অংশের ছাত্র হয় ডাক্তারি বা ইঞ্জিনিয়ারিং দিকে যাচ্ছে। এই তিনটে মোটামুটি একটা সোসাইটির স্বাভাবিক ছবি, হয় ডাক্তারি, নয় ইঞ্জিনিয়ারিং, অথবা ওই প্রফেসরির দিকে। এই তিনটে হচ্ছে সাধারণ জায়গা। এবার এই যে দীর্ঘকালীন শিক্ষা ব্যবস্থা আমাদের বর্তমানে চলছে, এর ফলে কি হচ্ছে, আমরা আমাদের ত্রুটির কারণে ছাত্রদের মধ্যে যে কিছু স্বাভাবিক, তাদের যে জেনেরিক কিছু স্কিল রয়েছে, সেই স্কিলগুলোকে তাদের ভিতরে রয়েছে, কিন্তু আমরা সেটার জন্যে তাদের সজাগ করতে পারছি না। এর ফলে কি হচ্ছে, কর্মসংস্থানের যথেষ্ট স্কোপ রয়েছে বিভিন্ন জায়গায়, বিভিন্ন, এই যে জেরিয়াটিক কেয়ার একটা এমন অদ্ভুত জায়গা, কিন্তু এই ফিল্ডে করার মতন লোক নেই, ট্রেন্ড ওয়েল ট্রেন্ড পার্সন এই ক্ষেত্রগুলোই নেই। কিন্তু তার মানে কি কর্মসংস্থানের অভাব? না, কর্মসংস্থান রয়েছে, কিন্তু আমাদের ছাত্রছাত্রীদের মধ্যে সেই জেনেরিক স্কিলটা তৈরি হয়নি যে আমি আমার সাধারণ স্কিলটাকে এমনভাবে তৈরি করব যে আমি যে কোনো পেশাতেই খুব আনন্দের সঙ্গে, প্যাশনের সঙ্গে অংশগ্রহণ করতে পারবো। তার ভিতরের এই যে জেনেরিক স্কিলটা তৈরি হবে, সে তার পড়া সাবজেক্টটাকে এমনভাবে কাজে লাগাবে। একটা বাংলার ছেলে, সে স্বাভাবিকভাবেই প্রফেসরি স্কুল মাস্টারমশাইয়ের কাজ করার পাশাপাশি যদি একটা জার্নালিস্টের কাজ করে, সে তাহলে তার ভিতরের এই স্কিলটাকে ওইভাবে কাজে লাগাতে পারে। একটা ম্যাথমেটিক্সের ছেলে, সে যদি একটা এই ধরনের ক্ষেত্রে যায়, তাহলে সে তার প্রফেশনের মধ্যে যে ফিন্যান্সের জায়গা, সেটাকে স্ট্রং করতে পারে। এই যে সব অবস্থার সঙ্গে মানিয়ে চলা এবং নিজের ভিতরে জেনেরিক কিছু স্কিলকে কাজে লাগিয়ে অ্যাডাপ্ট করা পরিস্থিতির সাথে, এটার মতন ক্যাপাসিটি আমরা আমাদের ছাত্রদের এই মেন্টাল ম্যাপিংটা করে দিতে পারিনি। এই জায়গায় দাঁড়িয়ে আমাদের বারংবার মনে হয়েছে যে আমাদের বিদ্যামন্দিরের এত বছরের 1941-এ আমাদের এই কলেজ তৈরি হয়েছিল, আজকে 2025 সাল। এই সুদীর্ঘ সময়ের মধ্যে দিয়ে প্রথমে HS, পরবর্তীকালে গ্র্যাজুয়েশন, মাস্টার ডিগ্রি, এমফিল, PhD, বিভিন্ন সেকশন চলেছে, কিন্তু এই জায়গাটা আমরা দিনে দিনে দেখছি ভীষণভাবে ছাত্রীদের মধ্যে এই জায়গাটার অভাব রয়েছে। আমরা এর ফলে আমাদের প্রধান ইচ্ছা ছিল এই বোস হাউস ক্যাম্পাসের মধ্যে দিয়ে যাতে করে এদের এই জেনেরিক স্কিলগুলোকে ডেভেলপ করা যায়। তাই প্রথম জায়গায় হচ্ছে এদের জব ওরিয়েন্টেড কিছু এমন ট্রেনিংয়ের মধ্যে নিয়ে আসা, তাদের নিজেদের স্কিলগুলো সম্পর্কে সজাগ করা এবং দেখানো বাইরে কি কি ক্ষেত্রে তোমার কাজ করার স্কোপ রয়েছে, বাবা ওঠো দেখো কাজ করতে যাও, সেই জায়গাটার বিষয় তাদের সচেতন করা। এই নিয়েই আমাদের এখান থেকে আমাদের প্রচুর পরিমাণ বিভিন্ন রকম স্কিল ওরিয়েন্টেড কোর্স চলছে, যার মধ্যে ডক্টরবাবু রয়েছেন, ধীরেশবাবু, আরও অন্যরা রয়েছেন, এবং ওনাদের বিশেষভাবে কৃতজ্ঞতা জানাই, এবং আরও বাকি ওনাদের সমগ্র টিম, তারা এত সুন্দরভাবে এই জেরিয়াটিক কেয়ারের কোর্সটি ওখানে করছে এবং বিপুল সাড়া পড়ছে। তার সঙ্গে নার্সিং এবং যোগা, এই দুটিকে ওরা সংযুক্ত করেছে। আমরা এর সাথে আর্ট অ্যান্ড ক্রাফটের একটি কোর্স নিয়ে এসেছি। একটা সাধারণ ধারণা রয়েছে যে ছবি আঁকা শিখে তোর কি হবে, কিন্তু ছবি আঁকা শিখে ও যদি ইন্টেরিয়ার ডিজাইনিং শেখে, তাহলে ওটা ওর জীবন তৈরি করে দেবে। আবৃত্তি, রিসাইটেশন, অ্যাঙ্কারিং, এর ওপর ব্রততী পরম্পরা আমাদের ওখানে কোর্স করাচ্ছে এবং এরা সহজে ক্যাম্পাসিং দিচ্ছে। তাহলে আর্ট, কালচার, মিউজিকের ক্লাস হচ্ছে, তার সঙ্গে সঙ্গে কিভাবে মিউজিকের সাউন্ড ইঞ্জিনিয়ারের কাজ, তারাও এখানে কিন্তু ক্লাস করাতে আসছেন। সাইকোলজিস্টরা ক্লাস করাচ্ছেন যাতে আর্ট থেরাপিকে তারা শেখাতে পারেন। এগুলো যে নতুন নতুন দিগন্ত খুলে যাচ্ছে, আমরা এইখানে এই বিষয়টার ওপর এডুকেশনের সঙ্গে এই জায়গাটাকে সংযুক্ত করতে ভীষণভাবে চেষ্টা করছি। আমি ছোট্ট আর একটু 2 মিনিট সময় নিয়ে একটা কথা বিশেষভাবে বলতে চাই। আজকের দিনে দাঁড়িয়ে এই জেরিয়াটিক কেয়ারের সঙ্গে রামকৃষ্ণ মিশনের এই যোগসূত্র প্রথম তৈরি হলো এটা নয়। আপনাদের সকলের এটা একটু আমার বিশেষ অনুরোধ জানানো, সবাইকে বলা, একটু আপনারাও ভেবে দেখবেন। আমরা স্বামীজির বিখ্যাত একটি কবিতা সকলে পড়েছি, জীবে প্রেম করে যেই জন সেই জন সেবিছে ঈশ্বর। এর আগের দুটো লাইন আছে, ব্রহ্ম হতে কীট পরমাণু, সর্বভূতে সেই প্রেমময়, মন প্রাণ শরীর অর্পণ কর সখে এ সবার পায়। তারপর বলছেন বহুরূপে সম্মুখে তোমার ছাড়ি কোথা খুঁজিছ ঈশ্বর ইত্যাদি। এই কবিতার লাইনগুলোর সঙ্গে জেরিয়াটিক কেয়ারের একটা অদ্ভুত সংযোগ আছে, এটা আমি দু কথায় বলবো। ঘটনাটা হচ্ছে এটা 1898 সালের ঘটনা, 1898 সালের ঘটনা। 97-এ স্বামীজি বিদেশ থেকে ফিরে এলেন। 98-এর এই পর্ব, তার একটু আগে থেকেই এক যুবক, সেই সময় চারুচন্দ্র তার নাম, তিনি ভীষণভাবে স্বামীজির লেখালেখি পড়ে ভীষণভাবে প্রবুদ্ধ হন। 1900 সালে তিনি উদ্বোধন পত্রিকায় প্রথম এই কবিতার লাইন দুটি পড়েন। পুরো কবিতাটির সখার প্রতি কবিতার অংশ। সেই সখার প্রতি পুরো কবিতাটি প্রকাশিত হয় 1900 সালের উদ্বোধন পত্রিকায়। তিনি পড়ে ভীষণ রকম প্রভাবিত হন এবং উনি ওনার বন্ধু, তখন ইয়াং যুবক, কলেজে পড়েন এবং স্বাভাবিকভাবে নতুন কিছু করার উদ্যম তার মধ্যে প্রচণ্ড। তিনি তার বন্ধু দুজনে মিলে, যামিনী রঞ্জন তার নাম, এরা দুজনে মিলে সেই সময় ঠিক করে এই মন্দির তীর্থস্থানে প্রচুর বৃদ্ধ বৃদ্ধারা পড়ে থাকে, যদি তাদের সেবা করি। চারুচন্দ্র যামিনী রঞ্জনকে বলছেন, দেখ স্বামীজি কি বলছেন, সবার ভিতরে ঈশ্বর, আমরা যদি তাদের সেবা করি তাহলে এতেই আমাদের ভগবান লাভ, এতেই আমাদের পরম প্রাপ্তি। ভীষণভাবে যামিনী রঞ্জন এবং চারুচন্দ্র দুজন উদ্বুদ্ধ হয়। ওরা বেরিয়ে রাস্তা দিয়ে যখন হেঁটে যাচ্ছে তখন দেখে কাশিতে একজন মা মলমূত্র পরিবেষ্টিত অবস্থায় পড়ে রয়েছেন, বৃদ্ধা। তাকে বাড়ির লোক রেখে দিয়ে এসছে, কাশিতে মরলে মুক্তি হবে, তীর্থলাভে তীর্থপ্রাপ্তি হবে। ফলত স্বাভাবিকভাবে আর খোঁজ নেয় না, সে পথেই মারা যায়। এরকম শত শত মানুষ মারা যায়। ওই বৃদ্ধাকে ওই অবস্থায় যখন তারা দেখেন তখন তাদের মাথায় স্বামীজির এই কথাটা স্ট্রাইক করে। এটি 1900 সালের ফেব্রুয়ারি মাসের আশপাশের সময়ের মোটামুটি ঘটনা, যদি খুব সময়টা ভুল না করে থাকি। 1900 সাল, এটা আমি নিশ্চিত। এরপর তারা দুজন একটু ভিক্ষা করে ওকে গরম দুধ কিনে খাওয়ায়, তারপর হসপিটালে ভর্তি করে। এরপর একজন দুজন করতে করতে ওরা একটা বড় অংশের এই বৃদ্ধ বৃদ্ধাদের সেবা করতে শুরু করে এবং নাম দেয় পুওর মেন রিলিফ অ্যাসোসিয়েশন। পরবর্তীকালে স্বামীজি 1902-এ শরীর যাওয়ার একটু আগে আগে কাশি যান, ওদের কাজ দেখে ভীষণভাবে মুগ্ধ হন এবং উনি ওই ইনস্টিটিউটটার নাম পাল্টে করেন হোম অফ সার্ভিস। আজকের দিনেও বেনারসে হোম অফ সার্ভিস, কাশী সেবাশ্রম, অত্যন্ত বিখ্যাত একটি আমাদের প্রথম বৃদ্ধাবাস ওখানে শুরু হলো এবং স্বামীজি নিজে এই নামকরণ করলেন হোম অফ সার্ভিস। গরিব মানুষ, মায়েরা যারা বৃদ্ধ বৃদ্ধা, তাদের যাতে একটু একটু কেয়ার হয়, একটু তারা যাতে ভালো থাকে এবং আনন্দে শেষ দিনগুলো কাটায়। বেলুর মঠে আমাদের বৃদ্ধ সাধুদের থাকার জন্যে ওখানে আরোগ্য ভবন আছে, খুব সুন্দর কনসেপ্ট। আরোগ্য ভবনে বৃদ্ধ সাধুরা থাকেন, তার ঠিক পাশের বাড়িটায়, সামনের বাড়িটায় থাকে সদ্য যারা জয়েন করছে সেই প্রি প্রবিশনার্সরা। সাধুরা দেখছে, বৃদ্ধ সাধুরা যে যৌবনের উদ্যম, যারা নতুন মন নিয়ে আসছে, আর নতুন ছেলেগুলো দেখছে সাধু জীবন, পরস্পর পরস্পরম ভাবয়ন্তম, এই আর তদ্বৃদ্ধি প্রণিপাতেন পরিপ্রশ্নেন সেবয়া, গীতার বিখ্যাত। এরা ওদের সেবা করছে আর প্রশ্ন করছে, বড়দের কাছ থেকে তারা জ্ঞান নিচ্ছে, আর বড়রা ওদের দেখে বাকি দিনগুলো পুরনো স্মৃতিচারণ করতে করতে আনন্দে কাটিয়ে দিচ্ছে। এই কনসেপ্ট কিন্তু রামকৃষ্ণ মিশনের মধ্যেও রয়েছে। আমাদের এই ভাবটা ভীষণ ছিল, স্বামীজি নিজে এত অ্যাডমায়ারার ছিলেন, এত এই বিষয়টাকে ভালোবাসতেন, তাহলে আজকে আমরা সাধারণ মানুষের দ্বারে দ্বারে কেন এই সেবাকে পৌঁছে দিতে পারবো না? ধীরেশবাবু আজকে রয়েছেন, পুরো টিম রয়েছে, এনাদের জন্য আমরা এই সুযোগটাকে কাজে লাগাতে পেরেছি, এই প্রয়োজনটাকে মেটাতে পেরেছি। আমাদের অনেক রকম ওখানে প্রতিকূলতা রয়েছে, নতুন ক্যাম্পাস হচ্ছে, স্বাভাবিক অনেক রকম আমাদের সীমাবদ্ধতা রয়েছে। সেই সীমাবদ্ধতাগুলোর মধ্যে থেকেও আমরা আমাদের মতন করে চেষ্টা করছি, সবার সাহায্য সহযোগিতা নিয়ে। তা এর জন্যে আমি বিশেষভাবে আজকের এই অনুষ্ঠানে যারা রয়েছেন আমাদের সাথে নিয়ে, আমরা যাদের সাথে নিয়ে এগিয়ে যাচ্ছি, তাদের সকলের জন্য শ্রী ভগবানের কাছে আন্তরিক কল্যাণ প্রার্থনা করছি এবং সকলকে ধন্যবাদ নমস্কার জানিয়ে আমার ছোট্ট বক্তব্য নমস্কার।
ধন্যবাদ জানাই স্বামীজিকে, থ্যাংক ইউ সো মাচ। আমি চলে যাব আমাদের নেক্সট প্যানেলিস্টের কাছে, মিস্টার দেবশঙ্কর মুখোপাধ্যায়। সো হি ইজ দি সিইও অফ পিএলএস গিভিং। আমরা জানি পিএলএস নামক যে অর্গানাইজেশন আছে, তারা বহু বছর ধরে from Bengal and they have been doing a lot of work in the CSR aspect as well. তো দেবশঙ্কর দা, he has been there, মানে এডুকেশনের সাথেও যুক্ত আছে, and তো আমি মানে the question I have for you, Devshankar da, is, with your extensive experience in business transformation and social impact, how can corporate philanthropy and private sector engagement create sustainable models for the senior care and active aging? মানে আপনার ভিউ পয়েন্টটা যদি আপনি শেয়ার করতে পারেন, থ্যাংক ইউ।
বেশ, থ্যাংক ইউ ভেরি মাচ অনিন্দ। আমি বাংলাতে চেষ্টা করি বলার। প্রথমত সেটা হলো যে বাই 2050 1 out of 5 individuals in India is going to be a senior citizen. ভারতবর্ষে it would be wrong on my part to paint the picture with one color. একটু ডেটা দেখার দরকার আছে। প্রিডমিনেন্টলি আমাদের টোটাল যে CSR স্পেন্ডস হয়, যেহেতু কর্পোরেট কথাটা বলেছে, অত্যন্ত দুঃখের সাথে আমাকে এই কথাটা বলতেই হচ্ছে যে 2014 থেকে 2021 রাফলি অ্যারাউন্ড 1254 billion rupees has been spent in CSR in India, which is fantastic. However, 0.3%, not even 0.5%, has been spent on senior living or senior care. আর যেটা আর একটা ডিস্টার্বিং ট্রেন্ড, ইফ আই কুড সে সো, যে কয়েকটা লার্জ কোম্পানিজ বা ইন্ডাস্ট্রিজ এই ডোমেনে কাজ করে, তাদের কন্ট্রিবিউশন কিন্তু আস্তে আস্তে কমে আসছে। এটা একটা কষ্টের জায়গা। দ্যাটস পয়েন্ট নাম্বার 1। পয়েন্ট নাম্বার 2, 100 জনের মধ্যে যারা 60 বছর, যাদের 60 বছর বয়স হয়ে গেছে, সিনিয়র সিটিজেন যাদেরকে আমরা বলি, প্রায় 40 থেকে 45 জন এমন আছেন যাদের কোনো ইনকাম নেই। দে হ্যাভ নো ইনকাম। ধরুন আর 23 থেকে 25% এরকম আছেন যাদের বছরের ইনকাম 12,000-এর কম। তার মানে 3 জনের মধ্যে 2 জন আছেন যাদের প্র্যাকটিক্যালি কোনো ইনকাম নেই। এটা কিন্তু খুব কষ্টের একটা জায়গা। এক্সাম্পল দিই, ধরুন আমি একজনকে চিনি যিনি 1995-এতে রিটায়ার করেছেন, ইঞ্জিনিয়ার ছিলেন, নামটা বলছি না, সিমেন্সে কাজ করতেন, 35 বছর সিমেন্সে কাজ করেছেন, 1995-এ রিটায়ার করেছেন। হি ওয়াজ 55 or 56, রাইট নাও হি ইজ 86। যখন উনি রিটায়ার করেন তখন উনি তার প্রভিডেন্ট ফান্ড, যেহেতু প্রাইভেট সেক্টরে কাজ করতেন, প্রভিডেন্ট ফান্ডটা গ্র্যাচুইটি মিলে তিনি পেয়েছিলেন প্রায় 12 লক্ষ টাকা। এবার আপনারা একটু হিসেব করে দেখুন, যদি 30 বছর তাকে বেঁচে থাকতে হয় তার স্ত্রীকে সঙ্গে করে নিয়ে, হাউ ইজ দ্যাট পসিবল? আর একটা ডেটা দিই, আমার মনে হয় এগুলো জানা দরকার, এগুলো কনটেক্সচুয়ালাইজ করা দরকার। ধরুন তার কাছে একটা 40 বছরের পুরনো একটা মেডিকেল ইন্স্যুরেন্স ছিল, ন্যাশনাল ইন্স্যুরেন্স থেকে তিনি মেডিকেল ইন্স্যুরেন্স করেছিলেন, ওয়ান অফ দ্য পায়োনিয়ার্স। 40 বছর আগে তার মনে হয়েছিল যে 1.5 লক্ষ টাকা যদি ইন্স্যুরেন্স যদি তিনি করেন, তিনি এবং তার স্ত্রী, দ্যাট উড হ্যাভ বিন সাফিসিয়েন্ট, রাইট? প্রিমিয়াম বোধহয় 1000 টাকা বা তার থেকেও কম কিছু থাকবে। আজকে সেই প্রিমিয়ামটা, যেহেতু তিনি এখনো বেঁচে আছেন, 75,000 টাকা পেরিয়ে গেছে, এবং দ্যাটস গ্রসলি ইনঅ্যাডিকুয়েট। ওকে, তার মানে যেটা হয়েছে সেটা হলো এই প্রবলেমটাকে, এটা একটা সোশিও ইকোনমিক ডাইমেনশন আছে, কিন্তু সেটাকে কিন্তু মাথায় রাখতে হবে। আমরা ফিজিক্যাল এর কথা বলবো, ইমোশনাল কথা বলবো, ফাইন্যান্সিয়াল অ্যাসপেক্টটা কিন্তু ভীষণ ইম্পর্ট্যান্ট। ওকে, আমরা ব্লেসড, ভারতবর্ষে এখনও অনেক ক্ষেত্রেই, স্পেশালি রুরালে, তারা তাদের পরিবারের সাথে থাকে, কিন্তু আরবানেতে আমরা যেটা দেখতে পাচ্ছি এটা কিন্তু একটা বড় সমস্যা হয়ে দাঁড়াচ্ছে। এই জন্য বলছি, কারণ আমরা 1993 সালে পিএলএস গ্রুপ একটা সিনিয়র সিটিজেন হোম তৈরি করে, বরানগরে মিলন তীর্থ বলে, খুব বেশি লোককে নিয়ে নয়, 30টা ঘর আছে, 30 জন থাকতে পারেন। এবং 93 সাল থেকে আজকে 2025-এ প্রায় 125 থেকে 140 জনের মতো বিভিন্ন পরিবার থেকেছেন, মানুষজন থেকেছেন। এবং তাদের যখন আমরা দেখি, তারা সেই সময় মধ্যবিত্ত ছিলেন, কারণ সেই সময় হোমটা কিভাবে চলতো, 50,000 টাকা বোধহয় একটা রিফান্ডেবল ডিপোজিট নেওয়া হতো, 1000 টাকা বোধহয় প্রত্যেক মাসে খরচার জন্য নেওয়া হতো। এবং তাদের কোয়ালিফিকেশন যদি দেখেন, বা তারা কেন হোমে এসে থাকছে যদি দেখেন, বেশিরভাগ ক্ষেত্রে নয় তার পরিবারের কেউ নেই, নয় তার ছেলেমেয়েরা বাইরে চলে গেছে, বা তিনি আর তাদের বার্ডেন হতে চান না। মানে 85 to 90% কেসটা কিন্তু, আমি শহরের ক্ষেত্রে বলছি এটা। তো এই যে একটা বিরাট একটা গ্যাপ, আস্তে আস্তে এই গ্যাপটা যে বড় হচ্ছে, এটা যদি না আমরা বুঝতে পারি, আমরা কিন্তু একটা ভয়াবহ একটা সময়ের দিকে দেখছি, যেখানে আমাদের অ্যাভারেজ লাইফ স্প্যান বাড়ছে। ভারতবর্ষে এখন পুরুষেরা 78 বছর অবধি মোটামুটি বেঁচে থাকেন, স্ট্যাটিস্টিক্স তাই বলছে। মহিলারা আরও 1.5 বছর তার থেকে বেশি, ধরে নিন 80। কিন্তু এই যে 60 বছর অবধি বা 58 বছর অবধি কাজ করার পর এই যে দীর্ঘ সময় তাদেরকে থাকতে হবে, what are the support system that we have in place? Unfortunately নেই। কর্পোরেটস, আমরা যদি এক্সপেক্ট করি সরকারের তরফ থেকে প্রচুর স্কিমস আছে, কিন্তু বিশ্বাস করুন, আমি হলফ করে বলতে পারি আজকে এই পোডিয়ামে যারা বসে আছেন তাদের ছেড়ে দিলে, যারা অডিয়েন্সের মধ্যে আছেন, খুব কম হয়তো হবেন যারা বলতে পারবেন 3টের থেকে বেশি স্কিম। আর দ্বিতীয়ত, স্বামীজি যে কথাটা যেটা বললেন, কেয়ার গিভার, আচ্ছা, যার এক্সাম্পলটা দিলাম তিনি আমার বাবার এক্সাম্পলটা দিলাম, কারণ আই ক্যান রিলেট টু ইট। মানে কতটা ডিফিকাল্ট হতে পারতো যে 30টা বছর একলা থাকা, এটা কল্পনা করা যায় না। রুপি হ্যাজ ডিভ্যালুয়েট, মানে প্রচুর ডিভ্যালুয়েশন হয়েছে, ঠিক আছে। আর কোনো সোর্স অফ ইনকাম নেই, আস্তে আস্তে ইন্টারেস্ট রেট কম হয়েছে। সুতরাং there are many factors that has to be considered. শুধু বেঁচে থাকার জন্য যেগুলো থাকা দরকার, মানে অর্থনৈতিক সামর্থ্য যদি না থাকে, তাহলে ডিগনিটিটুকু থাকে না। ওকে। আর আমার যেটা মনে হয় সেটা হলো, কর্পোরেট হিসেবে আমাদের সকলের একটা দায়িত্ব আছে। আনফর্চুনেটলি ভারতবর্ষের 100 টাকা যখন স্পেন্ড করা হয় CSR-এতে, তার 50% স্পেন্ড করা হয় এডুকেশন আর হেলথ কেয়ারেতে, ঠিক আছে। তারপরে যেটা আসে, এনভায়রনমেন্ট আসে, আরও কিছু আসে। আর 0.3%, অ্যান্ড আই এম টকিং অফ ডেটা পয়েন্ট ফ্রম 2014 to 2021, 7 বছর 8 বছরের ডেটা নিয়ে বলছি। এটা কিন্তু এটা যদি ইনক্রিজ যদি না করে, তাহলে কিন্তু আমরা একটা বড় সমস্যার সামনে দাঁড়াচ্ছি। এবং স্কিলিংয়ের কথাটা স্বামীজি বা বাকিরা যে কথাটা যেটা বলেছেন, দ্যাট ইজ অ্যাবসলিউটলি নেসেসারি। আমি আবার নিজের লাইফ থেকে আর একটা এক্সাম্পল দিলে হয়তো এটাকে এনুমারেট করতে পারবো। সেটা হলো, আমরা যৌথ পরিবারে একসঙ্গে থাকি দিল্লিতে, গুরগাঁওতে, অ্যাকচুয়ালি অবাক হয়ে যাবে। আমাদের বাড়িতে 8 জন সিনিয়র সিটিজেন আছেন, 4 জন চলে গেছেন, 4 জন আছেন। আমাদের বিভিন্ন ধরনের সাপোর্ট স্টাফ নিতে হয়। একটা ছোট্ট এক্সাম্পল দিলে এটা কিন্তু ভুল হবে যদি এই এক্সাম্পলের বেসিসে আপনারা একটা কনক্লুশন টানেন, সেটা কিন্তু বলছি না। কিন্তু আমি যেটা বলার চেষ্টা করছি, আমি কোম্পানির নাম করব না, যেখান থেকে আমরা নার্সেস বা এই ধরনের মানে স্টাফ নিয়ে থাকি, তাদের বেসিক যে ধরনের ট্রেনিং দেওয়া হয় বা যে ধরনের অ্যাওয়ারনেস, যেমন ধরুন একটা দিন তার প্রত্যেক দিন ধরুন ব্লাড প্রেশার চেক করে তারপরে রিপোর্ট করার কথা, একটা দিন তিনি চেক করে দেখলেন যে কারোর একজন যার 95 বছর বয়স, তার ব্লাড প্রেশার হলো 60/30। এবার তিনি কিন্তু সেটা রিপোর্ট করেননি। সন্ধেবেলা যখন আমরা দেখেছি, যখন কল করেছি, তখন আমরা যখন জিজ্ঞেস করছি, হতে পারে হয়তো মেশিনের গন্ডগোল, হতে পারে তুমি 10 মিনিট হয়তো অবজার্ভ করার পর তারপরে আরেকবার চেক করবে, তার কিন্তু একবারও স্ট্রাইক করেনি। আমি যেটা বলার চেষ্টা করছি যে প্রচুর ছেলে মেয়ে ট্রেন্ড হচ্ছে, কিন্তু যে কোয়ালিটি মানে লার্নিং আউটকামসের উপর কিন্তু আমাদের একটু ফোকাস করতে হবে। হ্যাঁ, দরকারে এমার্জেন্সিতে যদি অক্সিজেনটা না দিতে পারে, যদি যে যে স্টেপসগুলো নেওয়া দরকার সেগুলো যদি সে না নিতে পারে, দেন ইটস এ কমপ্লিট ফেলিয়ার। ওকে, আমি কিন্তু অর্গানাইজেশনের নাম বললাম না, আমি গুরগাঁওতে থাকি, অর্গানাইজেশনটা বড়, প্রতিদিনের চার্জ হলো 1000 রুপিস। ওকে, প্রতি মাসে 30,000 টাকা করে এক একজনকে দিতে হয়। বাট দ্য পয়েন্ট দ্যাট আই এম ট্রাইং টু মেক, 30,000 ইজ নট এ স্মল অ্যামাউন্ট অফ মানি, নট এভরিবডি ক্যান অ্যাফোর্ড দ্যাট। কিন্তু এই ধরনের যে ছেলেমেয়েরা যারা ট্রেনিং করে যারা আসছে বা যাদেরকে ডিপ্লয় করা হচ্ছে, এই পুরো ইকোসিস্টেমের কিন্তু একটা বড় অভাব আছে। এবং এটা শুধু গভর্নমেন্টের কাজ নয়, গভর্নমেন্ট অ্যাকচুয়ালি খুব ভালো কাজ যে করে তাও নয়, বাট নানদিলেস আমার মনে হয় যে কর্পোরেট বা প্রাইভেট সেক্টরকে কিন্তু এগিয়ে আসতে হবে এই কাজটা করার জন্য। নালে কিন্তু উই আর লুকিং অ্যাট এ ভেরি ভেরি লার্জ প্রবলেম অফ হিউজ ম্যাগনিটিউড। দ্যাটস ইট।
Thank you, Debshankar Da. I think very, very important aspect, I think the corporates has to come forward. আমাদেরও জাগৃতি ধাম আমরা যে তৈরি করেছি জোকার কাছে, it's a corporate social responsibility project of infinity. And I think বেঙ্গল চেম্বারকে আমি বলবো, আমাদের CSR কমিটি আছে, CSR এর পোর্টাল তৈরি হয়েছে, সেখানে যদি এইসব কোর্সেসদের বা স্বামীজিদের যেখানে হেল্প লাগতে পারে বা বাঁচবো, অ্যান্ড দের আর লট অফ আদার এনজিওস যারা গ্রাউন্ড লেভেলে সিনিয়রদের নিয়ে কাজ করছে, তাদেরকে আমরা কিভাবে কর্পোরেটদের সাথে যোগাযোগ করিয়ে দিতে পারি আমাদের CSR কমিটির থ্রু দিয়ে, আই থিঙ্ক সেটা একটা আলাদা আমরা ডিসকাশন করব। I'll go to আমার নেক্সট প্যানেলিস্ট হচ্ছে ডক্টর ধীরেশ চৌধুরী, অ্যান্ড a well-renowned person, এই ফিল্ডে কাজ করছেন। হি ইজ দ্য ফাউন্ডার অফ বাঁচবো হিলিং ফাউন্ডেশন, অ্যান্ড বয়স্কদের নিয়ে প্রচুর বছর ধরে গ্রাউন্ড লেভেলে কাজ করা। তো ডক্টর চৌধুরীর কাছে আমার যেটা কোয়েশ্চেন, সেটা হলো যে উই আর অল অ্যাওয়্যার অফ যে একটা বড় অ্যাসপেক্ট বয়স্কদের, সেটা হলো যে এমার্জেন্সি। এমার্জেন্সি হ্যান্ডেল করবে কিভাবে, হুট করে এমার্জেন্সি হলে কি করা উচিত, অ্যান্ড একটা অধিকাংশ সময় এমার্জেন্সি নিয়ে তখন মাথা কাজ করে না, অ্যান্ড দের ইজ আ লট অফ ফিয়ার বাড়ির মধ্যে চলে। বাঁচবো কিভাবে হেল্প করছে, অ্যান্ড আমরাও নিজেদের বাড়িতে কিভাবে কি প্রোটোকল মেনটেন করতে পারি, সেই অ্যাসপেক্টটা আপনার যদি একটুখানি আপনি যদি শেয়ার করেন। আমি জানি বাঁচবো এমার্জেন্সির উপর ফোকাস করছে খুবভাবে, তো আপনার ভিউজ যদি আপনি শেয়ার করতে পারেন ডক্টর চৌধুরী।
আমিও বাংলায় বলবো, নিশ্চয়ই ইংরেজিতে বলার প্রস্তুতি নিয়ে এসেছিলাম, তবে ইংরেজি থেকে বাংলা আমার অনেক মনের কাছের, ফলে স্বামীজি সেই পথটা দিয়েছেন, সুযোগটাও দিয়েছেন। থ্যাংক ইউ বেঙ্গল চেম্বার অফ কমার্স অ্যান্ড ইন্ডাস্ট্রিজ যে আমাকে এইরকম একটি সম্মেলনে আমন্ত্রণ জানিয়েছেন। সেকেন্ড টাইম, গত বছর আমি এসেছিলাম, এবং অনিন্দ্যবাবুর সাথে আমার সম্ভবত সেই দিনই প্রথম ফিজিক্যালি আলাপ, এবং তারপরে আমরা কিন্তু যৌথভাবে অনেকগুলো কাজ করেছি ফর দ্য জেরিয়াট্রিক অ্যাসপেক্ট। তো বেঙ্গল চেম্বার সেই সুযোগটা করে দিয়েছে, এই যে মানুষের মধ্যে যোগসূত্র, এটা কিন্তু আমাদের কাছে একটা বড় বিরাট আশার আলো। তো অনিন্দ্যবাবুর কোয়েশ্চেনের উত্তর দেওয়ার আগে আমি ধন্যবাদ জানাই যারা প্যানেলিস্ট হিসেবে রয়েছেন। ডক্টর অরুণাংশু তালুকদার, যিনি একজন জেরিয়াট্রিকে একটা আইকন বলতে পারেন এখন, আমাদের কলকাতা মেডিকেল কলেজের হেড অফ দ্য ডিপার্টমেন্ট, সুপার স্পেশালিটি ডিপার্টমেন্ট, এবং স্বামীজি এসছেন, স্বামীজিকে প্রণাম। স্বামীজিদের সাথে কাজ করার সুযোগ, এটা আমাদের একটা বড় প্রাপ্তি, এবং অন্যান্য যারা রয়েছেন, এবং আমার আগের বক্তা খুব সুন্দর কতগুলো তথ্য তুলে ধরেছেন, খুব রিলেভেন্ট। এবং জেরিয়াট্রিক সেক্টরে এই বিষয়গুলো যদি আমরা আলোকপাত না করি, আমরা কিন্তু অন্ধকারে থেকে যাব। তো আমি একটু লিখি, তো নিজের একটা কবিতা একদম প্রাসঙ্গিক, সেটা দিয়ে আমি শুরু করছি। সেটাতেই একটা বার্তা আপনাদের কাছে যাবে বা চেষ্টা হবে যে আমাদের প্রবীণেরা আসলে কি আছেন এখন। তো আমার কবিতার নাম দুধ রুটি। বুড়োটা খাবার টেবিলে বসে বসে এক মনে দুধে রুটি চুবিয়ে চিবিয়ে চলেছে এক ভীষণ আমেজে, পরম তৃপ্তিতে। এরই মাঝে আয়ার চিৎকার করে হাঁক, শেষ হলো মেসমশাই, আর কতক্ষণ? কানে যতটুকু পৌঁছচ্ছে তাতে বেশ বিরক্ত বুড়ো। এইটুকু সময়ের এতটুকু খুশি থাকার স্বাধীনতাতেও হস্তক্ষেপ। এদিকে আবার বুড়িও আলাদা ঘরে খাবার শেষ করে বিড়বিড় করছে, কি জানি বাপু, এত সময় কেন লাগছে? বুড়োটাকে কি তবে লক্ষ্মী বেশি রুটি আর দুধ দেয়? প্রায় 90-এ পড়া বুড়ো, খাটো শোনে, দেখেও কম। আর বুড়িটা তো সেই কবে থেকে অন্য ঘরে, যেটুকু সম্পর্ক সে তো লক্ষ্মীকে ঘিরে। ছেলে মেয়ে দুটো দেশের বাইরে, তাও প্রায় বছর 30 গড়ালো। ওদের চেহারা, গলার স্বর, এমনকি মাঝে মাঝে নামটাও বিস্মৃতিতে চলে যায়। সেই লক্ষ্মী যে ভরসা তখন ওদেরকে মনে করিয়ে দেওয়ার, ঠিক যেমনটা দিনে কখনো মাছ ভাত, কখনো সবজি, আর রাতে ফিক্সড সেই দুধ রুটি। অথচ যৌবনে কি দেমাক আর অহংকারী না ছিল বুড়োটার। বুড়িরও কম ছিল না মোটেও। বাড়ি, গাড়ি, শাড়ি, গয়না, ফিক্সড ডিপোজিট, ফরেন ট্যুর, আর মাঝে সাঝেই ককটেল পার্টি। আর ছিল টাকা মাটি, মাটি টাকা বলা লোকটাকে পাগল ভাবা, আর দুধ রুটি খাওয়া তাচ্ছিল্যের বেশ কয়েকজন চাকর বাকর। জীবনের প্রায় শেষ সীমায় এসে পৌঁছনো বুড়ো বুড়ির এখন ব্যাংকে টাকা আছে, লকারে গয়না আছে, আলমারিতে দামি শাড়ি ঝুলোনো আছে, ড্রয়িং রুমে কিছু দামি সুরার বোতল সাজানো আছে, ফাইলে গর্বের ডিগ্রিগুলোর সার্টিফিকেট আছে, গ্যারেজে ধুলোর আস্তরণ পড়ে যাওয়া গাড়িটা আছে। নেই শুধু সেই দম্ভটা, হ্যাঁ আরও আছে বই কি, দুজনের পিল বাক্সতে বেশ কিছু ওষুধ আছে, দুটো ঘরেই রামকৃষ্ণের ছবি আছে, ছেলেমেয়ের পরিপূরক হিসাবে লক্ষ্মী আছে, আর লক্ষ্মীর বানানো রাতে দুধ রুটি খেয়ে ঘুমিয়ে পড়ার অভ্যাসটা আছে। এই হচ্ছে বর্তমান সমাজে আমাদের বুড়ো বুড়িদের অবস্থান। আমি ব্যক্তিগতভাবে বুড়ো বুড়ি কথাটা বলতে খুব একটা স্বাচ্ছন্দ্য বোধ করি না, কিন্তু এটা একদম বাস্তব থেকে তো এই যে কবিতাগুলো আমার একদম বাস্তবের অভিজ্ঞতা। আমি দেখেছি একদিন এরকম দুধ রুটি খাচ্ছে বেশ আমেজ করে দুজন মানুষ। এক গল্পটা পুরোটাই কিন্তু আমার একদম রিয়েল গল্প, মানে কবিতাটা। তো অনিন্দ্যবাবু যে প্রশ্নটা করলেন সেখানে যে প্রসঙ্গটা বলি, যে জেরিয়াট্রিক একটা কিন্তু শুধুমাত্র কোনো একটা ক্লিনিক্যাল প্র্যাকটিস নয়। জেরিয়াট্রিক হচ্ছে একটা ব্লেন্ডিং অফ কম্প্যাশন, অ্যাটিটিউড, স্কিল, প্রফেশনালিজম, ডেডিকেশন, এমপ্যাথি এবং কোলাবোরেশন। এত কিছুর যদি ব্লেন্ডিং না হয় তাহলে কিন্তু জেরিয়াট্রিক ইজ ইনকমপ্লিট। জেরিয়াট্রিক ওই চেম্বারে আসবে, ওই 15 মিনিটের বা 10 মিনিটের একটু শুনলাম, স্টেতো দিয়ে দেখলাম, আর একটা খসখস করে প্রেসক্রিপশন লিখে দিলাম, তাতেই আমার দায়িত্ব শেষ। ইট ইজ নট এ জেরিয়াট্রিক্স। জেরিয়াট্রিক্স পুরোটাই একটা আলাদা। স্যার এটা অত্যন্ত ভালো কাজ করছেন, এবং এই প্রসঙ্গে বলে রাখি আপনাদের এটা জানা উচিত যে রাজ্যের অনেক সময় আমরা অনেক নিন্দা টিন্দা করি, এগুলো এই প্রসঙ্গে আমি এখানে বলার কিছু নয়, কিন্তু এই যে সুপার স্পেশালিটি ডিপার্টমেন্ট যেভাবে কাজ করছে একটা হাততালি পরা উচিত। আমি নিজে দেখেছি যে সুন্দরবনের এক প্রত্যন্ত মানুষ যিনি একটা বিরল রোগে ভুগছিলেন, তাকে কিভাবে সারিয়ে দিয়েছে একটা পয়সা খরচা না করে। ফলে এই কাজগুলো তুলে ধরা হয় না, মিডিয়া হাইলাইটেড করে না এই কাজগুলো। কেন করে না জানি না, এগুলো টিআরপি নেই তাই করে না, কিন্তু এগুলো আজকের এই মঞ্চে এগুলো জানানো উচিত। তো যাই হোক, আমি যে পয়েন্টগুলো, আমি 10টা অবজারভেশন আমি তুলে ধরবো অনিন্দ্যবাবুর প্রশ্নের উত্তরে। একটা হচ্ছে, আমি এর গত 1 দশক আগে একটা কন্ডাক্ট করেছিলাম সার্ভে 203 জন প্রবীণ মানুষের মধ্যে, যারা সবাই অ্যাফ্লুয়েন্ট সোসাইটির। তার মধ্যে 199 জনের এক বা একাধিক রোগ ছিল, মাত্র 4 জন ছিলেন যারা কোনো রোগহীন, এক বা একাধিক রোগ ছিল। এবং 2011 সালের সেন্সাসে 8টা ডিফারেন্ট টাইপস অফ ডিসএবিলিটিস যেটা বয়স্কদের মধ্যে দেখা গেছে, একটা হচ্ছে স্পিচ, হিয়ারিং, সিইং, ইন মুভমেন্ট, মেন্টাল রিটার্ডেশন, মেন্টাল ইলনেস এবং মাল্টিপল ডিসঅ্যাবিলিটিস একসঙ্গে অনেকগুলো, এবং 5.7% অফ দ্য টোটাল পপুলেশন 60 অ্যান্ড অ্যাবাভ তারা কোনো ফ্যামিলি সাপোর্টের বাইরে বা বন্ধুবান্ধবের সাপোর্ট ছাড়া থাকে, এবং যারা সুপার এজেড অর্থাৎ 80 ঊর্ধ্ব তাদেরই সবচেয়ে বেশি এমার্জেন্সি কিন্তু হয়, অথচ খুব পরিতাপের বিষয় তাদের লোকবল সবচেয়ে কম। ফলে এই যে 80 অ্যান্ড অ্যাবাভ তাদের যে হিউম্যান রিসোর্স থাকা উচিত একেবারে প্রায় তলানিতে, এবং এই 80 অ্যান্ড অ্যাবাভের লোক সংখ্যা কিন্তু ভারতবর্ষে কম নয়। পরিসংখ্যান বলছে প্রায় 1,33,00,000 বর্তমানে 80 ঊর্ধ্ব, এবং প্রায় 13 লাখের কাছাকাছি মানুষ এখন 90-এর উপরে। আমার একটা স্টাডিতে 35% অফ দ্য এল্ডারলি পপুলেশন তারা পুরোপুরি কেয়ার গিভারের উপর ডিপেন্ডেন্ট, পুরোপুরি, এবং তার মধ্যে 99% কেয়ার গিভার বলতে কিন্তু সবসময় যে আমরা প্রফেশনাল কেয়ার গিভার, যে কোনো বাড়ির লোকও কেয়ার গিভার করতে পারে, কিন্তু আনফর্চুনেটলি 99% অফ দিস সেকশন তারা কিন্তু প্রফেশনাল কেয়ার গিভারের উপর ডিপেন্ডেন্ট। এবং যে আমার আগের বক্তা যিনি বললেন না, এই যে প্রেশার 60/30 কোনো অরিয়েন্টেশনই নেই, এটা জানাতে হবে, সেটা জানলে তবে তো তিনি জানাবেন, তার তো এই ব্যাপারটাই নেই, তিনি শুধু প্রেশারটা মাপতে হয় এটুকুনি জানেন, কিন্তু প্রেশারের কি মাহাত্ম্য, কি কখন জানাবেন সেই অরিয়েন্টেশনটা তৈরি হয়নি বলেই আজকে এই অবস্থা। অথচ পরিতাপের বিষয় হচ্ছে যে এখন নিডস প্রচুর, এই যে স্বামীজি বলছিলেন প্রচুর কাজের সুযোগ, অথচ আমরা তৈরি করতে পারছি না, অথবা তৈরি করলেও এমনভাবে তৈরি হচ্ছে যারা কোনো অরিয়েন্টেড না হয়ে কাজে নেমে পড়ছে। এটা খুব আনফর্চুনেট। আমরা বেঙ্গল চেম্বারকে ধন্যবাদ জানাই যে এরকম একটি আলোচনা এখানে করার সুযোগ দিয়েছেন, কিন্তু এইটা আলটিমেটলি একটা কম্পালশনে দাঁড়িয়ে যাবে, এমন একটা পরিস্থিতি দাঁড়াবে তখন আমরা কিন্তু তাকে কমব্যাট করতে কিছুতেই পারবো না, আমরা যদি এখন থেকে প্রস্তুতি না নিই। ফলে এই জায়গাটা কিন্তু ভীষণভাবে ইম্পর্টেন্ট। এবং একটা 44% অফ দ্য এলডারলি পিপল তারা তাদের যে অ্যাক্টিভিটিস অফ ডেইলি লিভিং তাতে লিমিটেশন, তারা নিজেরা করতে পারেন না, দে নিড সাপোর্ট ফ্রম দ্য কেয়ার গিভার্স। ফলে এই জায়গাটাতে একটা বিরাট ব্যাপার। অ্যাপ্রক্সিমেটলি 8% অফ দ্য এলডারলি পিপল আর বেড রিডেন, পুরোপুরি, এবং এই বেড রিডেনের মধ্যে মোটামুটি ভারতবর্ষে এখন দেখা যাচ্ছে প্রায় 44 লক্ষ প্রবীণ মানুষ বেড রিডেন, এবং এই 8%টা সবচেয়ে বেশি আরও গিয়ে দাঁড়ায় 19%-এর কাছাকাছি দাঁড়ায় এই বেড রিডেন পার্সেন্টেজ, যেটা আপনার সুপার এজেড সিনিয়রদের মধ্যে। ফলে এই বেড রিডেন পেশেন্টদের ইমার্জেন্সি ক্রাইসিস আরও বেশি হয়, অথচ তাদেরকে ট্রান্সপোর্ট করা, তাদেরকে নিয়ে যাওয়া, এমার্জেন্সিতে এসে নিয়ে যেতে হবে প্রপার ওয়েতে, সেই লোকবল নেই। ফলে এটা একটা বিরাট জায়গা। তারপরে হচ্ছে যে আমাদের অনেকগুলো এমার্জেন্সি, যেটা অনিন্দবাবু বলছিলেন না, আমাদের কিছু কিছু মানে অনেকগুলো মেজর এমার্জেন্সি আমরা কিন্তু অ্যাভয়েড করতে পারি আমরা যদি একটু অ্যাওয়্যার থাকি। এবং এই আমার আগের বক্তা বলছিলেন যে ফ্রেন্ডলি, এল্ডার ফ্রেন্ডলি সিটি, এল্ডার ফ্রেন্ডলি, কিন্তু আমরা তো এল্ডার ফ্রেন্ডলি হোম তৈরি করতে পারিনি। এল্ডার ফ্রেন্ডলি সিটি তো অনেক পরের কথা, যদিও কেরালায় হয়েছে এল্ডার ফ্রেন্ডলি সিটি, আমাদেরও এখানে চলছে, কিন্তু এল্ডার ফ্রেন্ডলি হোম সেটা অ্যাওয়ারনেসের অভাব। ফলে এই যে এমার্জেন্সি ক্রিয়েশন হয় তার মধ্যে একটা মেজর পোর্শন হচ্ছে জাস্ট শুধু পড়ে যাওয়া। এই পড়ে যাওয়া বা ফল, এই ফলটা দু রকমের কারণ হতে পারে, একটা হচ্ছে এক্সট্রেন্সিক, একটা হচ্ছে ইন্ট্রেন্সিক। ইন্ট্রেন্সিক হচ্ছে আমার নিজের শারীরিক কারণ, শারীরিক বিভিন্ন উপসর্গ সমস্যা, সেগুলো আমি যাচ্ছি না, কিন্তু এক্সট্রেন্সিক কারণ যেটা পুরোপুরি অ্যাভয়েডেবল, যেটা পুরোপুরি অ্যাভয়েড করা যায়, অথচ আমরা করছি না বিকজ আনঅ্যাওয়ারনেস। এবং আমাদের জানি যে আমাদের যে অ্যাফ্লুয়েন্ট সোসাইটি, তাদের মার্বেলগুলো পিচ্ছিল, আমরা আমাদের মেম্বার একজন ছিলেন প্রতি মাসে একবার করে পড়তেন, মাথা ফাটতো আর আমরা স্টিচ করতে যেতাম। তো বিকজ অনলি ওই পিচ্ছিল, এবং তারা ফার্নিশটা দেখেছেন, কিন্তু এটা যে নট এল্ডার ফ্রেন্ডলি সেটা তারা লক্ষ্য করেননি। ফলে এইভাবে কিন্তু আমরা যদি অ্যাওয়্যার থাকি তাহলে কিন্তু এমার্জেন্সিকে প্রিভেনশন করা যায়। এ সিগনিফিক্যান্ট এমার্জেন্সি সিচুয়েশন ক্যান বি প্রোভাইডেড বাই, যেটা তো বললাম, এল্ডার ফ্রেন্ডলি হোম। আমরা দেখেছি আমাদের এক্সপিরিয়েন্সে নিয়ারলি 70% অফ দ্য এমার্জেন্সি কেসেস যেগুলো বাড়ির লোক মনে করছেন এমার্জেন্সি, বাট দ্যাট ক্যান বি ইজিলি ম্যানেজেবল অ্যাট হোম যদি প্রপার ইনফ্রাস্ট্রাকচার থাকে, প্রপার ইনফ্রাস্ট্রাকচার ওয়াইজ যদি অর্গানাইজেশন থাকে, তারা কিন্তু এটা 70% কেস আমরা আমাদের নিজেদের, আমরা দক্ষিণ কলকাতা এবং সদ্য আমরা সল্টলেকে ইউনিট খুলেছি, তো আমাদের 18 বছরের এক্সপিরিয়েন্সে আমরা দেখেছি যে 70 থেকে 80% এগুলো আমরা এমার্জেন্সিটাকে বাড়িতেই ট্রিট করতে পারি। যেমন ধরুন সেটার জন্য কি লাগবে, একটা তার সঙ্গে ইন্টারাকশন, তার অবস্থা সম্পর্কে জানা। একদিন এক ডাক্তার গেলেন, আরেকদিন আরেক ডাক্তার গেলেন, তৃতীয় দিন তৃতীয়, তাদের পক্ষে সম্ভব নয়। বাট যারা অনবরতভাবে একজন পেশেন্টকে মনিটর করছেন, আমি ফরচুনেট যে আমি একজন পেশেন্টকে 20 বছর ধরে দেখছি, 20 বছরের ওঠানামা দেখেছি। আমার 70 এখন 90 হয়েছে, 60 এখন 80 হয়েছে, তাদের পরিবর্তনগুলো চোখের সামনে দেখা। সো আমি যেভাবে হাতের তালুতে আমার পেশেন্টকে জানি, অন্যজনের পক্ষে সম্ভব নয়। এবং সেইখানে এমার্জেন্সি ক্রিয়েশন, যেমন ধরুন সিওপিডি, স্যারের সামনে বলতে আমার একটু ধৃষ্টতাই। তো সিওপিডি, ক্রনিক অবস্ট্রাকটিভ পালমোনারি ডিজিজ, এইটা অনেক সময় এক্সাজারবেশন হয়। আমরা যদি বাড়িতে সেটা ম্যানেজ করতে পারি, ওয়াই ইউ শুড অ্যাডমিট দ্য পেশেন্ট। এবং পেশেন্ট যদি অ্যাডমিট করা হয়, সেক্ষেত্রে কিন্তু নোজোকোমিয়াল ইনফেকশন হয়ে সেটা ডিটেরিয়েশন গিয়ে অনেক ভেন্টিলেশন, তারপরে মারা গেছেন, এরকম প্রবণতাও রয়েছে। ফলে এই জায়গাতে আমরা, আর 2 নম্বর হচ্ছে আরেকটা ব্যাপার, সেটা হচ্ছে বেড অকুপাই যদি নন এমার্জেন্সি পেশেন্ট দিয়ে অকুপেন্সি থাকে, তাহলে এমার্জেন্সি পেশেন্টরা যাবেন কোথায়, সেটা সরকারি হোক আর বেসরকারি হোক। আর 3য় নম্বর হচ্ছে ইকোনমিক অ্যাসপেক্টেও, এই এমার্জেন্সি পেশেন্টের যদি আমরা বাড়িতে, যেটা সেরকম নয়, আমি বারবার কিন্তু বলছি, আমি কিন্তু হসপিটালের ভর্তি হওয়ার একেবারেই বিরোধী নয়, কারণ হসপিটাল ভর্তি হওয়া ম্যান্ডেটারি, কিছু কিছু সিচুয়েশনে ওগুলো তো কিছু করা যাবে না, কিন্তু যেখানে করা যাবে, যেখানে সেই ইনফ্রাস্ট্রাকচার রয়েছে, উই শুড অ্যাভয়েড দ্যাট। এবং ইকোনমিক্যালিও কিন্তু অনেক বেশি লাভবান। এবং তারপরে হচ্ছে যে সিনিয়র সিটিজেন যারা ধরুন এই 80 ঊর্ধ্ব বা 90 ঊর্ধ্ব একা রয়েছে, বা অনলি উইথ স্পাউস, যদি অ্যাফোর্ড করতে পারেন, আই অলওয়েজ প্রেফার তারা কিন্তু কমিউনিটি লিভিং, সেটাকে কিন্তু তারা অ্যাক্সেস করা উচিত, যদি অ্যাফোর্ড করতে পারেন। এবং এই জাগৃতি ধাম আমি এখানে বলে বলছি না, আমি গেছি, ওনাদের সঙ্গে অনেক দিন ধরে কাজ করছি। এটা একটা সুপার একটা রেসিডেন্সিয়াল ফেসিলিটি তৈরি করা হয়েছে সমস্ত দিক থেকে বিচার করে। ফলে যারা অ্যাফোর্ড করতে পারবেন, ওয়াই নট, তারা কেন নেবেন না? বাড়িতে এরকম আনট্রেইন কেয়ার গিভার, এরকম একটা ইনসিকিউরিটি, তার মধ্যে থেকে নিজের অ্যাংজাইটি বাড়ানোচ্ছে, এরকম জায়গায় যাওয়া অনেক বেটার। এবং সেখানে ইমোশনালি ভেবে লাভ নেই, আমার বাড়িতে থাকলো অথচ আমি তাকে কোনো সঙ্গ দিলাম না, আর কীরকম, এটা এই যে সেই বুড়ো বুড়ির মতো। তো এই জায়গাটাতে কিন্তু আমাদের খেয়াল রাখতে হবে। এবং জাগৃতি ধামের যেটা একটা অ্যাফোর্ডেবল সে ব্যাপার আছে, কিন্তু একটু লেস অ্যাফোর্ডেবল এরকম জিনিস তৈরি করতে হবে, অ্যান্ড দ্যাট শুড বি এন্ডোর্স বাই দ্য গভর্নমেন্টকে এন্ডোর্স করতে হবে। এই যে স্যার বলছিলেন না যে 0.3% আপনার হচ্ছে সিএসআরের, তাহলে একটু 1% 2% করলে কোথায় যাবে বুঝতে পারছেন, কতটা আমরা ডেভেলপ করতে পারবো। ইভেন 1%-এর লেস জিডিপি আমাদের সিনিয়র সিটিজেনদের ব্যবহার হয়। তাহলে এই জায়গাটাতে আমরা শুধুমাত্র এই ভাবনা চিন্তা করে শুধুমাত্র ঠান্ডা ঘরে পলিসি বানিয়ে হবে না, দ্যাট শুড বি ইমপ্লিমেন্টেড প্রপারলি এবং গ্রাসরুট লেভেলে। এবং লাস্টলি আমি বলবো যে এই ক্রাইসিস সিচুয়েশনটাকে যদি আমাদেরকে হ্যান্ডেল করতে হয়, দেন গভর্নমেন্ট, এনজিও, দ্যাট শুড বি কোলাবোরেটিভলি কাজ করতে হবে। এবং আমরা রামকৃষ্ণ মিশনের সাথে খুবই সৌভাগ্যবান যে এরকম একটা খুবই ছোট লেভেলে, কিন্তু আমরা যখন শুরু করেছিলাম তখন আমরা খুব দ্বিধায় ছিলাম যে এই কোর্সটা কি সেরকমভাবে জনপ্রিয়তা লাভ করবে, কিন্তু ওখানে সীমিত আসন আমরা দিতে পারবো না বেশি, অলরেডি 27, এবং তারা খুবই একজন আছেন বিএসসি নার্সিং করে আমাদের এই কোর্সটা করছেন। তো আমরা খুবই ভাগ্যবান এবং স্যারেরা আমাদের সাথে রয়েছেন, আর তার জন্যই আমরা করতে পারছি। প্রচুর ভালো ফ্যাকাল্টি। আপনাদের কাছে এই বার্তাটা দিতে চাই, যদি এরকম কোর্স আপনাদের কারো করাতে চান, জাস্ট হায়ার সেকেন্ডারি পাস করলে তাদেরকে আমরা ওরিয়েন্টেড করে করিয়ে দেব, এবং সেখানে জেরিয়াট্রিক যোগাও চলছে। এবং একটা লাস্ট কথা বলি যে আমি ব্যক্তিগতভাবে তো কিছু চাইছি না আপনাদের থেকে, কিন্তু সংগঠনগতভাবে আমি দুটো রিকোয়েস্ট করব আপনাদের এই মঞ্চে। একটা হচ্ছে যে রামকৃষ্ণ মিশনের ওই জায়গায় যে রিস্ট্রা বোস হাউস ক্যাম্পাস সেটা তৈরি করছে, রামকৃষ্ণ মিশনের ক্রেডেনশিয়ালিটি নিয়ে তো বলার কিছু নেই। তো আপনারা যে হাউস রয়েছেন তারা যদি একটু সাপোর্ট করেন, তাহলে আমরা কিন্তু এটাকে অনেকটা বড় আকারে নিয়ে যেতে পারবো। আর আমার ব্যক্তিগত সংগঠনে বাঁচবো, যেটা হোম কেয়ার সার্ভিস করে তার জন্য বলছি না, কিন্তু আমরা মাসে একটা করে সুন্দরবনে জেরিয়াট্রিক আউটপেশেন্ট ক্লিনিক চালাই, যেটা পুরোপুরি নিখরচায়, এবং প্রতি মাসে 100 জন রুগী ওখানে নিখরচায় দেখাতে আসেন, আমাদের ডাক্তাররা দেখেন, এবং আমরা 1 মাসের পুরো ওষুধ দিই ফ্রি অফ কস্ট, কারণ ওষুধ না দিলে ওখানে শুধু প্রেসক্রিপশন দিয়ে কোনো লাভ নেই। এই জায়গাটা যদি আপনারা যারা পারবেন একটু সহযোগিতা করবেন, কারণ আমরা একটা প্ল্যাটফর্ম মাত্র, কিন্তু বহু মানুষের সহযোগিতাতেই আমরা যা কিছু করতে পারছি। অনিন্দ্যবাবু আমাদের সাথে রয়েছেন, অ্যাসিওর করেছেন এবং বহুভাবে রয়েছেন জাগৃতি ধাম ইনফিনিটি গ্রুপ। বেঙ্গল চেম্বার কমার্সকে অনুরোধ জানাবো আপনারা যদিও পাশে থাকেন, এবং আজকে এই বিশেষ অনুষ্ঠানে মানে বিশেষ এরকম একটা কনফারেন্সে, এরকম একটা প্রেস্টিজিয়াস কনফারেন্সে বলতে দেওয়ার সুযোগের জন্য অনেক ধন্যবাদ।
ধন্যবাদ জানাই ডক্টর চৌধুরীকে। আমার লাস্ট প্যানেলিস্ট আমরা এন্ড উইথ রাধিকা কালকে উমেন্স ডে, সো শি উইল এন্ড the panel. The reason for me to bring Radhika di, because I have seen, আমরা caregiving নিয়ে বলছি, but she's part of British Council for a number of years, but the main reason for me to bring her on the stage where she can share her real-time experience of how she is taking care of her elderly father. I know Murthy uncle for a long time now. So the question I have for Radhika, what are the real-time challenges you are facing, Radhika, and what are the steps you have taken, to take care of uncle? And if you can share some insights, and I think those things, if we can also implement, and do talk about the book which you have written as well.
I'll do that. Thank you so much, Anindo. Thank you, Bengal Chamber. I feel a little bit out of place in such an August panel, actually. But it's fascinating and insightful, and thank you so much for having me here. At the British Council, one of the roles I play is, I look after workforce planning, and age is a protected characteristic for us. So the aging workforce, people who are older in the organization, how to make sure that they're not discriminated against, how to make sure that we are completely inclusive. These are things that I do look at. But on a personal basis also, I engage with older people on several scales. I mean, দুটো NGOর founder member বলতে পারেন. One is called Friends of Kolkata's Elderly Folk, which works with the homeless elderly of Kolkata. We run 2 homes where they are brought and looked after for the rest of their life, unless we are able to send them back to their houses. And I also am a founder member of Koshish the Hospice, which is located in Purulia, and which works with the rural populace, providing palliative care services as well as hospice services. So I've been doing this for a number of years, and I've been engaging with older people on several levels. So yes, I do feel somewhat qualified as a beneficiary, as a recipient of all the services and facilities that these policies encourage, to talk about the experience of somebody on the ground. সেখান থেকে আমি বলছি, আমার কাছে health is not just physical health. It is always emotional, mental, and physical health. And all 3 are so closely interlinked and interconnected. If one is not doing well, the other 2 will not do well. সেখান থেকে আমাদের ভাবতে হবে। Emotional health, এখানে কিন্তু পরিবারের বাড়ির ভীষণ ইম্পর্টেন্ট একটা রোল আছে। আমরা যদি আমাদের বড়দের, and it's not just parents and in-laws, it's our neighbors, it's our uncles, aunts, relatives, সবার সাথে আমরা যদি একটু টাইম দিই, একটু কথা বলি, then we will understand. ডক্টর ধীরেশ যেটা বলছিলেন, হাতের তালুতে সেই নলেজটা হওয়া উচিত যে এই মানুষটা, এই ইন্ডিভিজুয়ালের কি প্রয়োজন আছে। সেটা যদি আমরা না করি, then we are setting ourselves up for failure, and we are also, our own future is at stake, because we are going to be senior citizens tomorrow. তো সেখান থেকে আমাদের ভাবতে হবে। Mental health, equally important, but what are we doing for mental health? What are the provisions we have for ensuring that mental health issues, primarily depression, everything else, but loneliness fosters depression. How do we address that at the policy level? How do we address that at the home level, at the institutional level? These are thoughts. I don't have answers to them. I know that here in Kolkata, we do not have enough facilities for our older people, either in the emotional health area or in the mental health area. As for the physical health area, Well, I attended the session prior to this also, and I was listening to Wing Commander Sarin Raj talking about the importance of having people listen to patients in the hospital setup. এটা কিন্তু আমি দেখি না, এটা খুব ইম্পর্টেন্ট নিশ্চয়ই, কিন্তু এটা হচ্ছে না, পেশেন্টের কথা কেউ শোনে না। বারবার ওপিডিতে, ডায়াগনস্টিক সেন্টারে, হসপিটালে আমরা দেখছি সামান্য সামান্য জিনিস, অ্যান্ড অল অফ ইউ উড হ্যাভ ফেস দিস থিংস। একটা এক্সরে নিতে হবে, এক্সরে টেবিলে তাকে শোয়াতে হবে, সেই মানুষটা উঠতে পারছে না, আনট্রেন্ড টেকনিশিয়ানস, ওঠো ওঠো, ঠেলছে তুলছে টানছে, all you had to do was tilt the table a little bit. It was a tilting table. You spoke of insurance. Even now I'm in the consumer courts with an insurance company because of reimbursement. You know, বয়স্কদের হসপিটালে নিয়ে যাওয়ার কারণ এবং তাকে ভর্তি করার কারণ, it has to be looked at differently from my going to hospital for a certain requirement. Insurance companies take full advantage of clauses that are set up in a way that discriminates against older people. This has to be addressed. There's so many things like this. Looking at myself, what have I done with my father? My father is now 80 years old. He has been living with me for the last 20 years. My mother passed away about 15 years back of cancer. So we went through that journey together, and since then he has remained in my house. So there are a few things that we set up very early on in our journey, such as with my husband. You know, it's difficult when the wife's father comes and lives in the house. I've seen this happen to many of my friends. But it's not that difficult when the husband's father or mother comes to live, right? So this was something we addressed at the very beginning. We never discriminated between your father, your mother, my mother. We didn't. It was equal. And that has worked for us for all these years. Now we are a unit. And you know what? An old person, I've seen so many of them living with their children in the house, but they're living in the corner in one room. ওদের টাইমে টাইমে খাবার দিয়ে দেওয়া হচ্ছে, টিভি আছে, আইপ্যাড আছে, মোবাইল আছে, but the one thing that they're craving for, attention, somebody to talk to them and listen to them, is non-existent. Why are we so busy that we don't have time for them? যারা হিন্দি পড়েছে তারা জানে, প্রেমচন্দ said this so many years back, বুঢ়াপা বহুদা বচপন কা পুনরাগমন hai. If we can look after our children so well, why can't we look after our elders equally well? It's the same principles. Activities, communication, keeping busy, listening, paying attention to what they are saying. These are things we do with our children naturally, isn't it? If we were to do the same with our parents, then that's all it takes actually. তার পরের গুলো তো সবকিছু পলিসি লেভেলে আসবে, অনেক কিছু আছে ওই ব্যাপারে বলার, কিন্তু এখান থেকে আমরা সবাই শুরু করতে পারি. This is what I have done with my father, and this has worked for us. You know, and at some point, I think, you know, the power dynamics change. We've, all of us, everyone in this room, I'm sure I take the liberty to say this, remember those traumatic times when we've had altercations with our parents, when, you know, we didn't agree on something and we exploded, they exploded, all this has happened. I think personally that all of us here who are not yet at that stage are living with that repressed trauma. And we are now taking it out on our parents by ignoring them, not listening to them, or, you know, doing what we have to do as our duty, but not going beyond. When I realized this one day, I decided that I will set that aside. That's over. He was a father for the first time of an 18-year-old girl. That's it. That's over. It's in the past. Let me set that aside and let me live with him as an adult and treat him as an adult and be an adult also. So that day, the power equations changed, the dynamics changed. I no longer worry about what he will think of me if I come home late. If I have to come home late, I will come home late. Even at 50, that exists, by the way, the phone calls, you know, when I'm late. But yeah, now we've made our peace with these things. And as two adults, we really enjoy each other's company. That's what has made the difference. You know, because no longer do I feel like a child in front of him, or no longer does he feel like, you know, he needs to be an authority figure all the time. These are things that we have worked out over the years. And for this, coming back to Dhiresh Babu's kotha, hater talur moto chinta is so important. You know, to do this, you have to talk to each other, you have to share things, you have to hear stories. Coming to stories is the book. I wrote a book last year when he turned 80. I'm not promoting the book, okay? I'm trying to tell you why I wrote that book. It was because my father, you know, loved to tell stories, And আমরা ছোটবেলা থেকে অনেকগুলো গল্প শুনতে শুনতে আসছি, just as each one of you here have, you know. সেই গল্পগুলো আমার কাছে সব দিনই খুব ইন্টারেস্টিং, ফ্যাসিনেটিং লাগতো. So I was thinking what to do for his 79th birthday, and it struck me that this is a good way to put together something that the children of our family, future generations, will understand, enjoy, and perhaps, you know, one of them one day may think that I should do some research into the, you know, heritage of our family. So I wrote the book. But the book came out very well thanks to a wonderful publisher. It came out well, and it has sold out all its 2 editions so far. It's doing well, and my father is so happy. I mean, he doesn't say it out loud all that much, but I know that he is very pleased to have finally been acknowledged, you know. So for his, you know, for all the things that happened to him in his life, not everything was good, obviously, some good, some bad, just like that. You know, for those things to get validation from your children, that's what has happened. So that has been a really great experience for us. And maybe, no, all of us will not write books about it, but what we can do is we can hear, listen, and try to do things that will reach out and touch the hearts of our elders. And that's all it's about. Coming back to policy, I have to say, এখানে আগের সেশনেও আয়ুষ্মান ভারত নিয়ে অনেক কথা হয়েছে. Sadly, Ayushman Bharat, as far as I know, is not implemented in Bengal as yet, and that is a huge, huge loss for us. We want Ayushman Bharat. As a patient, as a caregiver, we want Ayushman Bharat to be brought in here. Our older generations are not financially stable. Just like you said, it's the same thing, you know. Insurance does not cover a lot of things. Insurance is not paid out in several cases. Old people are not set up for battling in the courts. They need that support, you know. And they also want their financial independence. They don't want us to pay for everything. They want to live on what they have saved and put away. And সেটা যদি না হয়, সেটা ঠিক নয়. So Ayushman Bharat is a policy which is required here, but it also requires proper implementation. I'm afraid that's not happening. If I look at the private hospitals on this list itself, well, I'm very sorry, I don't mean to offend anyone here. We have had good, wonderful experiences also, but sadly the number of unpleasant, sad experiences, needlessly sad, which could have been avoided, are equally high. You know, and there is no redressal mechanisms. I mean, they're there on paper, they're there in theory, but the one who shouts loudest hears. The one who cannot shout just goes ignored. You know, if you go into the public healthcare system, older people are lying on the corridors just like everyone else. There is no separate arrangements for them. That's not fair, that's not right, that's discriminatory. And it's not there in places like Delhi. I've taken my father to Deen Dayal in Delhi, and they have a proper senior citizen treatment system which has worked for us. Why can't we have that in Bengal? Why don't we have that in Bengal? Why must we always be, you know, children of a lesser god, as it were? So that's where I'll stop here, because these are things that all of us know, and I know we're running late as well. But there are, you know, while the intention is good, I do believe that there is much more to be done, and all of us together need to do it. So let's step up and come together to do it. There is a whole lot of things that need to be done. Addressing emotional health, you know, there's so many ways of doing it. So I'll stop on that note. Thank you.
Thank you, Radhika. I think, yes, I think.
Only one
yes.
comment before Radhika, you spoke really well. And it's straight from the heart. দুটো জিনিস বলে আমার মনে হয় যে বলা উচিত, যেহেতু সিএসআরের কথাটা উঠেছিল। ভারতবর্ষে টাটা ট্রাস্ট খুব ভালো কাজ করেছে এই জেরিয়াট্রিক কেয়ারে, সিনিয়র সিটিজেনদের নিয়ে। আর ন্যাশনাল স্টক এক্সচেঞ্জ ফাউন্ডেশন, ঠিক আছে, এরাও ভালো কাজ করেছে। যদি কখনো সুযোগ হয় তাহলে তারা যে কাজটা যেটা করেছে সেটা করবেন। এরকম আনফর্চুনেটলি খুব বেশি অর্গানাইজেশন নেই যারা করেছে। বাকি অর্গানাইজেশন নিজেদের মতো করে যেমন প্রচেষ্টা করার সেটা করেছে। আই এম শিওর অনিন্দ যে গ্রুপকে রিপ্রেজেন্ট করছে বা আমি যে গ্রুপকে রিপ্রেজেন্ট করছি তারাও কিছু করেছে। সব প্রচেষ্টায় সাধুবাদ জানানোর জন্য। তবে সবাই যদি এগিয়ে আসে, সবাই যদি কালেকটিভলি একটু যদি এগিয়ে আসে, তাহলে এই ডোমেনেতে কাজ করাটা সহজ হবে এবং ইম্প্যাক্টফুল হবে। থ্যাংক ইউ অনিন্দ।
গ্রেট।
অনিন্দ, আমাদের একটু ঘোষণা করে দিই, এজ ওয়েল লিভ ওয়েল। আপনারা যারা আছেন আমাদের বাঁচবো হিলিং টাচ ফাউন্ডেশন অ্যান্ড জাগৃতি ধামের জয়েন্ট কোলাবোরেশনে আমাদের কিন্তু একটা ইউটিউব চ্যানেল আছে, এজ ওয়েল লিভ ওয়েল, যেখানে আমরা কিন্তু বয়স্কদের বিভিন্ন অ্যাসপেক্টে ভালো থাকা নিয়ে আমাদের বিভিন্ন ভিডিও হয়। আপনাদেরকে রিকোয়েস্ট করব যে ইউটিউবে ওই চ্যানেলটি আপনারা সাবস্ক্রাইব করবেন এবং আপনাদের মতামত জানিয়ে বা কী ধরনের আপনারা আলোচনা শুনতে চাইছেন সেটা জানিয়ে আমাদেরকে সমৃদ্ধ করবেন। এজ ওয়েল লিভ ওয়েল আমাদের ভিডিও ইউটিউব চ্যানেলের নাম।
থ্যাংক ইউ, একটা জোরে হাততালি হয়ে যাক সব আমার প্যানেলিস্টদের জন্য। হ্যাঁ, স্বামীজি জাস্ট বলে আমরা এন্ড করে দেবো।
হ্যাঁ, আমি জাস্ট আলোচনার মাঝখানে একটা জিনিস মিস করে গেছি। এখানে পিয়ারলেসের প্রতিনিধিরা রয়েছেন এবং জাগৃতি ধাম অনিন্দবাবু রয়েছেন, বেঙ্গল চেম্বার অফ কমার্স রয়েছেন, সকলকে আমি বিশেষভাবে আমন্ত্রণ জানাচ্ছি আমাদের রিস্টার এই বোস হাউস ক্যাম্পাসে আসার জন্যে। এটি শুধু এখানে তো একটা দিক রয়েছে, এখানে আমাদের জেরিয়াটিক কেয়ারের ক্লাস হচ্ছে প্রতি শনিবার, তার সাথে আপনাদের সকলের জন্যে জানাই এই বাড়িটি একটি ঐতিহাসিক বাড়ি। সুভাষচন্দ্র বসুর দাদা শরৎচন্দ্র বসুর বাড়ি এটি। সুভাষচন্দ্র বসু মহানিষ্ক্রমণের আগে তার সঙ্গে এই বাড়ির সম্পর্ক ছিল, পরে জাপানি কনসুলেটরা এই বাড়িতে এসেছেন। ভারতবর্ষের জাতীয় আন্দোলনের সঙ্গে এই হেরিটেজ বাড়ির বিশেষভাবে সংযোগ রয়েছে। গঙ্গার ধারে অত্যন্ত ভালো একটি মনোরম জায়গা রামকৃষ্ণ মিশন কাজ করছে। আপনারা সকলে আসবেন, সবাইকে আমরা প্রতিষ্ঠানের তরফ থেকে আন্তরিকভাবে আমন্ত্রণ জানালাম কখনো কোনো সময় আসার জন্য। নমস্কার।
Sharvani, over to you.
I request Mr. Arnav Chakraborty from the chairperson of our People's Management Committee to please be on the dais and do the honor on behalf of Bengal Chamber. I request sir to please present mementos to the moderator and the panelists. To Mr. Devanshu Mukhopadhyay, CEO Peerless Giving. To Ms. Radhika Singh, Global Head for Workforce Planning, British Council. To Dr. Tulika Bhattacharya, Socio-Behavioral Gerontologist. Shami Umapadananda from Ramakrishna Mission Vidya Mandir. To Mr. Anindo Dash, the moderator of the session from Vice President Marketing Infinity Group and Jagriti Dham Senior Living. Professor Dr. Urunangshu Talukdar, Professor and Head Geriatric Medicine Department, Medical College, Kolkata. And Dr. Dhiresh Kumar Chaudhuri, Geriatrician, Founder and President from Bajbo. Thank you. Thank you. I request all the delegates and the panelists and speakers, please join for lunch. Session, showcasing promising health tech startups, AI in primary healthcare and well-being. I request the dignitaries to please be on the dais. Dr. Uttam Ghosh, Director Health Program from Bandhan Konnagar. Please. Mr. Deepak Daftari, Chairperson, IT Entrepreneurs and Startup National Committee of the Bengal Chamber, and mentor Webel BCCI and Tech Incubation Center, Director and CEO DD Web Vision Private Limited. I request the panelists to please be on the dais, the health tech startups from the Webel BCCI Tech Incubation Center, Mr. Sanjeev Dhara, CEO Health Boss, and Mr. Karthik Mishra, Founder and CEO Udaypad. I request Dr. Ghosh to please deliver the opening remarks for the startup session.
Good afternoon. It's my pleasure to be here. Thanks BCCI for inviting me in this session. Bandhan is an NGO and it was registered in 2001. And we are conducting many development programs in different states across India. And we are associated with BCCI for many years in supporting the startups as the incubation support. And today, the issue is quality care towards good health and well-being. And it is the third Sustainable Development Goal set by United Nations in 2012. And the target is to achieve it by 2030. Accordingly, different nations and different agencies are taking many steps to reach the goal through their contribution. Primary health care, we believe it is the backbone of the healthcare services of a nation. If we cannot strengthen the system of primary health care, finally, we will be unable to reach the Sustainable Development Goal. Inclusion of artificial intelligence in medical healthcare, of course, it is contributing a lot in diagnostic facilities and even analytical issues to plan for a better treatment in future, analyzing the patient health records, past health records. But the concern issue is, we are mentioning the primary health care, but all the modern facilities, or most of the modern facilities are absent in the rural settings, whereas more than 70% of our population resides. So we have to strengthen the primary healthcare system, and we have to make available and affordable all the modern facilities and the artificial intelligence in the rural setting. Then we can hope that we will be able to reach the Sustainable Development Goal. Otherwise, we will fail to reach our target. So, we are going to start our session. Our moderator, Mr. Deepak Parikji, is here with our two panelists. They are on a inventor, they are the startups, and they are supported by BCCI as incubation monitoring. So I am requesting Mr. Deepak Ji to start the session.
Thank you, Dr. Ghosh. Good afternoon, everyone. I think after lunch, these sessions are the most difficult to conduct. People with a full belly and a happy face find it difficult to concentrate. But I can assure you, after the end of the session, it will be our efforts to make you feel energized and make you feel that you did not waste the next 45 minutes of your life into listening pure Gyan. To give you a small background, Bengal Chamber of Commerce runs a dedicated tech incubation center with Government of West Bengal, Webble, and Bandhan Bank. The objective of the incubation center is to not only handhold promising startups, but to showcase Bengal. It's the general perception that nothing happens in Bengal. The perception comes from the industry, the perception comes from angel investors, the perception comes from VCs, the perception comes from fund houses. But the surprising part, and the reason I'm sharing this with you, is for all of you to realize that we are not in such a bad situation actually. I'll share one data statistics with you that most of the fund houses, the VCs who raise their funds, raise 60% of their fund money from old family money in Calcutta. So technically, if it's a 100 crore fund, they raise 60 crores exclusively from Calcutta, from the old established business families. Yet, there is a paucity of these investments for our startups from this pool of money itself. And this all stems from the perception, from the lack of initiative, and from the basic premise that we don't beat our drums well enough. The primary objective of the Tech Incubation Center is to change that perception that things are happening in Bengal. To give you a small example, 2 years back, we had a startup coming to us, a gentleman called Shovik Haldar. You all are aware of crypto and cyber fraud. You read about it in the newspapers day in and day out. There are softwares in the international market which cost a few crores just on a subscription basis. None out of India. And Shovik had this basic idea that I'm going to create a crypto and cyber forensic software, a product out of India. When he came to us, he just had an idea in his head. We believed in his idea. We do the annual tech summit in Bangalore. We took him there. The Honorable IT Minister was there. We all heard him. He took a lot of flack. He had to listen to a lot of negative feedback. But the key was to take that feedback constructively. He worked on it. He came back to Calcutta. He applied to the STPI Chunauti competition, won the first prize of 25 lakhs. Build his product from Calcutta, where the perception is nothing happens. Created a world-class product using that 25 lakhs and went again to Bangalore last August for the second edition of the Tech Summit and presented in front of 12 of the largest VCs in the country. 3 were interested in his idea. He now had a proof of concept. And 1 took it forward. And finally, last month, Shovik raised 4 crores at a 28 crore valuation. This is the idea and power of conviction and having the faith that if nobody's done, doesn't mean it's impossible. Nobody's tried it hard enough. I'm going to do it. And he showed. And today, his customers are some of the biggest government agencies which are in front of the camera and which work behind the camera. That is a moment of achievement. And he's created a software which nobody else, not even the big software companies, could create. And he's working wonders. He's working with almost all the government agencies. The reason of telling you this story is that you need to have conviction and faith in your idea and need to work whatever the world says. What people might say anything and everything about your idea, about your startup, about you, about the region you come from. That is not a barrier. Today we have 2 promising startups, again from the Tech Incubation Center. This is a health tech conference, so we bought 2 startups who have been with us for 6 months, who are trying to find their feet. We are trying to groom them. We are trying to show them the path. And it's a journey, and I will request all of you to listen to their story, because today they are here, tomorrow you might be sitting on the 2 chairs on 2 sides of me, and you might be the recipient of the next 4 crores or 5 crores or 10 crores for your idea. Sanjeev and Karthik, we'll do a session with few questions, then we'll take few questions from the audience. Try to keep your answers brief and concise, because I think after a lunch session, nobody wants to hear a lot of gyan. So I would request every answer, if you can limit to 2 or 3 lines, that would be a great service to the audience also. Tell us something about your startup. We'll start with Karthik, then we'll go to Sanjeev. So, Karthik.
Thank you, Deepak. Good afternoon, everyone. So, my startup is Udaypad. It's a yoga-based startup. Basically, we are the Uber of yoga industry. Means we are working the yoga services and individual in home and also for the corporate. And also we work for various NGOs, schools, and everywhere, wherever that wellness session is required. So our startup is there.
Thank you. Sanjeev.
So I am from Health Boss. Basically, Health Boss is a marketplace where we are trying to bridge the gap with the user and the service provider in healthcare industry in all the way, not only the doctors, diagnostic centers or hospitals, but also the wellness center, wellness related vendors. So it's a marketplace where user can choose the service providers according to their locations, budgets, and ratings.
So, my next question to both of you is why health, why wellness, why not something else? Why did you pick this particular segment for your journey?
Okay. So basically, my background, I did my MTech in machine learning. Then I worked in the corporate more than 10 years. So at the time of working, so I feel that there is very much gap in that health and wellness sector for the corporate people. So throughout the day, morning 8 to night 8, so we are only working in front of a laptop or computer. So there is no time for the health. But for taking the care of your own health and your own mental well-being is very much important. So that's why that idea came in my mind, and I want this culture, this wellness and physical activities should be in that corporate also. That means whenever at the time of work, so anyone whoever associated with the corporate, so they can practice or they can have some time in that office premises only. So that's why that idea I tried and it just clicked. I just now lots of MNCs and also government are working with us. So that is the journey. Thank you.
We started this when we see a lot of people struggling at the need of the hour, the golden hour, with lack of informations related to health industry. Sudden cardiac arrest, sudden health requirement, where to go, whom to call. So there's a lot of information, less informations to people who are not related to health industry. So our effort is to available lot of informations related to healthcare to all the Indians so that they can be useful at the time of need.
So, Sanjeev, tell us something about your journey. See, starting a startup is always a pain point. Especially in Eastern India, there's still a taboo in, if I am to say a controversial statement in some of the traditional families, that why not a government job or why not a secured private company job? Why do you want to do a startup? Why do you want to ruin your life? I'm just generalizing for the fun of the audience. Why a startup? How has been your journey? The backlash or the negative feedback which you faced till today. Could you share some of the inputs when you started and where you are today?
So we started this with a simple cause. When I find my friends, relatives always struggling with the information in healthcare industry. My wife is a doctor, so she encouraged me to build up something, which will help people. They don't have to ask each and every one for the need at the time of golden hour. So we started this with simple thought that we will put up a lot of informations so that it will help people. Later on, we tried to put other well-being portions into it. And initially, when we started building up, there are thousands of apps, healthcare apps. Somebody is concentrating on doctor, somebody on pharmacy. But we find that marketplace, as a marketplace where all the healthcare service providers can be there and showcase their specialty, rates, and advantages to the users. That is why we got the intention to build it up further. lot of negative came that it will not sustain, but still with the help of the mentors in the BCCI and the guidance, we have reached that we have completed the initial app, and now we have started listing the providers, and we also have 1,60,000 customers base in our app right now.
Karthik, your journey, the same question.
Okay, so as per my journey, so whenever I just started my career, so back 2013 or 2014, so I just already involved in my personalized work, means I very much dedicated to my work, so I throughout the day I just work, but sometimes after some certain times so I just feel exhausted, so there is no time for my any activity, because previously I was involved in that volleyball tournament, means volleyball at my college level. So after that I just lost everything, means there is no scope for my any activity other than work. So I then realized that it's a very bad thing. So if anyone, means if anyhow, if I can same thing, whatever I was in the school level or college level, this physical activity I can bring in my offices. So on that time only I just started to create a team in my office premises only. I just create a team for cricket team, football team. Then I again realized that it's a very good idea. So if this type of culture I can build just like as a company, so it can be a helpful for the corporate or any for NGOs or any for any group for anywhere. Okay. So now gradually I just started working on it. I just started building on the technology on it, and after that I just started to execute it on it. Now it's a full-fledged one service, so that anyone can grab from our the services. So anyone, means whoever just running any NGOs, any schools, college, anyone, so they can take our services and they can utilize it in a good manner. So it will be not only affect their corporate culture, but also it's a healthy work environment that corporate, and also that spirit, that team spirit will be also inbuilt. So in these services, so that's why our journey is in that way it's going on. So now it is only in West Bengal, so now we are just planning to expand it all over India.
Thanks, Karthik. So I am assuming both of you are bootstrapped, both of you are cutting corners, both of you are taking a lot of hit in your personal life and trying to do this from money which you've saved, from money which you are earning from side gigs. How difficult is it to sustain a startup when you've not raised funds, you've not got grants, and you're just starting up, and you need to do a lot of sacrifices, cut down costs on yourself, your family, your personal life, everything. How difficult is it to create something bootstrapped without money, without help, without external support?
So frankly speaking, that starting a startup is very difficult journey, because whenever just we are in that any work or any working life we have, so we just every month end we are just getting the salary, just we can easily survive. Okay.
But is it making you sad or happy, the struggle?
So now I am very much happy, because means although it's a bootstrap, but somehow at the beginning it was very much difficult to manage. So on that time, whenever I was starting up, so lots of cost is associated. So whatever the salaries I am getting, 50% salaries, I am just involving that salary in my corporate, in the startup. So on that time to survive, I mean, in this real world, so it's very much difficult, because so whenever you are just going to for startup, so you have some certain amount of money you need to invest. So for building anything, means if you have any trainer also, or anyone who will be working for you, so you need to put some money to him, because otherwise why he will giving his 10 minutes of time in your or in your work, so in your passion. So that's why at the beginning it was very difficult. Now also it's not so easy, because now I am just running whenever that 50 plus employees are working with me, so every month I need to take care for them. So it's very difficult, but although it's the journey is very much interesting, but let's see, hope for the best.
Sanjeev?
So as you said rightly, starting a startup is really difficult. But when I started this, it was not meant for a huge big business. We started this just to make a lot of informations to help people. And later on, we think that it can be scaled to a business. And then we started thinking. So far, I am the CEO, I am the marketing manager, I am the sales manager. Because initially, when you start, you will not get fund until unless you start getting revenues. So up to that stage, you have to make your own. Most of the startup does with their savings, and it is very much required. When you do spend your savings, you are very cautious. You go through that journey which helps in future. So I believe it's this the system, and with the help of the mentors, you can groom up and scale it up later on.
So let me make it a bit more difficult for you. How difficult is it to put the pressure which you face on your families, because somewhere down the line, because of your startup, because of your investments, because of your struggles, your family is also a part of it. So how do you cope up with the family pressure of convincing your dream, your idea, and taking them along with you for the sacrifices which you are doing on a day-to-day basis?
See, most of the people who does job as well as try to build up a startup, the time is the main factor. So you tend to get involved more into the startup. So throughout the day, you visit your potential clients and different offices, and in the evening you start working on the ideas you have got. And obviously family complains that time, but my better who is a doctor, so what I did is I involved her into my business, so we spent time together to build it up. So for me it is not a challenge. Family is with me building up this particular app, so I'm lucky in this case.
So as with any startup, God forbid this fails, we all have our moments of faith, or we have our moments thinking that what if things don't turn out the way? Have you thought of a safety net, a backup option?
See, when we started this, we did not think of scaling it up to a big business. But right now, when a lot of money is being put in, yes, definitely we have a backup plan. Like if this particular startup doesn't work, then with the same subscriber base who actually faithfully enrolled, or the people who faithfully believed on our ideas and came in, so we will be diverting it to some other part of healthcare, and definitely it will click, not with the information only. So we are thinking of building up a AI app parallelly, which is going on, where he was talking about rural development or rural part of healthcare. So we are also making an AI app parallelly. Maybe we will be integrating it later on with this particular app. If it doesn't click, then separately, where a village girl or a woman can just pick up on the AI, that is what are the problems they have, and app will suggest that these are the probable things you might have, or these are the probable tests you might do, but do consult a doctor. So that kind of AI we are building just to keep a backup.
Thanks, Sanjeev. What's your backup plan, Karthik?
So my answer is will be little bit different. So as per that, human civilizations will be there, human beings will be there, so health will be there. So always there is a chances to how we can do better for the society in their health sector. So now in the modern age in AI, so lots of things now, not lots of technologies are coming. So
what's your backup plan if nothing works?
So if nothing works, so my core sector is my software technology, so I will be strict on it.
So you've not thought an alternative to your startup? You've not thought that you will do the startup, but not something related to it?
I'll check. So I don't have such type of backup plans as of now. So as for my understanding that as per that health sector will be there, so there will be always chances, and we can do different things. Lots of things we can try one by
Good.
one.
Because when you say I don't have a backup plan, that gives a lot of assurance to a VC or an angel that their money is safe, because you're not looking for a runaway path. Good to know that. So coming to my next question, are you looking to raise funds? If you're looking to raise funds, what is the journey going to be in the next 1 year?
Certainly, I am looking for funds, but as not necessarily. But for modern day technology sustainability, we need to make a good technology stack. So for that, obviously, I required funds, and also for the trainer, whatever the trainer is associated with us, for their training perspective, and also to make them more aware and more certifications for this trainer is, and also to create more studios or anything that uh, prospective we required funds. So certainly it's not particular figure I can't find out, but certainly we can discuss about it.
Sanjeev, looking to raise funds? Yes, no. If you're looking to raise funds, what are you going to do with the funds? Where do you see yourself 1 year down the line?
Definitely, we are looking to raise funds. Right now, development requires fund and marketing and onboarding users as well as service providers require funds. So the amount is not yet decided. We are still in a discussion with our mentors and guide for fixing it up. And but definitely, we are looking for funds.
What is it that you finally want to achieve with your startup once you're successful? Is it name, fame, money, glory, or good for the society? What is it? And I want an honest answer.
It must be fame and good thing for the society, because we started this with a motto to help people. And if that particular objective is met, I think by product, money and other things will come.
Karthik?
My answer should also be the same. First, I want to work for the society, and obviously I want to make money. That's all.
Which comes first?
Working for the society first.
Without money?
With money.
Do you think both go hand in hand?
Yes, if I work with my passion and if I do at the right time, right job, so obviously both I can serve. Means I can earn money and same time I can work for the society.
So currently you are only based out of Calcutta.
Right.
Which are the core areas you want to focus once you've captured the Calcutta market? What do you want to do next?
So first, I will be going for all other metro cities in all over India. So whenever it will be captured, I will be go the middle tier cities. And now at the last, I will be going for the rural areas. So for the rural area, we can't generate revenue, but we can work various NGOs so that we can spread our health awareness. We can do various camps that how they can more give time or they improve their healthy lifestyle. So for that, whatever that, if we want to can engage with any other corporate CSR activities, so by them, so we can just help them. So in their coming future.
Sanjeev? What are expansion plans?
So
You are doing in the
1 year, I'm looking that right now my subscriber user is 1 lakh. So my first goal is within 1 year, I should have at least 10 lakhs users using my app and taking help of the information provided in the app. That's my first goal. So if I can put the users, obviously providers will come. And if providers comes with the listing, I'll be generating revenue. And if I generate revenue and show some revenue and the prospect which I am currently working only for the Calcutta and West Bengal, then later on we can expand it to pan India, so then fund will come.
So before I open the floor to audience questions, I'm sure we have time for a few questions. Do we have time for a few questions? 5 minutes. So before that, I wanted to share 2 stories with you. And these are very relevant and maybe they will show you that it's never impossible to dream. And both the stories are from 2 totally diverse backgrounds. When I say diverse, one can be North Pole, one can be South Pole, and you'll relate to both the stories. I'm sure all of you have eaten products from Wow Momo, and we've all heard countless stories, read his articles in newspaper, Sagar Daryani and Vinod Homagai. When he had come to us, he had just 5 stores. Vinod and Sagar had 5 stores. Today they have 650 plus stores. They are valued at almost 2,800 crores. They are expanding every day. On an average, I think daily they open 2 or 3 stores on a daily basis. When we asked Sagar that in Calcutta, there is a momo stall in every corner of the city. Why momos? And this is where the beauty in simplicity lies. His one line answer was that I want to be the McDonald's of Momo. When you say that, the conviction shows, the clarity of thought shows, and it shows where you want to be. He said momos are sold in every corner of the city. I want to do it in less than 2 minutes in a packaged format in a clean and hygiene environment. Some of us offered him money. People think raising money is the most difficult part. Raising money is the easiest part. Living with that money is the toughest part. You'll be surprised to know that he was offered a check of 50 lakhs by some of us for a 10% stake when he was at, I think, 12 or 13 stores at a 5 crore valuation. And he barely had money, but he had the conviction to reject and give that check back in 2 days. And he said, and I'll quote, नहीं भैया अभी नहीं लेंगे, बड़ा बनेंगे, बड़ा करेंगे और बड़ा पैसा उठाएंगे. And then there was a tycoon, I remember, Sanjeev Bhikchandani was there, the founder of Naukri.com, Padmaja, the principal at Indian Angel Network, and Sagar was a volunteer in the speaker's lounge. And he pitched the idea, and Sanjeev liked it so much. And Sagar, being Sagar, always the great salesman, took Sanjeev along, landed in Delhi, and raised his first round of 10 crores at a 100 crore valuation at 36 stores. He had gone there to raise 5 crores. The demand was so huge, he had to increase it to 10 crores. That's the power of conviction. That's the power of clear thoughts. This is something to do with momos. The other diverse example, which will really prove and make you proud of what we are doing in India. There was a company called Agnikul, which some of us had come across 4 years back. In India, any satellite less than 200 kg, the wait time to launch is 2 years plus. When a big satellite goes in space, the smaller ones piggy bank. They came to us and they said, sir, we have one vision and one dream. We will cut down this 2-year period to 2 weeks. And we will build the first 3D printed rocket engine in the world with 0 moving parts. A rocket engine typically has 1,000+ moving parts. And he just had an idea from IIT Chennai, from Anna University Chennai. Some of us believed in him, gave him the money. Last year, a moment of pride, they were the first company in the world who developed that rocket and launched it from ISRO. When nobody could even think of it, people laughed at them, people joked at them. They not only built the rocket, they successfully launched it, a world's first 3D printed rocket engine with 0 moving parts. And they actually brought down the launch of a sub 500 kg satellite from 2 years to 2 weeks. They can print a rocket engine, one engine every 2 weeks. That is the power of dream. That is the power of clarity. That is the power of conviction. I think what makes us entrepreneurs is the will, power, and the strength that we should go on. Nothing is impossible. Impossible is just another word. So with that, I think we'll open the floor to the questions from audience. Any questions, please feel free. Try to keep your question objective. Any questions? Anyone for the panelists? I think we'll wrap up then. Dr. Ghosh, I would request you to give the closing remarks and we can wrap up.
Thank you, Deepak ji. BCCI has taken a noble responsibility in providing mentoring support to the startups. And out of many startups, we have showcased 2 startups here, and they have explained their activities. And actually, we have a dream to enjoy good health and well-being by 2030, and that means 2030. If you want to make it real, again I am saying we have to strengthen our primary healthcare system. If we only look towards the tertiary level healthcare system, sustainable development goal will not be achieved. And for availing the service, genuine information is very important. And there is a very lack of information we have experienced while we are working in the rural communities. They don't know where they will get the proper service, good healthcare service. So in many cases, they are being exploited. Sanjit Dhara, what he has invented is an information app. And through this app, people may get the proper information about the doctor services, cost, and everything. So my appeal to the investors and donors to come forward, to work together, to strengthen the healthcare system in the rural settings, the primary healthcare system, and to provide the funding support for the startups, for their growth and development. Thank you all.
Thank you. We have a pleasant task to perform. I request my colleagues from the Bengal Chamber to please present mementos to the panelists and the moderator on behalf of Bengal Chamber. To Dr. Uttam Ghosh, to Mr. Deepak Daftari, to Mr. Sanjeev Dhara, and to Mr. Karthik Mishra. I request the panelists please be on the dais for a photo shoot. Please, for a, yes, this side in the front. We will proceed towards the last session of today's Health Tech Summit, Biotechnology and AI in Healthcare. I request the panelists to please be on the dais. First, we would like to announce that Dr. Debashish Ghosh, CEO, Kolkata Biotech Park, he won't be able to join today due to some, he has some meetings. So I request Dr. Iman Mukherjee, Assistant Professor from Indian Institute of Information Technology, Kalyani, to please be on the dais and moderate the session. I request other panelists to please join us. Dr. Borun Kanta Bhattacharya, Manager R&D from East India Pharmaceutical Works Limited, and Professor Kaustam Panda, Head and Coordinator, Department of Biotechnology, GEV, University of Calcutta. Please be on the dais, sir.
Hello. So, good evening. After taking a heavy lunch, I think we are here to discuss about the bioinformatics and AI in healthcare. So, we know that the real fact that ছেলে আমার মস্ত মানুষ মস্ত অফিসার বৃদ্ধ বাবা মা রইল ঘরে যেন পাহারাদার. This is the real fact in everyone's house. almost everywhere. So this is very pathetic. In the pre-lunch session also, Dr. Chaudhuri wrote a nice poem. He has explained through his poem that how the elderly people are suffering. Dr. Mr. Mukhopadhyay, Dev Shankar Mukhopadhyay, he has mentioned that out of 3 people, almost 2 people, at least out of 2 out of 3 people are suffering from getting the good treatment in the healthcare. So these are the problems that we are facing. So now that is why we are here to discuss, and Bengal Chamber of Commerce and Industries has given a good opportunity to discuss this issue. So I would request Mr. Panda to highlight the issue that how AI can help in the healthcare.
Hello. So basically this is very technical, so I'll start with a very simple this thing because of the time is short. First of all, AI is nothing but an extension of what the human brain does. So let's not confuse on that. Now, what are the advantages of AI over HI, human intelligence? So first need to understand that. Why are we trying to access AI for healthcare, which the human brain has been doing all this while? The reason is that AI, unlike the human brain, has 2 facets which are exceptional. One is it can work like a perpetual motion machine. The human brain actually needs rest, it needs sleep, it needs break, it can be distracted, but a machine can work perpetually like a perpetual motion machine without any breaks. So that is going to accelerate things up. So one of the main reasons of accessing AI is to accelerate healthcare, which human intervention, we don't use the term impossible, but it's improbable for the human brain to accomplish. The second thing is efficiency. So with time, the shortening of time, the efficiency also is going to increase, because in AI you can integrate multiple human brains together, which one human brain does. So in a machine you can incorporate the facets of multiple human brains. So here 3 people are sitting out here. We have our individual brains with which we work through our own experience and our knowledge. But in an AI, we can integrate all these 3 brains together to function. So, and can make it multitasking. So it can multitask and do things far better in a more broad spectrum way. So simply said, I'll just give you an example of how this is going to change. We have all seen what has happened during the COVID period. You see, one of the biggest threatening things that is coming in is the evolving pathogens which are coming in. And COVID, like, the RNA viruses which are coming in, what they do is they mutate very fast. And in a very simple way, it's like it changes its looks the moment it enters, exits, and it can do it within minutes and seconds now. And that is a big problem for our immunity, because our immunity is devised in recognizing these pathogens and devising antibodies against them, And that is why during the COVID period, you heard that we didn't, elicit any kind of natural immunity against the virus, because these viruses change their, looks, the coat proteins very frequently through mutations. And that is why if you now put in AI into place, it would be, you can now envisage to race with these viruses. So these AI tools would be working 24/7 and tracking these mutations of these viruses and helping us in vaccine development, which was a big challenge for us this time. And we still do not know the vaccines that we developed worked or not, I'm sorry to say, because we didn't get the time to even test these vaccines. The second thing is drug development, the drugs that we use. I'll give you a simple example. I was in a Pfizer laboratory 2 years back in US, and there I saw there were more than 1,000 robotic AI tools trying to develop chemical molecules. So very simply said, these drug molecules are like lock and key. So these are keys which go and target our body's protein, or let's say the pathogens, like antibiotics target bacteria. There are drug molecules which will target the proteins in our body which cause diseases. And that is how, you clinically manage diseases. So these chemical molecules have to have the proper shape and size, conformation, very simple, to interact with these targets in order to be efficacious, in order to cure us. And this is a trial and error game. So if you leave it to humans, it takes long time, because humans, we go on doing trial and error. Here there were 1,000 robotics doing the same exercise, trying to synthesize these chemical molecules and trying to see whether it is fitting. You can well imagine these machines will do it much faster than humans can do it. And that is how these AI tools are now going to accelerate our drug development very fast, especially for evolving diseases and new diseases that are getting evolved. And last but not the least, I'll just read the precision medicine. You saw during the COVID period, it simply said, all of us are different with respect to the diseases we have, response to diseases we have, response to drugs we have. You saw during the COVID that the same virus infected many of us, and many of us were, had loaded virus in our lung, but we were asymptomatic. Nothing happened to us. And there were people who were infected for 3 or 4 days, and they died out of a cytokine storm. So that is the difference. Same pathogen or same disease may attack person A and B, and nothing will happen to person B, and the person A might succumb to it. Similarly, a drug, you might have seen that in your family, you have a particular painkiller, it works fine for your mother, but the same painkiller doesn't work for you. That is simply because you are genetically different. So all of us are genetically different. That means the drugs we have are having sometimes may not work for us. So there is no single drug for everyone. And that brings us to the era of precision medicine. That means we have to customize drugs for each and every individual person. And that's very difficult to do through human intervention. Now, with the advent of AI, you would be able to do it much faster, because you would be able to screen the variations between two human beings across genetic pools much faster with these AI tools, because they can handle a lot of data together and analyze them much faster than the human brain can. And that way, this precision medicine, which otherwise looks to be an impossible ploy for us today, looks to be very feasible in the very coming days, and it will become both cost effective as well as feasible. And that is why then you will be sure that the medicine that you are having or is being prescribed will work for you. And it's not just a trial and error drug therapy that is usually done. So I can go on, I think I'm crossing time limits, I can go on like that, but I'm sorry, there are other panelists who will add to, and if you have other questions. These are 3 main areas that we are actually looking where AI will help biotechnology: drug development, vaccine development, and precision medicine. Otherwise, you can imagine the lot of data do we handle during human trials and drug trials. That would also become faster, much easier, and more precise with the advent of AI tools. So AI is there to help the human brain and not compete with the human brain as a misconception. And as the last thing I must say, the conundrum of AI, whether it's going to finish human race, a lot of people are skeptic about it. See, for any technology, for that matter, it all depends on the intent of use. You can use it, if you use it malified, you can kill. If you use it beneficial, you can save life. Any technology, you just name it. So AI is no exception. So we have to be very sure that when we use this AI, there are enough regulatory measures in place to ensure that the tools are used for beneficial purposes more than for any harmful purposes, to not let it be a Frankenstein. Thank you.
Thank you. I request Professor Bhattacharya to highlight on the issue that how AI can help elderly people and the economically poor people.
Actually, what Professor Panda has highlighted, that drug development process, for the drug development process, it has to come through a rigorous exercise if it's done by the human being. So if the entire the steps and process is processed through AI system, then it will be most cost effective. And most of the things is that for the development purpose, when the molecule is discovered and it comes as a product, it is a huge ballgame. So 90% of the cost of the drug development goes for clinical trials. And if we use the AI for clinical issues, which molecule is more efficacious for the particular disease, it can be screened and used for the clinical trial. That will not only shorten the experimental protocols and experimental durations, and also the efficacy of the drug itself. So it can be an economical process also.
Thank you. Actually, even suppose elderly people who are in his home alone, then if we can design some system using the concept of AI, IoT, then I think it is possible, because suppose some old people is suffering a lot. Now at that time, maybe that there is some cameras, some sensors are there. So from that, if we design some architecture so that automatically the ambulance will come, automatically they will take the patient to the hospital, so that can be arranged. So even for your information, I can tell you that I am associated with IIIT Kolkata, and Indian Institute of Information Technology Kolkata and IIT Kharagpur and some other institutes. We are along with the government of India, we are trying to build up this system. So hopefully within few years it will come in the market also. So now may I request Mr. Panda to highlight on the issue that how is it the responsibility for the government or how startup can help or who are the other organizations who can help to build up these AI systems for healthcare and bioinformatics?
See, especially for an Indian society, and especially in Bengal, don't take me otherwise, when anyone would say that I would go for a startup and I want to, pursue my dream, there would be a discouragement from the family, because that's very uncertain track. So I have an innovative idea, be it AI or anything. I have gotten when we were starting the Kolkata Biotech Park, we had this experience. A lot of people had very good ideas, but they were afraid to come in. Number one, because they didn't have the money to gamble with, and their parents, the family was not supportive. This is where the government has to come in. Government support has to come in for any startup, be it AI or biotechnology, for any. The government has to come in and put in the initial money for the proofreading, the proof of principle stage of testing the technology. What is the benefit of the government? The benefit of the government is, out of 10 technologies, let's say 3 technologies click and these people become self-sustaining and become successful. These people are going to next employ a lot of people. In the Kolkata Biotech Park, we had 2 companies which are now employing more than 400, 500 people. And they are paying taxes more than what they had been given support for. The money that they have been given as support, initial support, they are yearly paying much more than that amount per year as taxes. So it is kind of a win-win situation for the government and everywhere. If it is not for angel funding or the VCs or the government coming in, young people would not be encouraged to come in, for any, be it AI technology, be it biotechnology. We have seen this is the scenario. And it is very pertinent in West Bengal.
And you have to think also for the rural people. This kind of approach can be taken care of by the urban people. So if you go into the rural area, this technology for the per capita income is very low. So how can they afford to take up these things, these facilities? This they have to think of.
Absolutely, sir. So if you could highlight how AI can help in Bio E3. E3.
I don't know what this is.
Bio E3. Bio E3 means economic empowerment and another E, what? I forget. So how it can enrich the empowerment?
Economy that previously I have answered, that if it is well acceptable that it can cost effectively utilize the drug development or any kind of product development, it will enhance your efficacy and economy. So you can use that Bio 3 the DBT program also, that employment, environment and economy. That is now, last year it has been proposed by the government of India. Okay. So there is other funding also that can be utilized for these things.
Yes, sir. In 2014, even the startup company, I think what I can remember that around 10 billion profit was there. But in the investment in 2024, it is $300 billion, and it is expected that in 2030 it will be
Is it
1,000.
globally or Indian perspective?
In India.
Okay. For startups?
For startups.
Actually, according to the last budget, we have, for the biotechnology purposes and biotechnology startups, there is 9,000 startups, last budget report. And it will go up to 10,000 in 2025. So there is a huge possibilities for funding and getting fundings from the government also itself.
So may I request Mr. Panda to, if you highlight on the issue that what socio-economic changes can be made if AI comes in the healthcare and bioinformatics?
So I highlighted on that. The first thing, the advantage would be affordability. So a lot of things, the drugs, see, most of the drugs are so expensive, especially for cancer therapy, are so expensive because the drug developing companies invest billions of dollars in developing those drugs. And that is because a lot of human intervention and uncertainty is involved and trial and error is involved. With the advent of AI, what would become is, because you have simulated models of drug development, this quest for new drug molecules will be more certain than it is right now. And so the human trials and everything would become more simplified and more definitive, which will bring down the cost of drugs and of course healthcare to a substantial extent. And that is what we are saying, that, and of course this will extend to everything, agriculture and everything, it will extend. So the constraints of human or capability, a lot of it would be taken care of, and the speed of technology development would increase, thereby decreasing the cost of a lot of technology and affordability. And that what exactly he said, that poor people who cannot afford certain kind of healthcare would be able to possibly get access to it. I'm speaking in terms of healthcare, but try and understand this is applicable to anything. I mean, any technology where AI would go, whatever, if AI technology is costly today is because of the constraints of developing the technology. With the advent of AI, there will be more speed in development, less cost involved in the development, and more precision. And of course, it will reflect in the form of more precise and cost-effective technology coming out. So obviously, the accessing population would increase. So even people who cannot afford it would probably be able to afford it.
So, if AI comes in the healthcare and bioinformatics, do you think, and what you have told that in the rural area, the problems you have highlighted, so what should be the plans for the government to proceed in this direction?
That should be a policy for the development. For anything you are developing from urban to rural area, that should be a policy for the government side, that they will develop such kind of infrastructure from the urban area to the rural area. And that policy consists of every steps and layouts of the how they reach to the rural area. Okay. No, it is a work of the policy makers. Na? I cannot spell out in a nutshell.
If I may add, I have been acting as an advisor for the government for a long period. I've seen, I mean, we do not usually have truce with the reality sometimes. We try to follow the West, you know. I was telling him this story when we first started the Kolkata Biotech Park. When I was facing the expert committee in New Delhi, I was asked, how are you going to build this model up in lines with the biotech park in Heidelberg, Germany? Or these are two successful biotech parks, by the way, the initial, or the Research Triangle biotech park. I really didn't have answer then. And when we came back and I built that biotech park and it successfully started running and we went back for the evaluation meeting, the same gentleman asked, which model did you follow? I said the Bangla model. See, and jokes aside, this is, when he's talking about policy, we have to be very practical about our niche needs where we are working. The niche needs of West Bengal may not be the needs exactly in Bihar or any other state. So when this kind of policy is developed, we have to look into what are the technological needs, and we should first invest on those kind of technologies rather than copying the West or any kind of developed countries. I feel that much. I don't know.
And actually, what is the need that first you have to spell out the highlights of your policy. That he said that for the development of the infrastructure, especially for which is needed here for the West Bengal, and then you have to spell out for the policy or incentives, whatever you are providing to the investor itself. Why they are coming if you are not providing any incentives for them? So these are all should be all clearly mentioned in these policies. Okay.
And actually a roadmap, a proper roadmap by how you will going to achieve it. And actually a policy is a part of that roadmap. Yeah.
So what do you think that how the educational institutes or research organizations and the industry, startups, all these government can come together to build up this AI-based healthcare system?
So basically, as you can understand, in academic institutions, we have, like we do biotechnology, right? So to do, and science is interdisciplinary, to bring in AI into biotechnology, we have to now increasingly collaborate with people who are, the real core people of AI. If I tomorrow say that I'm a biotechnologist, I am going to do AI, it is not a feasible thing to do. I mean, that's the wrong thing to do. So my expertise as a human being, again, with a human brain, is in biotechnology, not AI. When a certain technology comes in which can basically facilitate or augment the capability of my technology, I have to collaborate. So it is through constructive collaboration with computer science or AI experts that, the drug developing companies, and it is being done like that even, that you have to, you take this forward. So don't expect that every niche lab would become, have a core AI sector. But it is through collaborations it will start. Maybe tomorrow or day after there might be AI integrated labs you will find, but not really.
And that should be recognized by the CDSC also.
Right, right.
The drug authorities, CDSCO or DCGI should approve this process, machines, and till date, for the manufacturing of medicines, AI generated data and AI enabled machines are not used in the production systems also. That has to be approved by the DCGI, the regulatory. So this has to come first.
And this is actually an evolving process.
Yeah.
This interdisciplinary nature of science is an evolving process. See, there is nothing called pure biology now. You know?
Yes.
So you have to know maths, you have to know physics, you have to know chemistry to biology today. So you can't say, like, there are a lot of students, I mean, I don't know, they are here that I would leave out maths in my +2 because I want to study biology. You cannot do it any further because science is becoming so interdisciplinary, you will need maths for biology. And in fact, the biological system is one of the most intricate mathematics if you really study the biological system. So AI comes in, tomorrow some other technology will come in, and this kind of, interdisciplinary mergers will go on for the increasing of this thing. And this is an evolving process, I believe.
And this is what is that is incorporated in the new education policy or syllabus.
NEP, yeah,
NEP.
yeah.
So what kind of modification you or do you think NEP 2020 is totally, absolutely okay for AI in health?
That is very much difficult to comment on.
Don't ask me. I'm a big critic. Don't ask me. I think the NEP 2020 is an Alice in Wonderland document. I tell everywhere. You have to be in conformity with India. You just cannot copy the... See, I am against, I'm sorry to say this, semester system. I'm sorry to say this. But we had studied in a 2-year period where we assimilated knowledge in a long-drawn, far better process. Today, we hardly have 3 months of classes because of all these holidays I'm not mentioning. And we stuff the students with knowledge. They just vomit and forget. We see, if you ask a student first semester questions in the 4th semester, they can't answer. What is the use of such education? I'm sorry to say that, but so this NEP thing is going to, I'm sorry to say, but we are not doing what we are doing properly even in education. NEP is a bigger load that is going to come up. I do not know how people would cope with it, but realistically, there are certain good things, of course, certain good things, but if you blindly follow the NEP, we are copying the West, which I don't think would be right for us. I'm sorry to say this.
Yeah, there are many nice things in NEP 2020, but actually the infrastructure is the issue in India, what I feel. Okay, so any question from the floor? Yeah.
Good afternoon, everybody. I am from Sister Nivedita University. I'd like to draw the kind attention of Professor Panda. I have a very simple and basic question regarding drug development. Do you feel till today we have enough quality data to learn the machine? Biological data, real biological data. Number one.
Can you repeat the question again?
Do you feel till today we have enough quality biological data to learn the machine for drug development?
For India, you are saying?
Global.
So if you are asking about the West, they really have. They really have. If you naming companies like Pfizer and Merck, so what they do is, even if their in-house facilities do not allow them that kind of extensive knowledge base to apply for drug development, they would get people who are resources. You saw what happened for the vaccines. None of the vaccines were developed by the big shots. It were for the COVID vaccines. They were developed by very small companies. Even the Pfizer vaccine was not developed by Pfizer. For India, if you talk about our country, we are very poor in drug development. And that's because we have obsessed ourselves, because of resources again, because we do not have that kind of investment provisions. And second is that we are blindly following the generic market. And most of you know what the generic market is. That the moment one of the established drugs patent, ends, we blindly copy that drug and send it to the market. And India is doing fantastic in the generic market. If you go to the West, any store, it is filled with the generic drugs from India. Sun Pharma, I think East India is also doing. So nothing wrong, nothing wrong. And these generic drugs are very cheap, and the poor buy those drugs, and it's a big help for the poor, because the big companies sell it at a premium price, and mostly the poor cannot do it. So to answer your question, India has the potential to do that kind of research, but the resources are not enough to do that kind of big budget drug discovery for most companies. And that is probably they resort, and he will be a better person to answer this question, probably resort to the generic drug development, which is also helpful.
And thank you, sir. And my second question.
Can I, if you give me the liberty, can I divert this question to him? Because he belongs to a drug.
Questioning him also.
Actually, a single molecule for development into a drug needs 10 to 20 billion US dollar for a successful drug discovery. For our Indian market, very few companies can afford to venture for these kind of expenditure. Okay, so the companies like Zydus, Oakard, or Cadila, they can afford, and they have new molecules with 3 to 4 new molecules. Recently, naphthromycin, you have seen that new antibiotic has come up with resistant pneumonia. But the majority of the companies, 80% of our pharma companies are MSMEs. So they cannot afford to venture into a new drug discovery regime. Okay, so we are, our R&D is working on the generics, and we have 2 types of generics in Indian market, and one is generics, that paracetamol called paracetamol, and we have branded genomics. Branded generics means that it has a trade name, doctors prescribe this in its generic name. Okay. Our company's paracetamol is Paragesic. So it is Paragesic 650. It's not paracetamol 650. Okay. So it is the main thing that the company's profile, company's ability to invest for a new drug discovery, and the team works on these issues. Okay.
Okay, sir. I am not. My question is not from the Indian perspective, the global perspective, because we have engaged computer for drug development. I think way back 1960, almost 70 years we have spent. According to my knowledge, hardly we found captopril, and a few molecules are under clinical trial. A purely computer-aided drug development process, we have still to find out.
AI is now involved in first 5 to 6 years. We are hearing about the AI and data interpretation via AI.
Sir, but
it is nothing doing with the use of computers with application of AI in the drug development.
So I told you about the example I saw in Pfizer, and those people told us a drug discovery which used to take them 5 to 6 years is now taking them 6 months. You understand? There are more than 1,000 robotics which are doing the trial and error of docking, the chemical library molecules with the target molecules. Okay, you understand what I'm saying? So this previously used to be done by humans. So I walked into the lab, and probably I can do one docking experiment in 2 days. They are doing 1,000 docking experiments in 1 hour now, those robots.
Sir, regarding the docking, I am also a medicinal chemist.
Yeah.
I am from Jadavpur University. My university was. I have done my PhD there.
Okay.
Now, regarding my question is there. We have engaged computer in the form of docking, whatever QSAR, drug development process.
So sorry to interrupt you. Have you done, as part of your academic quest, have you done docking experiments? No.
Yes, yes.
So did you find it useful as a predictive model for your wet lab experiment?
Definitely not.
Okay.
100% not.
So this
because
AI stuff is exactly that. AI stuff is not going to give you any kind of wet lab validation. You understand?
Yes, yes.
AI is going to give you a predictive, more predictive route to follow so that you can discover a drug molecule more with more certainty than you were doing in a more trial and error regime. Am I making sense? Yeah.
But sir, the medicinal chemistry have engaged, what I am going to say, we have not sufficient amount of real biological data because it is very difficult to retrieve those data. There is an ethical point of view. In today's world, it is very difficult.
No, I agree with you, and that's exactly what I said. See, the question of precision medicine comes even today when I'm taking a drug. I am not certain it is going to work in my body because I know that there is a scope of the drug not working in me and working in him because we are genetically different. You understand?
Yes.
Say, like in the COVID, as I said, when the virus enters your lung, you don't know whether you want to be asymptomatic or whether you are going to succumb to that viral infection. So all of us are different, and I agree with you what you are saying.
Yes, yes.
The more data and India is so genetically diverse, and that is why we are the hotspot of these human trials, So the more data you collect, the better, more effective drug that you will create. And I agree with you, the drugs that we are having today are not ensuring enough to ensure that it will cure you. It may not at all work with you. Cancer drugs, I'm sorry to say, people, in US they now the insurance company won't give you money unless you provide genetic proof of the fact that this drug is meant for that patient. You understand? We don't do this here. We give all kinds of drugs, and maybe many of the drugs don't work. So in US they have started this process that for cancer, if there are customized drugs for genetic aberrations against cancer. So if you're giving a different drug for cancer, which is not tuned to the genetic defect that that particular patient has, the insurance company won't pay the hospital, which
Okay,
is
thank
not
you, sir.
which is not happening in India right now, which is not right because we are possibly paying more money for our treatment than the US people are paying. Sorry to say this, but
Because
that is
the
how it
problem is because of the AI hype, we are hiding our real problem. Because the real biological data is still not enough to develop a machine or to learn a machine.
So that for that you cannot blame AI. It's, as I said, AI is just a slave of human feed. The better you feed, it's like a computer program, and he's an expert in there. The more algorithms, more comprehensive algorithms you put in a particular program, the more strong that program becomes. It's like a weak antivirus software and a strong antivirus software.
Yes.
So you are right. The more broad spectrum biological data you put in, the better would be the drug discovery, recourse. I totally agree with you. But for that, don't blame AI.
No, sir, I'm not blaming. Because
And
people
today we are sitting here just discussing the potential of AI. We have not done it. See, 50% of people believe that AI is going to end the human race. We are at least sitting out here and talking about the positive aspect of AI. But let it be. We'll see how it goes. But we are just here discussing what are the potential of AI. We still do not know how much it will accomplish. And you being skeptic is a good thing. Skepticism brings about revisions and modifications.
Okay, thank you, sir.
And in many fields, you will find that many other field also researches are going on the synthetic data that is also generated by AI.
And we have experienced the combinatorial chemistry and high throughput. They are already discussed. A lot of robotic machines try to generate the screening. But till now, high throughput screening is not a way out till today also. For this reason, we are going in a path
where we are learning some misinformation, like whatever we are now receiving from social media. Our brain is learning some misinformation, not sufficient information. In the hype of machine learning, we are escaping our real problem, because in other field it is very much applicable.
See, one of the biggest constraint of getting human data is the bioethics involved in accessing human data. You understand? Number one, when I am studying this thing, human trial, the biggest problem is having a control group. Let's say I am studying a lung disease, right? How many people, healthy people, would volunteer to give me lung tissues for that analysis?
This is the real problem.
You understand? So that becomes a big problem. Accessing human data, and with the strong ethical rules and laws governing collecting human data, that is one of the big constraints. You don't want to go into jail becoming too ambitious, you understand? So that is definitely a constraint. And that is one of the factors that you are saying is because we are not getting enough biological data to, do the needful.
Okay. Thank you very much, sir, all of you.
Thank you. Any other question from anyone? Okay, thank you. I think we can conclude here.
Thank you. I now request the team members from the Bengal Chamber to please do the honor and present the mementos to the moderator and the panelists. To Dr. Imon Mukherjee, the moderator of the session from Indian Institute of Information Technology. To Professor Kaustav Panda, Head and Coordinator, Department of Biotechnology, GCGEB, University of Calcutta, and Dr. Barun Kanto Bhattacharya, Manager R&D, East India Pharmaceutical Works. I request the panelists and the moderator to please be in front for a photo session. Thank you. We will close the Health Tech Summit today, and thank you all for joining us today.